microphone, but it's only for the few people in Zoom, 5 at the moment. So I like to get into a discussion. So it's important that it's not I just talk to you, but we get interactive and you also ask questions, but sometimes remember me to repeat the question for the Zoomies or ask your question yourself. That's the reason we have this funny microphone. So, what is your background? How much do you know about electrophysiology? And that's also a nice thing to have a microphone. You can hand it over.
So I'm Ross. I'm an ENT surgeon from Scotland in Dundee. I have very little background in EMG, so here to hopefully learn a bit more.
Would you allowed to start from scratch?
I'm Anna. I'm also work in Scotland, but I had the pleasure to be in Jena and Gera, so I managed to see some of it as well in the hospital here.
I'm Andreas from Denmark. I don't have any experience with the laryngeal EMG yet, but I'm starting a cooperation with our neurophysiologists in December. So I'm here for the start of a new career. I'm from Denmark, south of Copenhagen.
Sorry, but for the quality of my voice, I have upper respiratory tract infection. Sorry. My name is Halina Grzelec. I'm a neurologist from Szczecin in Poland, experienced in electromyography with several years experience in laryngeal electromyography as well, especially in the neurological conditions, but also in traumatic lesions of the laryngeal nerves for otolaryngologists.
Hello, I'm Anna Dąbrowska. I'm from Szczecin, from Poland, but I'm Phoniatrist. I'm totally beginner in electrophysiology, but I think that it is a very good place to learn more.
Good morning, Nicholas from Brussels, Belgium. I have some experience in LEMG, but with a neurologist.
I'm Céline from Belgium. I work with Dr. Robert. I just saw some LEMG with him, never do it myself.
Good morning, Shashi from Coventry, UK. I've got some experience of EMG. We've got a good team with our neurophysiologists, but I'm hoping to learn more. And having looked at your videos, I'm quite excited about today's course. Yes, there is a person with whom he's a neurologist, neurophysiologist who's coming here. Thanks.
Good morning, I'm Pierre Cavena, I'm ENT from Switzerland. I'm just starting from scratch. We use it quite a lot for injections, but I have no background about EMG. And yes, for spasmodic dysphonia, this kind of indication. Yeah, but no background.
Good morning, I'm Evgenia Schäffner from Lübeck, Germany. I've got some experience during my education with laryngeal injections with EMG controlled, but only with supervision, and I'm about to start EMG injections with colleagues from the Department of Neurology in Lübeck, so I would say I'm on the beginner level.
Hi, I'm Timo from Austria, Innsbruck. I'm an ENT surgeon there. I had the chance to do some LEMGs there and one injection actually, but I'm totally on a beginner level. Because of Klaus Potocznik, yeah.
He's also coming today, or he was already here, but he will come later. Sun is too nice and he knows a little bit about it already. So he has direct access to it. That's a good chance to start.
Good morning. I'm Theon Taletti. I consult in neurology in Leeds, UK. I have background in electrophysiology, including EMG from neurology. My special interest is dystonia, and I'm doing vocal cord injection EMG guidance. I have used a little ultrasound also for assessment, and I'm very interested to see what is your
Ultrasound and EMG?
Coming from the dystonia, I already use for dystonia in general, limbs, neck, other part, but I transferred that to the larynx to recheck my anatomy.
Who's using ultrasound? As ENT, it's not so complicated, but who has done ultrasound of the larynx? Who's doing ultrasound? Perhaps all of us? Who's doing ultrasound of the larynx? What's funny that even ENT doing a lot of head and neck and looking for lymph nodes, very seldom look at it. It's on the screen. We see it, but we don't, open our eyes and look for the larynx. And it's nice. Sometimes it's easier than putting it needed.
I'm Simone Bernhard, pediatric ENT surgeon from Rotterdam, the Netherlands, and I have no experience at all with EMG.
Scoping and...
Yeah, I do. Yeah.
And now ultrasound.
No.
Because there are also 2 ultrasound machines, so there will be it's a little bit off topic, but tomorrow there should be time, or in the breaks there should be time for just putting the probe on top. It's less painful to do this. Ultrasound from each other. If I would have to volunteer, I would choose volunteer for the larynx. Ultrasound and not for the EMG.
Yeah, good morning, everyone. Oh, sorry. I'm Antje Pusnik, University Hospital of Leipzig, not so far from here. The phoniatric division, actually, and I have no experience at all. I'm very excited.
With EMG and ultrasound?
Yeah, with EMC, yeah, of course. EMG.
With larynx, you've seen.
Yeah, yes, of course.
My name is Maximilian Young. I'm from the University of Rostock, and I assisted my senior doctor in several examinations, EMG.
I'm Elias Jokic.
No. She makes it herself.
Elias Jokic. I'm from the LMU-Klinikum in Munich, Germany. I'm ENT and studying the specialization in phoniatrics. Yeah, right now I have no background in EMG. I'm looking forward to get something new.
I'm Shiying Hey ENT surgeon and laryngology in London, and I have the pleasure to be invited to this course to be the faculty together with my neurophysiology colleague Doreen up there. I always say to Doreen that I'm the hand, she's the brain when we do the diagnostic EMG. So I'm very happy to be here with my brain, and so looking forward to the lovely 2 days, and then we can hopefully enjoy and share a bit of experience in laryngeal EMG.
So my name is Guan-Min Ho, and I'm an ENT otolaryngologist, and also with subspecialty in laryngology. And I'm also the inventor of the voice implant, so which you will try out tomorrow during the hands-on part, and I hope you will like it. Yeah, thank you.
It's more like, but also therapeutics. That's the idea that it's nice to examinations. It's nice to know something, to learn something about the parent patient or the larynx. At the end, as a doctor, it's also nice to help our patients, and that could be bolus injections, but it could be also surgery, implants, and that's the idea. We try to get from putting needles in, also to putting needles in for overload, putting needles for diagnostic from our innovation.
Guten Morgen. I am Maciej Zieliński from Poland. I work as ENT surgeon in Zabrze, and I do specialization in phoniatrics in Krakow. And I did some research about EMG of facial nerve. So my introduction was about EMG, and I had a larynx introduction about larynx EMG with James Thomas. But I haven't performed yet. I did research, but I didn't do it alone. I had like electrophysiologist. I just only theoretical introduction. Okay.
Good morning. My name is Samira Zabana. I'm from Berlin, from the Charité, and they're in the phoniatric department, and we do it quite often, or our consultants do, and I got to do it twice, and now I want to learn more about the theory and also the practice. Thank you.
Good morning. Oh, sorry. My name is Zuzana Blatko. I'm from Prague. I'm ENT doctor, and we have not much experience with laryngeal EMG, but we would like to perform it, and I'm from pediatric ENT department.
The department wants to go forward in the direction and present you the knowledge?
Yes, we both came for this purpose because we do laryngology, but we try to do EMG, but not with great success together with our neurologists. But laryngeal EMG is sort of something different than from facial nerve or the things we did so far. So we tried to get some more knowledge. Yes.
As an ENT, we have access to both cases, larynx and face. Case muscles are pretty big compared to larynx. They can tolerate it much easier. Solutions are similar, so you have a chance to start with the face, or do both. But face you can more academic, more step by step, with call weak, needs the needle in for a minute. Larynx, you're always a little bit stressed and have to make fast decisions and have less repetitions. James.
I'm James Thomas from Portland, Oregon in the USA. I'm a laryngologist. I'm a proud owner of a 10-channel EMG, so I have done some EMGs. Mostly I use it clinically in the office for localization, and I use it surgically when doing nerve reinnervation. And I will be talking a lot about visualization of the larynx, and I've spent some time correlating what we see in terms of movement with what EMG might represent.
Okay. Good morning. I'm Michal Jurovčík. I work in the same department as Zuzana. I have experience with pediatric otolaryngology and with endoscopic surgery and with EMG and face and cochlear implants and regarding issues.
Microphone having some please. Has everyone said something? Great. So there's one microphone with you, so you're allowed to speak just loud if you want. I have to catch a microphone, but I think that's okay. So please interrupt me and please get interactive, and you just ask for the microphone if you want one. Okay, what for? So some of you want to start with a EMG and you managed to get the funding to get here and get time for it, and some of you have already a machine, so I think that's really a good start. But there's also some evidence that EMG is something useful. Should work with this machine also. Then I can move a little bit. Because there's a nice meta-analysis. It's not very precise, isn't it? So the pictures can be improved that way. There's a nice meta-analysis looking for, oops, Here are the nice numbers. Over 500 patients included in it. Is it coming? Here. So a lot of studies were summed up from more than 30 years, and over 500 patients were included in this meta-analysis, and they were checked how valuable is it to put needles into the larynx to check if there's something prognostic valuable. Can we do get some diagnostics or not? I think it's fine. I can do it with this now. I think it's a problem with the two screens that it's if it's here. No. Wants the mouse. Okay. Yeah. Here's a 500. And now the interesting stuff are these two numbers. And for the poor prognosis, the EMG, if you do it in a more or less structured way, can tell you in a 90% certainty that there's a poor prognosis of recovery. The other way around, it's only 55%. So this means if you put an EMG needle in, get some signals, it looks not too bad, and you decide on some categories that is the EMG that there could be a good recovery, you don't know. For this patient, you can tell them, there are good chances, but we don't know. So doing an EMG is 50%, just guessing is 50%. Throwing a coin is just 50%. So for these cases, the EMG was more or less useless, but anyway, you can tell them there's still hope, go on, do some, see and wait. But for the other group, for them, it's interesting. For the ones where you get bad signals in the EMG that tell you there's a pure chance of recovery. And what kind of signals are these? The strongest one is pathologic spontaneous activity. If you put a needle in and get activity, what is proving that some of the muscles are denervated. I will show you later what this means. This is the strongest hint. And if you get these, for sure, you know some axons has been killed by various surgeon, a tumor, you don't know. And there's only very little chance of recovery. And if there's recovery, the nerve will make some mistakes. It's peripheral nerve, so they have chance to recover, to start growing. But if they start growing, they normally, they don't find the same muscles as before, so the recovery will be incomplete. So this is interesting that you know about the bad outcome patients earlier, and that's perhaps good because we can speed up this process. We could do more innovative stuff. We can tell this patient there will be a long way for you. Go faster to surgery, go faster to injections. So it's I think it's good to have it that way around and not the other way around. This was only diagnostics. Then there was another group, another very nice study from the Moonin and Rosen group, Pittsburgh and the US. And they were doing it in a prospective study where they were taking the EMG out of their normal settings and then looking, is there really an impact on it? Does the EMG make a difference? So very artificial, very unique. I think we should do this for much more techniques. Would be interesting to do, talk to a patient, make a patient's history, make a conclusion, and then scope him and see how much the scoping changed in your opinion, or is it only confirming what you already have heard, what you already have got from the letters you have read about him? Is the scoping so valuable as you think, or auscultation or ultrasound? But normally we all put everything together, and with our human intelligence, we make a diagnosis. Here, they propose separated, very nice. So first, patient and laryngologist performs a standard clinical examination. Then a pre-EMG diagnostic was written down and fixed. And then a blinded EMG expert put a needle in and did his examination only based on what he has done in this room, without talking too much to the patients about patient's history, only about I put a needle in your larynx now, please do some maneuvers, some sniffs, some phonation. And then in step 5, these 2 reports were compared. Does anyone know such a study from any other technique? Ultrasound, CTs. I think it's really pretty cool, and it's valuable if it's really worth the hassle we do. So do we need the MRI? Does the MRI really change our clinical pathways, or is it only? It does, of course, these studies are around, but especially for such a nice small technique, I think it was very nice from this group to do it. Very important study, and we should think about doing this also the more future. And so they were doing this in 50 patients, and 13 of these patients are very detailed presented in this list where they were saying what has changed and what was a reason for it. So very open paper with a lot of insights. And to make the story not too long, in 10% of the cases, as in 5 from 50, the diagnosis changed by the EMG, and in 18, so over 30% of the patients, at least time course changed. Not the diagnosis, but they were speeding it up because they were saying, okay, they are pure prognosis, or the other way around, they were saying it has time, there are signs for recovery, please, let's wait a little bit longer. I think that's a reason to do it. So if EMG as an extra thing does such an impact on the timeline and sometimes even on the diagnosis, we should consider if it's worth the hassle. Unfortunately, it's a hassle. It's not so easy to do it. It's not just read the paper, get your machine and start it, but that's the reason why we are here. So anatomic stuff, we will do some preparations tomorrow with it, so we can really dissect larynges, how to put needles in. And this afternoon, we will have talks from Berit and perhaps from Klaus and from Gerhard Förster, who will show us in which angle you get into which muscle. We will not go into too much details this morning. This is just one more thing with definitions. There is the English language, like often, has nice vocabularies, and you can choose from a bigger variety of vocabularies than in most other languages because of having sucked in so many different things. Paresis and paralysis are 2 nice terms, but often made in a wrong way, or not very precise one. But I would recommend to differentiate here a little bit better, because paralysis officially is a completely loss of any movement visible. If you asked the neurologist, they say you don't need an EMG to be sure that there's no movement. Even if the muscle is a little bit innervated and you can only find it by EMG, it can still be a paralysis if the muscle is floppy and if there's no movement in it. This is a little bit gray, this area. If you say electrophysiological paralysis or if it's a clinical paralysis. But to be on the safe side, I would just be more precise and say after EMG, it's still completely denervated or denervated paralysis. But I wouldn't use the term paralysis in the future for the cases where there's still some movement. And I wouldn't use it for sure for phases where there's still some movement. And many people do it, even in good publications. A lot of people talk about facial paralysis because it sounds so much better than palsy. Palsy is a little bit open and floppy, and so the people try to avoid it and try to use a more clinical, but they do just the opposite. They get more wrong by using a term what is for sure for complete complete loss of tone, complete loss of function. Don't have to be completely denervated. So paralysis, floppy ones, muscle, as little activity as possible. Paresis, everything where a little bit movement is left. So, and if you don't know, then I would recommend you to use palsy, because it's open, because it's not very precise. but often we don't know. So why shouldn't we use this term, what is a little bit unprecise, as long as we haven't scoped the patient very good, as long as we haven't put needles in. If you don't know, then say vocal cord palsy or facial palsy, and don't talk about paresis or paralysis if you haven't examined your patient a little bit.
Palsy is an English word. Is there a more clinical word for palsy that's not either paresis or paralysis?
You have the native speakers.
We tend to, I entirely echo what Fabian say, because for us, we don't tend to use paralysis or paresis unless it's a neurologically confirmed with EMG evidence that there's a neurological denervation. So what I normally say to our trainee as well in our unit, we describe what you can see endoscopically, and endoscopically what you can only see is a not moving vocal cord, either reduced movement or not moving, which is why we tend to use immobile vocal cord. That's what we say. And unless you put an EMG in and the nerve is not working, then you call that paralysis or paresis. We have also called paresis, which is reduced innervation, but completely no movement. Doreen can tell you what it looks like on an EMG that we'll call paralysis. But endoscopically, all we can conclude is an immobile vocal cord. That's what we say. Is it what you do as well? Yeah, that's what we do. I stopped using it for a long, long time. And because what I can only report what I see endoscopically. And in terms of, obviously, we have James here, which is great. I think when you look at a vocal cord that's not moving, you can hear it, you can have visual perception, you can have endoscopic assessment, but you don't have the neurological status unless you have an EMG to diagnose that. Until you can prove that, then I wouldn't necessarily say so. But I'm sure Doreen will have better answer if you think about neurological perspective.
Got a microphone, apparently. Yeah, I'll have the special one. It really depends, on the situation. If you know the patient just had surgery in the right place and they wake up with an immobilized vocal cord, then you know it's a nerve lesion, and you can use one of those. For me, paralysis, paresis, like Fabian said, it's just a degree. Paralysis is complete, and paresis is just it doesn't need to be complete. It's just some weakness. But if you're not sure, absolutely, then you want to use something that just describes the state until you actually identified what the cause is. And what you use with that, obviously, we're talking a lot about EMG, but we're also talking about visualization. So, which method you use to determine what the underlying pathology is your way. If you have ultrasound and demonstrate that the nerve is separated, it's enough to also tell you, okay, this is a neurological lesion, etc. And equally from the history, you often get a lot of, already which way you're going. But if you're not sure, I think immobility is probably the best way to describe.
I think I don't want to say that there's a right and wrong, and language has no right and wrong, and science has no right and wrong, and society has no right and wrong, but we just should be a little bit careful. And it's funny that people who try to be especially precise by using the cool word paralysis often do it just in the other direction. And in the paper, you should, if you really talk about denervated larynxes, then you have to use not only paralysis, but say electrophysiological confirmed denervation. And it's not possible to make it much shorter. And even then you have to go into more details. How have you examined it? And so at the end, I just want to get your awareness about it. But yeah, the native speakers are perhaps a better people to ask what is a good word for it. And you see it's a consensus paper who's just doing the opposite of what I recommend. They recommend palsy not recommended by Rosen and Dickers. So who am I to say Rosen is wrong? But Dickers are good.
I'm happy to say either one of them are wrong. Yeah, I think endoscopically they're useful terms, and paralysis is improperly used. But there is a state of paralysis when you've cut the nerve and you cut it. There's complete immobility, but it quite quickly starts to regenerate. So yes, electrophysiology allows you to define more, but so does endoscopy, because you can say paralysis Paresis is quite common, that is limited motion, but then there is synkinesis, some sort of tension without motion endoscopically, and there's dyskinesis where you have a motion, but it's in the wrong direction. And then you can get more precise because you should in fact say there's dyskinesis of the lateral cricoarytenoid muscle during the activity of expiration on the left side. So it's valuable to be precise with our terminology, and it's valuable to take our terminology and be precise with muscles, and when we can with electrophysiology.
For the larynx, but also for the face, it's really funny how often things are changing, but that's good. I think that's progress, that we that new things come up and that people want to make sure I have something new, so I use new terms, even if they are perhaps old and differently used. So, actually, I don't want to talk too much, but let's go back a little bit to the larynx. But you are free to comment on it. This talk is about axons and muscles, motor axons and muscles in general. So it fits for the face, it fits for the larynx, but of course it also fits for the most of the rest of the body. The difference is here often we have very short distance for fast regeneration. Here it's a little bit longer, but we are also in a very lucky position. After 3 months, the nerve can already reach the muscles. And here it becomes half a year, and here it becomes sometimes more than 2 years. And so muscle atrophy is often too fast, and the muscles are more or less on a very pure state when renervation kicks in contrast to the face or the larynx, where even if you have cutted the nerve, there's little risks that no nerves find their way back. This is really in the larynx a very nice situation that there are muscles around who can, there are nerves around and muscles around who are innervated, and they get supply from them over the midline by renervation by the laryngeal nerve. So it's after a few weeks or months, you often get some renervation. So any kind of damage. And then there's a shock status of the soma, and it thinks about, do I have to die or can I survive? And often it survives, that's very nice, but only the distal part gets lost. And I compare this often with a tree where you cut a branch. So there will be no regeneration looking the same than before. So if you cut something from a plant, if the plant is more or less healthy, there will be new sprouts. But these sprouts don't come in the same line. But where does the sprouts, if you cut branch of a tree, there are new branches coming from the side, and not one, but normally 2 or 3. That's a botanical trick. If you want to have one nice tree, but reach your apples, you cut it from time to time, so it starts to branch and gets shorter and denser, and you can reach the apples on your tree, or you can it gets more dense, so the neighbors don't see you. So you cut trees by inducing branching. And the same can happen here. So there's some damage, and prednisolone can push the nerve a little bit more into regeneration to keep it alive. So that's the reason why for facial palsy, there are good studies. They give prednisolone early, so that's more of them survive. And then this regrow starts, but very slowly. How fast is it growing? This process where the nerve starts to regenerate. Yeah, that's it. It can be up to 3 millimeters, but in clinical life, it's not going straight forward. So if you count how fast the axon is growing, it can be up to 3 millimeters, but the front, in total, the average is around 1 millimeter. So here it can be already after 2 or 3 months, you have a chance, depends where the lesion is. But the other thing what often kicks in earlier is that muscle from the other side are so close by that they get some cross innervation over the midline. So reconnect and everything is good. Except if it's too long, then there could be some atrophy of this muscle, but don't be afraid too much about atrophy. Who has known something about atrophy of muscles? How fast are the facial muscles getting useless after skull base surgery? How fast do you have to go for reinnervation surgery in the face? What is your plastic surgeon telling the patients?
I'm not sure. You know, I'm not sure what they sort of.
There are plastic surgeons talking about 6 months or a year. And with a year, I think I can live. With 6 months, I think it's a little bit trying to make money by pushing the patients fast to expensive, big surgeries, because the muscles are getting weak from day to day, but they have good chance of recovery if they get renovated. It's okay to tell the patients after 3 months, after 3 months, there could be that there's without any renovation, the muscle just gets back because the nerve is only blocked. It's only neuropraxy and no external damage. So in this case, I wouldn't talk about surgery at all to not frighten the patient. But after 4 months to 6 months, it's okay to mention that there are surgical possibilities. But I wouldn't push them to decide after 6 months. I think you can wait for a year and you can do EMG. And with EMG, even first signs of renovation you can see. And if you see renovation in the larynx or in the face, you can say, okay, it's already getting better. Let's wait a little bit longer. And if it then gets a stable state and the patient is very unhappy with it, then there are very nice surgical techniques to get a second chance, to get more accents in, to get movements in. But don't push too hard, worried about the larynx. In that case, if you're so worried about the condition of the muscle, then try to keep them alive by what can keep muscles alive? Electrostimulation. Yeah, thank you. So super dangerous, causes synkinesis, but no, there's no evidence for it. So a lot of people are afraid of electrostimulation causing synkinesis but I haven't found a paper proving that it's really doing any harm in that direction. And if it would cause synkinesis, if I have a floppy face, a floppy larynx, synkinesis are good because I don't want denervated muscles. So unfortunately, electrostimulation or the long impulses, Exponentialstrom, or they don't have an effect on it. Sorry.
I mean, the muscle atrophies very quickly.
Super fast, yeah.
But the question is, are the muscle fibers still aligned? And one of the ways electrically we sort of look at that is the spontaneous activity that they throw up when they're denervated. And actually, you can see this spontaneous activity for a lot longer than you might expect. Yeah. So meaning that there's still muscle fibers, producing electrically, spontaneous electrical activity, meaning that they should be still, they might be atrophied, but they're still, functional. They're not actually dead. So that's kind of I think the difference here. So when you look sometimes at limb muscles, it's really surprising if somebody had like some sort of traumatic injury with no reinnervation. But even sometimes after 2 years, you still see spontaneous activity if there hasn't been any reinnervation to that muscle. So yeah, I think it's difficult, and in the facial muscles, I have also seen it like after quite a long time when I wouldn't expect any spontaneous activity anymore actually to be there, to still see it. So, and I think there's a lot of factors that age and a lot of other things that sort of maybe play a role, whether the muscle fibers will actually degenerate and then not be available to be reinnervated if there is a reinnervation process. So I don't think we understand all of that.
Yeah. No, we understand very little from it, but you're right. Again, the term atrophy makes it so open that you can push patients. Oh, there's atrophy starting immediately, what's completely right, and it's going on, but it's going on for years perhaps, and it can be reversed by electrostimulation, but much better by renovation. And so we are not in a super hurry to push this patient for fast renovation surgeries. And because it's not atrophy going to nothing, but atrophy going to smaller muscles and less fatigue-resistant muscles, but you can start training them and get them into a better condition later on. Yeah, and as you mentioned, a lot of clinicians don't know about it, but even if you check the literature, we don't know too much what happens to this muscle on long terms. But electrostimulation is a nice toy to play with it, to start to get this muscle artificially a little bit better, because if muscles contract, they don't atrophy too fast. And there are studies with electron microscopy of completely denervated muscles over years. By electrostimulation, they get better, they get bigger volumes, they get better histology, and if you stop it, they fall down again, because it doesn't change the renovation status if you stimulate these big muscles, but you can increase them, and because they are moving, and they get into atrophy again if you stop doing it. But it never goes wrong. So this picture is a little bit too optimistic, or this picture is a little bit too optimistic, because as mentioned, normally it always branches, it always gets sidetracks, and it tries to get to other regions. So, for example, completely different muscles, or double or triple innervations, or even 10 fibers. So there are always some things being different after renovation than in the first state. And there are also very nice pictures from 1944 showing that here, that's how it should look like, and that's how it looks afterwards. So some of these muscle fibers are atrophy, they have smaller caliber, and the nerves have reached them and have reached different areas instead of only one area. And that explains why the signals look like this. If you now put needles in, you get nice polyphasic activity, because different lengths of nerve fibers reach the same motor unit, but the motor unit is now perhaps bigger or more spread, or a little bit more different to before. So the signal is not nice, but disturbed. Last slide. This is still valid since nearly 100 years. No, it's also from the 20s, huh? This classification. So healthy nerve is a little bit damaged, so you just put some pressure on the nerve, but all axons survive. But less signals goes through. Normally a little bit goes through, perhaps 1%.
So, I mean, that's one of the surgical referrals that come to neurophysiology often sort of talk about neuropraxia, axonotmesis, and neurotmesis. And I think, a lot of people describe it in a very sort of casual way. I don't think they have a full understanding how we as electrophysiologists see these sort of terms. So I often don't use them, because I think there's a sort of, I think maybe starting with axonotmesis is probably easier. So axonotmesis means that obviously axons are damaged, means that the distal end of the nerve dies. And you know, when it's used in the term, what you mean is that the sort of sheath, i.e. the sort of neurosheath, is intact. So the nerve is structurally, if you sort of look under the microscope, is still intact. And the difference between axonotmesis and neurotmesis is that that is not the case. So actually, electrophysiologists can never distinguish between the two. We need some form of visualization, either at the time of surgery that we've cut through, or ultrasound or some other imaging form to distinguish between axonotmesis and neurotmesis. And usually,
a super interesting point that because for us as surgeon, it would be interesting to differentiate between this. But if you only check the fibers and see if impulses get through, they don't get through here and they don't get through here.
That's right. So, and usually people use axonotmesis when all the axons are gone, which is perhaps also not, from a neurophysiological point of view, not so helpful. Yeah. So when you talk about neuropraxia, I think in common language, most people use that term, as you just said, it's a little bit damaged, but not fully maybe. But actually neuropraxia, what it means is that you have a demyelinating lesion, meaning that there's local slowing or conduction block of the signals because only the myelin sheath is essentially damaged. And electrically, what you see, either if you can, do some stimulation above the lesion and then across the lesion, you'll see that the signal is slow, and you usually get conduction block, meaning you stimulate at a certain amount and not all the signal rise on the other end. Whereas if you go below the lesion, so let's say you have an ulnar nerve lesion, it's usually easiest to understand. So if you have an ulnar nerve lesion with neuropraxia, would mean I stimulate below the lesion, I get a good response from the muscle, and then when I go above the lesion, only half of the signal will rise because some of the axons are not conducting because there's conduction block. So the axons are intact, but they cannot conduct the signal along that side. And of course, that has a very good prognosis, because if you take away, if it was pressure, for instance, or maybe a stretch or something of that sort, that myelin sheath can recover very quickly within days, and you can recover from that conduction block without any long-term damage, because you haven't damaged any axons, no regrowth is required, etc. So that is true neuropraxia. In the real world, though, like I say, the surgeons often use it as a, well, there's a little bit of damage, but there's some recovery. And maybe that recovery can be full, but if you do electrically, if you look at electrically, and there has actually been axonal damage of some of the axons, so not full axonomesis, but partial, you will see electrical changes because there's been regrowth either across the lesion or that other nerve fibers that are connected are actually sprouting out. So from an electrophysiological point of view, I very rarely use these forms unless somebody specifically is asking, and I then try and explain it. Because, as I said, I cannot distinguish between neuromesis and axonomesis without imaging. I can say it's a completely denervating lesion, which means that is a possibility that actually you cut through the nerve. And on the neuropraxia side, more what I would use is, this is there's no axonal loss, there's no denervation, and in the laryngeal sort of EMG, that's very hard. You can't really do the stimulations. We only have the EMG signal to tell us, so that would be a lack of denervation changes in the muscle that would tell us, okay, it's likely to be neuropraxia. But most of the time we don't see the patients with neuropraxia. Yeah. Because by the time they come 2-3 weeks later, axonal loss, they would have either recovered by then, in which case we wouldn't do either an EMG or there is some axonal loss, which we
as a surgeon, you can see them because you perhaps do the damage yourself. Then you hope that it's neuropraxia, and if it recovers in a few days, then you can say, luckily it was this. But even in that cases, there's a chance that by scalpel you make a small incision, some damage of the whole nerve, some pressure, but only the myelin sheaths, only a nerve block, but 3 axons are cutted by your scalpel.
Or it might be pressure that some of the pressure has, only caused the myelin sheath damage, and that was recovered, but some of the axon, maybe it was too much, and there is actually axonal loss. So it can be a mixed lesion. These are very rarely sort of completely one or the other, unless you sort of cut through, in which case it's that. But it's quite, if it is a sort of closed lesion, i.e. not something where the nerve's actually sort of severed as such, then it's quite possible it's a mixed lesion, that you've got some axonal lesions, i.e. some axonomesis, but partial, and others that are where there's just block and that's recovering.
And then there could be a nice recovery or the return of movement in the next weeks, because most of the axons start firing again, and the 3 axons who have been cutted start to regenerate, and then patient gets better and better and is happy about it, and then perhaps some synkinesis kick in after 3 months. And some patients realize, other patients don't realize. In the larynx, so there could be that there's something getting worse after a few months. In the face, sometimes I see that if the patient is blinking, some fibers here at the neck or at the chin are moving the wrong way. And then I'm sometimes don't tell the patients if they see them, because I told one patient who was completely happy coming for a follow-up after 6 months, and was saying, oh, everything is fine, my facial palsy completely recovered. I was saying, for my list, I will make a cross for incomplete recovery because you have some dimples down here. And he was going to the mirror, was checking it. He was like, can I do anything against it? And he was like, well, I can put Botox in. It shouldn't be a big problem, but it's, yeah, I have an open bottle here. And now he's coming every 3 months for something he hadn't realized before. So I was really saying, don't tell them. If they don't care about it, if they haven't realized, if they need a mirror to see it, but now he thinks, oh, it's important. I have to come every 3 months. I'm saying, no, it's not important. It's only super minor, but for sure, every time he blinks, here's a small dimple. What else should it be? An axon misguided, renovated. Very nice to see in the face. And now that he knows, he also feels it. So he hasn't felt it before, but now it's annoying me, doctor. But it hasn't annoyed you for half a year, but before I told you. But yeah, so be careful. Yeah, I've worked in a tinnitus ambulance, and so don't trigger things you don't want to trigger. But of course, it's a nice example that there was some damage, very minor, and if there's damage, there's always some mistake by renovation. 10,000 nerve fibers, 23 muscles, the chance of that everything gets where it belongs, yeah, it's super small. It's the same with the larynx. It's too complicated, but often the patient just outbalance it. So they learn to work with it. But only the cases where they don't learn it, they come to us and ask for help. Any questions so far? So this classification, as the other classification, yeah, is more or less be careful with it. I also try to avoid it. Say there's no sign for clear denervation, or there's a sure sign for ongoing renovation if I have several EMGs, but I try to not to talk in these terms. Yeah. Questions? Need for a bio break? Not yet. A little bit technical stuff. So we have EMG machines here in the room, and we will do some hands-on in the afternoon, but of course we are fast. We can also start a little bit early because this part was more or less optional, but I think most of you are here. So we shouldn't slow it down too much. It would be nice to be ready for dinner in time and not like always a little bit too late. So the first line is an EMG line. That's something some of you have perhaps already seen. The second and third is a little bit unusual. Who has good eyes? Mic could be a short form for microphone. So this could be sound. It looks like sound. So what is he saying? So, and so you don't know, but at least if you know which commands you have given the patients, you can reconstruct or can you remember what's in the signals. And here, what could this mean? THM, thermistor. Does anyone know what the thermistor is? This thing. Oops, hand it around. So you put these into someone's nose and the other thing close to the, you can pass it around. And it's, if you inspire, it gets a little bit cold. And if you expire, it gets a little bit warm. And so it's checking if you are breathing. So it's one possibility in the sleeping labs to check your breathing activity. Alternative to it would be something like this. Who has worked in a sleep lab? So this is something where if you put it around your chest and you breathe in, you see it on the signals. But if you lie on the side or if you only breathe with your stomach, there's no signal in it. So both things are, yeah, can have faults, but we can check them. And our idea, starting to try to get some scientific data out of it a few years ago, was we don't need just an EMG to put it somewhere, but we need a setting where we can go back into the tracks, talk about it, discuss it, and make decisions. And unfortunately, the companies still now can't record Also from a webcam, that would be very nice to put a webcam and the screen and get everything recorded. We keep on asking them, and they always promise us, oh, this seems to be easy. We could include it perhaps in the next version, but not yet. So that we can do an EMG from Doreen, and at the same time a webcam could record my instructions, her response, perhaps even her breathing activity to be seen, and then it would be pretty easy to go back later into the tracks and check, here's a EMG of the TA, because I was holding it in that direction and was asking for an R, and if I ask for a phonation, then there's activity. But yeah, having this slack, we were thinking about, let's include a microphone and a chest belt so we can get everything on the EMG machine without pictures.
I have tried it with a polysomnography device, and then you have the camera, the EMG, the belt, the sound.
That makes it even more frustrating because they have these machines, they're already there. And yeah, but the normal EMG machines for needles, they just haven't managed to put this software piece into the normal settings. And that was the reason why we were saying we need a second and third line, and most EMG machines have more than one line. So it's if you have a machine with 3 channels, then you can think about use the second channel for a microphone and the third channel for a chest belt. It's not super important for the normal clinical routine. To be honest, I'm often too lazy to put everything on and just write down what I found. But if you want to record data, to quantify it later, to do studies with it, what makes decisions about bigger surgeries, I would recommend to get a little bit better documentation by such a setting, as you have seen here or as you have seen here. So shall we start to put the first needle in someone's arm to get a little bit more you out of your comfort zone? Yes, please. Who's volunteering? So Doreen can do it very well. She can interpret the stuff. I hold the microphone. Sorry, I have no arms. Yeah. So there is a chance to get a signal from this machine directly on the screen. But Martin, who has set up it, is not yet here.
Browns.
But do you know how to connect it? Otherwise, it's not so super important. We can also see it and mit dem Silber nach unten. Genau. Ist es noch feucht? Let's start very slow. So you need the first thing is a ground. So you can put just a sticker on her. But yeah, trying to avoid plastic, I put this thing, and it should be a little bit wet, and it's still a little bit wet on this metallic side. You use the stickers normally, yeah?
Yeah, we use it. But they won't let you in the hospital too, sort of. Yeah, it doesn't. In the hospital, you have to have something that is either completely cleanable or
and you have to do single use normally. Yeah.
It doesn't actually matter where you put the ground electrode. If you don't have too much electrical noise, put it anywhere. You put it on the foot if you want to. So the ground electrode is not really relevant, the position exactly.
So you need to, exactly, somewhere ground, and the ground is normally green, and the green cable. Nice thing is that it's often the stickers are green, the cables are green, and the plug where you put it in is green. So that's helpful. Do we want a full session? No.
Do we want?
No, not yet.
Maybe not.
Because you're still in the 3-channel mode, but it's fine. Yeah.
Yeah, I can come out.
If you want, you can come closer. If you don't manage to get it on the screen, and it also helps you to stay awake. So if you can come here and around. To look on the screen, but also to see the machine. So there are also laptop machines who are much smaller, but yeah.
So perhaps also just a word on the needles, no? You have a slide on that, or is not?
on this slide, you already see it, that there's actually 2 needles in it. So this is what goes to the amplifier. It's not the signal of 1 needle, but a 2-channel needle. So concentric needle is a, you can open some of the needles in the box.
Yeah.
And
You know, have a look at this one. Isn't it?
Just throw them around.
So for diagnostic purposes, most people use concentric needle, which means you've got your cathode and anode in the same needle, because you've got the needle tip. You know, there's a very small area where the cathode is, and then the sheath around is the anode. When you do Botox injections, you're using something called a monopolar needle. It's just one pole from the needle. So then you need a second reference electrode. So then you need 2 electrodes, because one plugs in on one on the cathode. That will be your Botox, and then you need a reference electrode. So you need another bit. But for concentric needle, for the diagnostic purpose, you only just need 1 needle. And I think in the talks or in the chapters that you send, it also talks about a single fiber EMG needle, which is you know, I've not even seen one. I think it's basically when they also discovered and worked on the single fiber. These days, most people do single fiber EMG with concentric needles as well. All right. The one issue is that you can't actually tell how much interference you have until the needle is in the muscle, which is a bit of a problem. So if you have a lot of electrical interference, you won't notice until you've actually inserted the needle in the muscle.
But it should already get much better if you touch the patient.
Yeah.
If you don't wear gloves.
So, but you know, you're not seeing. One thing that you might want to just double check that you actually have a live needle. I don't know. I've had recently a lot of issues that the needle was actually dead, and then once you're in the patient, then you realize, because you haven't put on the sound beforehand. And of course, you've got sound and you've got some waveforms. We've switched off the sound for the moment, otherwise we'll just hear interference.
Give us the sound for a second, because it's really loud. That's the reason why it's
loud.
Oh, it's not so bad. Yeah. So now you see the waveforms up there.
Yeah, and you can hear that, you know, every time we do this, there's some nice sound there. Okay.
But it's good to hear something. So before putting a needle somewhere in, be sure the machine is running and you get some sound, and it has also an effect if you shake it. It's really a pity if you have something made wrong and the needle's in, and then realize, why is no good signal? So there's often something wrong.
Yeah.
Like the ground is not working well, or it's not plugged in the right way. And you can cope with it as long as you have no needle in the patient. At the moment the needle is in, you are under hurry.
Yeah. So I'm going to look at the muscle here. So if you bring your middle finger just going up and down. So you do want to support him.
Do you want a chair?
No, it's fine. It's fine.
It looks very uncomfortable. Can someone give her a chair, please? You're also small.
And then I'm also in the way. Less in the way.
So I always tell my doctors, please sit down. So surgeries in standing position are only half as good. Ultrasound, please sit down. EMG.
Just relax.
Because often things take longer than you expect. You think it's done in a minute, and then it takes 3 minutes, and your arm gets more and more.
So just listening to, you know, when I sort of touch the skin, already the noise disappears, and when I'm already in I was trying to sort of get some sound before actually in the muscle, because when you're not in the muscle, you don't hear what. Just relax for a moment. When you're not in the muscle, you actually don't hear very much when the sort of needle is just in the subcutaneous
so when you
tissue.
touch the skin or goes through the skin, the signal should be very silent, as you see. The first line is completely flat, because it's in fat tissue. There should be no activity.
But I'm already in the muscle. I'm already in the muscle.
Yes.
And the way that I know that is when I just tiny little bit. So I barely moved the needle, and you could hear there's some activity, sort of like some scratchy sort of activity, and that's what we call insertional activity. So if you're in a live muscle, you will always get insertional activity, whereas if you're on fat tissue, for instance, and you move the needle, you won't get that sort of. So I'll just do it again.
So you have a kind of tactile feedback. So the tip of the needle is sensitive to the tissue. If it's in fat, it should be a nice flat line. If you are moving through a muscle, it's touching muscle fibers like now and causing us insertion activity. This is really
just very gently, just relax.
Even less.
Much less, a little bit.
Less.
Okay, so you can see some activity sort of flashing past. Let me see whether I can stop this somehow.
How to freeze it?
Yeah, here we go. So just one of these signals will be one motor unit. And you can see there's several already. So at the moment, they're not very sharp, so probably not right next to them.
I'm
just moving them slightly.
So sharp is crispy. And if she's not very close to the muscle, then
Just
it's
relax
a bit more dull.
Come up. This finger up. Yeah, and this finger up. Okay. So I'm sort of in EDC, I'm just trying to sort of get something that is, just try and push the wrist up a little bit. I'm trying to get some more distant activity. So that's slightly more distant. You can hear that's sort of duller. Okay, I'm relaxing it. Just do this finger. You hear the sort of higher frequency components, then you know you're in the muscles. You should usually sort of sound very sharp. But so the point here is that when you're doing the EMG, you're recording from a tiny little area. So even though the laryngeal muscles are very small, you will not record from the whole of the muscle. You're recording from just a very small area. And just sometimes very small needle movements will change the signal. Because of the way that the needle is structured, it's got a bevel. So sometimes rather than even moving the needle, because you're at the danger of actually leaving the muscle and going to a different muscle, lots of muscle around. Sometimes it's just turning your needle around might sort of improve the signal rather than even sort of doing long, because change the direction of the needle once you're sort of in a little bit is virtually impossible. You're just bending the needle. You're not actually changing the direction when you're sort of trying to sort of going in a slightly different direction. Okay.
That's a very important point. That you have to go in the right direction directly and not by pushing it around. Like this in ultrasound, you see that you bend your needle here. Sometimes you feel it, but try to get back, get the right angle, and then start again. Don't try to cut through the muscle.
And
here we are in a super nice, comfortable position, a very nice volunteer, and very painless, isn't it?
Yeah, it's probably a bit uncomfortable, I think. So when you're doing the EMG, you're trying to look at three different things. You're trying to look at, is there any activity at rest? Very hard in the laryngeal muscles. Of course, it's almost impossible to completely relax the muscle under this sort of tense position and the patient is anxious, etc. But still, you get times when there's less activity, so you can identify, is there actually any spontaneous activity that the muscle produces without actually any nerve signals coming directly to the muscle. And then you're looking at what's the individual motor unit. So if you just do a little bit of movement, so you're looking at the shape. Normally, you expect a range of different size motor units. So motor units, we're talking about this electrical signal of the motor unit, of motor unit action potentials. Correct term. So you should get some smaller ones, some bigger ones. Most of them should be fairly simple. Sometimes they become, there are a few more phases than just going up and down a couple of times. So you're sort of trying to get a sense of that, of the individual signals that are on the screen. And then also you're trying to get a sense of how much do we get full interference pattern? So you're trying to activate the muscle with the relevant activation maneuver that we're going to talk later. So if you push really hard, push up hard as you can. And there should be a better screen to sort of show this, but you're basically then looking at what is the interference pattern. So in a normal muscle, you should be able to find that all the baseline is obliterated by lots of activity. So there should be a full interference pattern. If you've cut, you damaged most of the axons and you're only, having two of the axons conducting, you might only get two motor unit action potentials, then they will fire very fast at maximum activation, but you're still seeing the baseline in between. So you've got a discrete type of interference pattern, single motor unit action potential pattern of of the interference pattern. So those are the three things you're trying to judge. Spontaneous activity, is there anything? There shouldn't be anything under normal circumstances. What do the motor units look like? Are they how you're expecting in terms of size, shape, duration? And what is the interference pattern? Is there a lot of activity, which is what you would expect? Or are there only 2 or 3 signals coming through, which is not what you would expect? Okay.
Questions before we pull out the needles? So often if you do it in the larynx, you can't relax completely. So it's a very nice situation where it's a completely flat line if she relaxes. But so if there would be any pathologic spontaneous activity, the signs of long-term denervation or more than 10 days denervation, we would see it now perfectly. In the larynx, you often have some activity in between because you are under tension, it's a little bit painful, you are breathing, and breathing creates activity. But here it's really, yeah, brilliant situation. Thank you. Again, if you pull out the needle, you get a lot of noise. So it's good to know the mute button. It's always a... The machines by purpose have this button because it gets sometimes very loud. You want a good signal as if you're in, everyone should hear it. But if you get out, you immediately want to mute it. And you see here, it's even this yellow, because it's the other way around. If you go in and it's still muted, you sometimes focus on the patient, focus on the position of your needle and wonder why nothing happened. And it's just because you're muted. So really be careful to be live when you go in, but turn it off because it's annoying loud if you go out. Some of the units have also put pedals in. Yeah, but I mean, they have. Most of the time, most of the time, I think you need an extra person, at least in your clinic, right? Do you do laryngology and EMG ever completely on your own? You do. Yeah, but yeah, as mentioned, without most of the hassle, yeah. But it's a little bit not so nice. It's much nicer to have 2 persons. And in an academic hospital, normally you should have someone around to help you. But someone takes care of the patients. And of course, you putting the needle in, you have to do more or less both. You have to look in the face of the patient. You have to give the instructions, and you go with the needle into the right position. And then it's nice to have someone doing the recordings who knows the machine very well and gives you some instructions. I need more samples. It's nice. I have everything on tape. You can go out. So it's nice to do it in a 2-person setting, of course. So the machine, a screen, so you see everything. You have some loudspeakers. So we got the microphone on channel 2 here. So there's really a loudspeaker. They always have loudspeakers. So the EMG is always something where you hear something. It's different to EEG or ECG. But it's really helpful because when pushing the needle forwards and backwards, you want to hear what's going on before you see it. And you want to see, if you're looking in a different direction, it's good that you get the signal. And some diagnostic things you even hear better than you see it. The EMG, most of the judgment you can make. Yeah. Okay. What's perhaps good for us as laryngologists, that we have similar importance of hearing things. You can store them on the machines nowadays with the computers, and in theory you could export them. Ask the company, so if you really want to do research with it, ask them how to export them. Natus was not able to export them very well, so it was difficult to get them out, and it took some time and some workarounds. Normally little people do research, and if they do research, they don't do 3 EMG channels and things like this. So if you want to do more than look at the graphs and put them into an Excel sheet, if you really want to go into the basic stuff, then be careful that your machine can export it and everything is working. It should be easy, but it's something little people do. Looks like. Yeah, some companies it's easy. Yeah, I think it's coming more anyway. Yeah. Okay, you see the microphone. The microphone looks pretty normal. You can speak into it. So just to get the extended setting. Yep. Hello. It's not. I think it's working. It's just it's working. Just. Hello. No. There we go.
I think it's quite a bit of.
Don't break it. You can turn it on and off so that the battery is not running out. It's on off. Hello.
Oh, now it's on because it was just reacted to them.
No, it was off.
Okay.
Okay. If you
still something.
The funny thing is, if it's off and you shake it, it's still some signal. But why? Because the wires are catching up signals from the room. Really be careful. It's the microphone is not recording anything because the battery is not amplifying it and sending to the wires. But the wires are still in this room, and this machine is so sensitive that just the wire shifting around in the room is catching up some signals because these rooms are polluted with electricity. That's the reason why there's this frame. There was an electrophysiological lab in here, and they were trying to shield it completely. So there's really a very good condition. Not nowadays, yeah, we have polluted it again with too much electricity in it. But now if I turn it on, then I can really get the signal from the microphone. Make it perhaps smaller, then it's gets smaller. You only see it. And I would also perhaps put the 50 hertz smaller. Yeah, because then it's, yeah, and then the 50 hertz filter perhaps, and yeah, it's a little bit more. No, it doesn't change too much. At least you see a little bit, and you see it here in the repetition. If someone is speaking, yeah, this can help you. And now I turn it off again. Yeah, we have to be careful. Remember us later. If it's not running, it's because it's off, because I try to save the battery. And here's the last thing. It's chest belt. And you should put it somewhere here. Actually, it's breathing. So there it comes, the third line. Put your finger on it. And if I pull it, it goes down. If I relax, it goes up. You could see.
So this is usually quite a slow signal. So the way that the screens usually work, you can't really see this very well on the sort of initial recording. But when you sort of review it and then sort of compress the timeline, then you usually can see the signals. Our experience wasn't very good with the chest. The ones that we had to put on so tight that the patients were already anxious and a bit kind of, what are you doing? And then sort of putting something really tight around the chest, they really didn't like it. So we sort of stopped using it. Maybe we didn't persevere enough with it, but we really sort of didn't find that it sort of helped an awful lot. And then, like you say, some people, if you have singers, etc., they just don't breathe with their chest. They breathe in a different way. And you're not actually getting a lot of signal anyway. So it kind of didn't seem that we got a lot of helpful information. So maybe the thermistor. We haven't tried it out.
But again, different companies have different amplitudes, so you have to adjust your settings. So we spent an hour this morning to adjust this machine, because the machines come every time completely blank, and then you have to adjust the settings. And yeah, so it's, if you want to do more than an EMG, then think about it, but we can help you. And there's good instructions on the LEMG website, but we can also send you the stuff. And Natus, if they can do it in an hour. This morning they managed to do it. Also other companies. Good. So there are more machines we can split up later, but that's for after the break, because then more structures are here, then we will have the fun all together. Questions? Yeah, please.
Very good to bring up, because when we do our EMG together, we had an electric chair, which most patients have, and then that moves your patient to be more comfortable. We have to switch off our electric chair because otherwise it gives you the interference. So you have to think about everything in your room. It's not just, movement and all that. So it's super, super sensitive. And we only have light in our room. That's it. Nothing else.
There's a lot of electrical machines. There's the fan, and there are lots of machines.
We did turn up that potentially.
But most of the time, actually, the EMG is quite robust. But you may, when you start the service, you may have to sort of check. There may be something that you might have to put the chair in a different corner. Something, there's some really odd things with electrical. There was sockets or extension wires. Sometimes is really sort of dangerous. So it's not always predictable. Sometimes you come in a room and you think, oh God, this is going to be awful, and it's perfectly fine. If I go to the ward, sometimes, certain ICUs I can go, and there's like millions of devices around, and there's no problem with interference, and others, you just can't get rid of anything. So it's
often worse to get the preamplifier close to the patient, but this is not because these wires are relatively naked and not shielded. If it gets in here, it already gets digital, and then so if this is short, it's you sometimes wonder why the cables are so short, but the reason is to
close
avoid
that
too much interference.
Yeah.
Yeah, if you have very long cables, you just if you wind them up, sometimes helps.
Not swinging around and catching up the areas.
Okay. Thank you, Fabian. Thank you, Doreen.
Yeah, good. Let's just go through some slices and then.
Well, I'd like in London we saw, but there may be different makes. That's useful.
One trick to check it if you don't want to poke into your own arm. So you get a pretty similar intraneedle EMG without going through the skin. If you touch your tongue with a needle, so your tongue has no mucosa and a lot of muscle, and it goes so close to the muscle fibers that it nearly looks like a perfect EMG. Not a perfect one, but a little bit rounded. But it's pretty good to check the signal quality. If I want to check a room and I'm alone, often I just put the grounding and then put the needle on my tongue. And if the signal is fine, then get rid of this needle. But instead of putting a needle into my forearm, but that's a way to check it, to get very close to a muscle and get signal what's close to it. But by moving around your tongue to get different degrees of activity, sometimes you step yourself and start bleeding again. But anyway, it heals very fast. So that's the machine I have in our clinic, and a little bit older than this one, but pretty much the same. And heavy. We have also two laptop devices who are a little bit nicer to carry around. But in hospitals, actually, it's good if they are heavy because they don't get lost so fast. With EMG devices, they fall down or get lost. So it's okay to have something where people know where it is. You were asking for electrodes. So I have a slide with electrodes. Here you can see this double needle, this concentric needle. So I should use this pointer here. So the needle it's a hollow needle, was filled with plastic, and inside there's a second needle or a wire, and it's recording from inside to outside. So these two things are actually two needles, and so it records only a very tiny field, only everything close to the tip. That's good because it's very selective, but it's not telling something about the whole muscle, but only to the area where you put the needle in. So it's like taking a specimen for the pathologist. If you put the needle at the wrong area or in the wrong muscle, you get signals, but do a misinterpretation. And it's the same if you put a specimen outside of the tumor. The pathologist told you there's no tumor in the piece you took out, but it's not proving that there's no tumor in the whole patient if you don't know where you took your samples. So be careful. Needles, different sizes of needles, and these wires. And here, this is a standardized plug. That's important and easy. One here. So this plug with these 5 things, work it out. And here the machine has, for all of these channels, an entrance working like this. And there's another entrance up here where you can go in with 2 1.5 millimeter touch proof, or what is this?
But yeah, standardized, well, fairly standardized.
Pretty standardized. Unfortunately, the other end isn't standardized at all. Every company has its own connection between the needle and this cable. So if you get a new needle from a new company, what is very nice, much cheaper, you have to be careful that these needles have to come also with a new wire. This is connection cables. So you can't put everything together, or just the other way around. You could put nothing together, but it's not from the same company. But it's really, yeah, not very useful. If you ask someone else, can I get from your the neurology department some of your needles? I'm running out of needles. You also have to ask them, can you bring your cable? And we had this problem this morning. Gerhard wants a special needle he's very trained in it, and that's good. So if you do always use the same needle with the same stiffness, his brand, he can not only bring, he has to bring just his needles, but he also has to bring his wires. And fortunately, this 5-pin fits in most of the machines, but not the cables. That's the reason why I use just the same things that our neurologists use. So if one of my cables get broken, or if I run out of, I ask them. So I wouldn't worry about, so sometimes participants ask which are the best needles for the larynx. I would just look what is available in your department and try to stay with the same stuff the other use, because it's not worth to get your own stock on needles and then they run out of date. And so it has to be long enough. If the needle is too short for the larynx, that's a problem, but everything from 5 centimeters or 7.5 is fine. It's more that you should use the same needle again and again. So what is your most used needles, Doreen?
I'm going to tell you the color. I don't actually know, because we've started doing also some different sort of methods. So we used a slightly longer needle. So this one is definitely shorter than what, I think the one that you're just sort of passing around is roughly sort of the same size for the TA, I think we use. But what's the long one? I have to look up the,
6 centimeters, yeah.
Type of method, as Doreen was saying, you know how we used to do LEMG guided, just push it in. But we started to do thyrohyoid approach, which we also do the double bend needle. So you do endoscopic, and then you have the double bend needle going through thyrohyoid membrane, and you can see exactly where your needle is. And that is quite malleable. And I think it's 27G, but 6 centimeter.
I think it's for the ones where we're worried that there's no signal and it's too long, that we don't have spontaneous activity. So in order to, really confirm that there's no signal and we're in the right place, that's kind of when we're sort of gone that way. Yeah.
I mean, we did worry by bending the needle, it may, affect the signal quality, but it doesn't look like it.
No, the ones that we've done so far,
it's more robust than we think.
Bend?
Yeah.
The plastic is still insulating the inside
and
the outside, but you lose control to steer it.
Yeah.
So the larynx, I managed several times in the beginning to be on the left side. We try to retract it far enough, then go to the right side, go in again, and then putting out the needle and realizing the tip was bended. Instead of going from left to right, it was just bending the outside. It was twice recording the same side. I was like, oops. That's,
Okay. I mean, ours one seems okay. I mean, when we take it out, it'll still look the same. Maybe our patients are not so calcified. They don't drink so much milk or something. But I mean, it does go through okay. And then I think it's quite robust. But it's interesting to hear different ones.
You can, the easy trick to, it's really, if you are uncertain about it and you put too much force on it, an easy trick, if you go in with the needle, retract it and go back to the other direction, and you're not completely sure if it's still working, just turn it a little bit. And if it's turning, then the needle is straight. If it's not turning or if it's wobbling, then for sure you have to just get rid of this needle. It will happen tomorrow with the picks. So if you put needles into the picks and try to get from left to right without going completely out, what's good in theory, you often start to bend it. So there will be a lot of banded needles. Don't worry about it, but try to get this learning curve done before going to the patients. And to double check, just turn it a little bit. That's pretty easy. Thank you for the pen. So my co-host has arrived, Andreas Müller. So we have.
So sorry to be late. So we start with this pre-course to give you the basics for EMG, and later on we start with the battle between visual neurolaryngology and EMG. So I had to do some work in my hospital this morning, so sorry for being late.
You don't have to be sorry. It's a great honor that you're here at least. And yeah, it's only optional, this part. It's just, we just realized that a lot of people are interested in this pre-course, what I appreciate. Fabian Burk has also arrived. He's a colleague from Andreas. So he's also one of the staffs. And later on, we will split up into the different rooms so that can be, we've done already one EMG of the forearm here for demonstration, just to use the time, and then we later can split up in all the different groups. So needles, hooked wires, unfortunately, very nice for larynx, but not on the market at the moment. So this fine wires that get inserted, and then you pull out the needle and only the wires stay into the muscle and you get nice recordings from it. It was very nice for the larynx, but these long ones you need to get through this application device are not on the European market at the moment. And here, surface stimulation, just a plastic piece with contacts where you can stimulate, and yeah, single use adhesive ones. You can use them as ground, but you can also use it not in the larynx, but perhaps in the face to get some activity. Just some basic stuff. Let's say this is a larynx muscle, the whole thing, and every hexagon is one muscle fiber. And here now comes one axon, and an axon is not innervating a whole muscle. It's not innervating one muscle fiber, but it's always innervating a group of, and the exact number depends on the size of the muscle. So for big muscles, it's 1,000 or 500 or
several hundred, yeah.
Yeah, several hundreds for limb muscles, and for the eye, I think it's more or less 1 to 1.
No, it's not 1 to 1. There's
1 to 5.
About 10, I think.
1 to 10.
Yeah,
okay.
yeah.
And larynx?
10 to 20, I think.
Okay.
Yeah.
So the eye muscles are a little bit better controlled. 1 to 10 and 1 to 20 or 15 here for the larynx. But it's also very fine tuned. So it's really nearly fits. So what does that mean? If the brain wants to activate this muscle, it can decide if I want to go to activate 1 or 2 or 3 of these axons, and then this subgroup of muscle fibers is activated and fires at the same time. So push the axons away to make the picture easier. So putting a needle EMG in the middle, you get the recording, but only from the things who are close by. So everything what is too far away, the blue ones and the green ones are not in the field of recording. So even if the patient, insertion activity, this was before activation. And then this is important that I know that I'm in the muscle, and we can already make our first stitch on this piece of paper, on the documentation sheet. There is insertion activity, so there is still muscle, and we can classify it between normal or increased or no activity if it's completely atrophied. And then we go back and ask the patient to activate a little bit, as less as possible, or if you need more, then you already can get some recordings. And if you ask the patient to activate a little bit more from the same, then you can first only from the activity close by. Only the red one is firing. So only when the red is firing, you get a signal. If then the patient gets a little bit stronger, he activates more motor units, then it gets from the red and the blue, and the signal gets a little bit more complicated. This was the case when she was activating too strong, or not too strong, but a little bit more. If you ask her to activate even more, then perhaps all 3 motor units close by fire. And the interference patterns gets more and more dense. And at the end, there will be several dozen of motor units firing at the same time, and then you will not be able to differentiate the single things, the different units. So far?
Yeah, so increase of contraction is basically done in two ways. You're firing the motor units faster. So you get your first motor unit. If you do it in a limb muscle, you can sort of look at that very precisely. You fire first motor unit, and then you ask a little bit more contraction. The first motor unit will fire faster. And at a certain sort of frequency, the next motor unit will be recruited. So you then get your second signal. And obviously that sort of builds up. Sometimes these are not exactly sort of, maybe how we sort of simplified sort of see it, but it's basically frequency of firing and number of motor units recruited. And generally also you start with the smaller motor units, and then as you build up the larger motor units, so the motor units, the axons connected to more muscle fibers come towards the end. But again, the buildup is not so much in these small muscles where the motor units tend to sort of be more or less the same, size, or the variation of size is not quite as great as in a limb muscle, for instance.
So the important thing I want to show you here is that it's very important, a very strong influence where you put your needle. And we never know where we put our needles. So we try to put it into the muscle, and we're happy to hit these small muscles. But after a week, we can't go back and record the same area. So even if everything would be the same, and I put back the needle a week later and try to check if everything gets better, the signal can be completely different, but not cause of renovation or the patient gets more healthy, but just getting a different recording spot. So don't overestimate the truth from the EMG machine. Yeah, it can be that you are only at the wrong place, and that's it. Why it looks different. So
yeah, we often
try to avoid it by.
Yeah, I mean, we sometimes get asked, can we repeat? Can we see whether the EMG is better? And you really have to go. Well, first of all, there's the sampling error issue that you have anyway. Plus, you really have to go for quite a big step before you can say, this is truly different, because even just in the same muscle, you're sampling different areas, they look sometimes very, very different. So having is this better than, is there a bit more interference pattern than, those are just nonsensical sort of comparisons. Of course, if you have absolutely no signal, so there's only spontaneous activity and no volitional, activation of the muscle, and then you'll look at, 6 months later, and there's now suddenly good, motor units coming through, So there has to be quite a big change before you can really confidently say there has been an improvement. Minor changes are just not worthwhile looking for. It's not scientific, basically, because of the way that you're sampling.
So the other way around, it's not super important if it's a mildly decreased interference pattern or a strongly decreased interference patterns, because we don't know. So it's perhaps not worth to train too much into this subjective gradings and also an objective counting, because the tip of the needle has such a big influence, and we can't always get to the same area. Other way around, you try to get it for big muscles, several positions in the same muscle.
Yeah, sometimes, exactly. If you can see the muscles moving, but you're not getting good signal from where you are, you might sort of go somewhere else. Plus, obviously, you already, because your needle is most of the time in the muscle, even if you're a bit deeper, but you're just already sampling on the way, going in, going out. So you already have an area of sampling with these muscles that you're in there, you're lucky you're in there. Yeah. And then if somebody coughs or swallows, the needle suddenly is in a different place, and you're not sure whether you're even in the place anymore.
Yeah. Seen this? So multi-channel. And here it's very nice to differentiate between nothing and a little bit. Try to use this device. Okay. Laser pointer. So if there's nothing, if it's completely denervated, it's pretty clear. If there's a little bit activity like we have seen, it's good. And if the patient is asked to do a strong and only gets something like this, it's perhaps not enough. But between this pattern and this pattern, the differentiation is already difficult. So EMG, needle EMG is very nice here between 0 and 1, but on that side it becomes a little bit ambiguous. So if you have a lot of experience, if you are very sure where your needle is, you can make some judgments in that direction, but be careful. But anyway, that's the second point on your list. So first, insertion activity, that you are in the muscle, that's good. And second, there's activity if you ask the patient for the larynx for an R. So that's important, that you have to know which muscle has which maneuver. And for the larynx, as a phoniatrician, which one would you recommend? What is a good, put a needle in the TA, the vocalis muscle? I was also always starting with the E, but Berit was telling me E is not so good. Sorry. Why is E not so good? Yeah. So the larynx is pulled away from your needle, and it's fast. It's difficult to follow it. So an R has the same effect on the tension of the TA, but less elevation. So good idea. Good to speak to an experienced laryngologist who knows these tricks. Okay. Any questions? Only two more: pathologic spontaneous activity and synkinetic activity, and then we are done for the first session. Yes.
Thanks. You already said that there's only a part of the muscle recorded by the needle. Is there an area you can define how much of that area is recorded? And can you change the sensitivity of these needles to get different signals? Or can you not say how much of that area is recorded?
It's specific for the needle you use. For the concentric ones have a small recording area, and in theory, it would be possible to build an EMG needle with a zoom lens. Sorry, this is partly automated, and I don't want to get ended. So you could push the inner needle more out, and then the field of recording would get bigger. But these things are not on the market, and I think the market would be small to get some of these needles where you can adjust it, because they are too cheap, and it's not normally you choose different needles. So instead of putting a concentric one in, you could use a monopolar needle, a needle that is only recording the tip, and the ground is somewhere close by, and then it's not the ground, but the second pole is somewhere close by, and this field would be much bigger, with the pros and cons, that you get more crosstalk from other muscles, with the pros that you get a more activity from the whole muscle. Do you play with different muscles? I mean, with different needles for different purposes to get bigger recording fields?
Not really, no. I mean, you have to have a long enough needle and a big enough needle to get into TA, for instance, or PTA even more. So we just use standard needles. We don't sort of really experiment yet, but you just literally just tiny little bit of area around and it depends on the exact needle. So
we are normally happy about getting this small sample where we get some activity and not activity from all the area around. And that's also something like the stiffness and length of your needle. Also, the recording field should be relatively stable. You get trained to it. You have an eye, you have an ear trained on if this is already an intense interference patterns. And if you then take a different needle with a different recording field, your calibration would have to change. And yeah, I don't know if you want to be calibrated on 3 different needle brands. I have already the problem with Botox that I try to stick with one dilution for all my cases. Even it would be nice for face and larynx to have different dilutions, but I think it's too dangerous. I will mix it up. So let's try always the same dilution for all patients.
I mean, naturally, your needle moves anyway. The breathing, the things. It's not dead still anyway in that muscle. So you will have a bit of different areas. So.
Yeah.
I think the single fiber EMG needle has a much more defined and very small area which you can then actually use to, for instance, count the muscle fibers, in a particular area and make some calculation. Is that correct? But for the concentric, unfortunately, that sort of functionality is not there.
So the surgeon has already cut it. You see it? So, and in that area, on that time point, it would be possible still to stimulate. So if you would put something here and stimulate, these axons would, for at least for a few minutes, be able to get some contraction. So if you
not minutes, days.
It depends how much to stimulate, huh? Till all vesicles.
I mean, this is the point when we have peripheral nerve lesions, when the patients come too early. If they come on day one, I have a very good, so if the lesion's at the elbow, let's say, if I stimulate below, I still get a signal. And I don't know whether that is because of conduction block, because when I obviously go above the lesion, I won't get a signal. So it could be conduction block or neuropraxia, or whether that's simply because you need to wait for Wallerian degeneration to occur, and that takes, depends on, but usually you can sometimes still get a CMAP, you still get a muscle signal days later.
But only as long as the neurovesicles are still putting neurotransmitters to the front, huh?
Yeah, I mean, it just sort of gradually it dies back, but it can take surprisingly long, and you can still get, signals there.
What is really dangerous if someone writes in his surgical protocol, there was some damage, but I checked it afterwards and I still got good contractions of the muscles. So if you're not very precise, describe where he's stimulated, you have to be careful to trust him. Because if you stimulate somewhere here, there's still movement. After parotid surgery, the face is still moving. I don't have done anything. But yeah, you can cut it. You just have to stimulate before to be on the safe side, or to prove that you have made a big mistake, and what we often don't want to do. So for a few days, it's still possible to stimulate, and then these muscle fibers get more and more bored. But that's perhaps also a point. So it has something to do with a resting activity and getting. And then this interesting spontaneous activity, what Doreen already mentioned. And again, I would recommend not to use the term spontaneous activity alone, because it sounds so positive. But I would recommend to use the term pathologic spontaneous activity, because then it's clear that it's something bad, because it's pathologic. Can you help us to understand this phenomenon better, Doreen? What happens to no one knows, huh?
No, there is some explanation. It's partly to do, obviously, you only get the spontaneous activity if you lose the neuromuscular junction, integrity in essence. So that's why it takes some time for this to develop. There's various processes going on, so your membrane becomes less depolarized. So normally you're sort of at a -80, -90 millivolt voltage difference at the muscle membrane. So you sort of start to express different channels, potassium and sodium channels. Your membrane becomes less, so less minus, so you're sort of then sitting at -40 or so. It also sort of starts to oscillate in terms of it becomes a little bit more depolarized, a bit more hyperpolarized. So it sort of goes through these sort of swings, and then you sort of reach basically the threshold where you then start to produce an action potential easier. So there's a sort of various. It's to do with voltage-gated channel sort of expression and the lack of input. So even if you have a muscle that is not moving because of whatever, it's in the cast or something like that, the neuromuscular junction integrity usually ensures that you don't produce this activity. This only happens when you lose the connection completely with the axon. So if you get axonal degeneration in essence. Because normally, and even if you're not moving the muscle, you get some acetylcholine release into the synaptic cleft to sort of keep the muscle, so to speak, alive. So that those sort of processes, if they sort of fall away, the muscle membrane changes, basically the electrical properties change, and it then starts to produce this rhythmic action potentials spontaneously. So these are just muscle fibers producing action potential on their own, which is not something that happens under these circumstances, because normally they're silent and you only activate the individual. You can't actually activate individual muscle fibers on their own. You only ever activate whole motor units. So it's always an axon and all the signals, all the muscle fibers that are connected to that axon so they always fire in conjunction with other muscle fibers under normal circumstances. But under the pathological circumstances, if it's lost that sort of axonal connection, they then start to produce their own action potential at random. And sometimes it can be quite a fast firing, can be quite slow firing. So they're sort of different things.
And how differentiate we between volunteer activity and this pathologic spontaneous activity?
So it's
does anyone know? What is the difference between volunteer activity, what we have heard before, and pathologic spontaneous activity? You see it here a little bit, or I try to do it here. It's random, but it's more rhythmic. So it's more tuck, 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 or but very little bit like music, in contrast to activity from the brain going over the nerve to the larynx, to the muscles. This is always out of phase, always a little bit stochastic. So it tries to avoid to get in the same patterns. In contrast to this, there is more a little bit a chemical process, more denervation of single fibers, and this is relatively precise. And you don't see this activity if it's innervated. And if you do this multi-line EMG, you see tuck, 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 tuck. So the time difference between one and the other is very precise. So here a longer time, and here they can look different, but they are often in these patterns. And you see it on the EMG if you have to have this cascade mode where you have 5 channels or 10 channels. But even more important, you hear it. And we'll see if it hear it here. Do you believe it? It's different to what we have seen in her forearm, luckily. So we are happy that she hasn't any pathologic spontaneous activity in her forearm. Let's run it again. More than one fiber, 2 or 3 patterns in it. Each pattern has a very precise rhythmic. It's this one and the small one, but they have different rhythms, but all of them are very stable. This is a signal what is very bad for the patient. And now we are back to the first talk, 10 o'clock this morning, that if you have something like this, you can tell this patient, sorry, 90% chance of a bad recovery because some axons are dying. Very likely not the same way like before. I think the outcome is worse than before, so it will not recover to fully. Don't know how worse it is. So there's another phenomenon, complex repetitive discharge. That's relatively rare, but we have a good chance to see it tomorrow. Insertion activity, we've seen it at lollipops. Then the needle will move it around into the muscle. Like stuff going very unusual, in less than 5 patients. So very few. How often have you seen it?
Quite regularly, I would say. Yeah.
In which kind of patients?
Well, most of them have some sort of laryngeal nerve lesion due to usually surgery, sometimes infections. But it's I guess maybe it's not very well explained, as we discussed previously.
Yeah.
What actually happens? Yeah.
An idea would be that perhaps they contact each other and they start cycling between the activities. That one fiber is close to another fiber, and both are very volunteer, it starts to cycle them and could perhaps explain this activity. And the interesting thing is that it also we have managed to create it by putting needles into the larynx pits the whole day. Often in the at midday they start to get this activity. We'll see if we get it tomorrow. If we have one, we will call you. Oops.
So the book explain usually says that it indicates some form of chronicity. Yeah, having said that, but which here in the experiment on the day, so if what it tells you is that you're in an abnormal muscle, which is helpful. You don't get any other activity other than CRDs, means you were definitely in some place where you get abnormal activity. And if the patient can't activate the muscle, that's probably a bad prognosis. Clinically, if I see CRDs in any muscle, it doesn't actually tell me whether the patient had a problem with a nerve lesion or a muscle lesion. So I see it in myopathies, but also see it in chronic nerve lesions, generalized neuropathies, etc. So it's not very specific to what is the underlying cause, but it's usually tells you that there's something wrong. And the traditional teaching is usually it occurs in some sort of chronic process or in a chronic neuropathy, chronic myopathy, those kind of things. And there are certain muscle conditions where you see it more often than others. But I don't think it's very well understood, the phenomenon as such. But it's always quite nice if you're not getting a lot of, you're trying to sample the muscle, you're not sure you're in it, and then you sort of finally hit a place where you get this activity and the patient's not able to activate the muscle. At least it gives some sort of confirmation you're in a pathological muscle in essence. That's kind of always helpful.
But that's good. So that's a lot of open questions in electrophysiology. So it's not, for the patient, it would be nice if everything would be solved. But for you as researchers, it's great that there are things that can be published in the future. So if someone wants to publish a paper about a model creating complex repetitive discharge in animal model, please feel free. So we have it here. We just poke a needle for several hours into a muscle, and then it starts to get, and this would be a nice setting. So we could talk to neurophysiologists or biologists and try to understand these mechanisms better. And perhaps it would help our patients in the long term. So there's still a lot of things, even these techniques are not new. There's a lot of things not yet understood. So third point on the tick list, pathologic spontaneous activity, know it all, a little bit, a lot, and in all areas you put it everywhere.
Have you have an experience for any concomitant reason of doing electrophysiological assessment in people after having toxin?
After having Botox?
Botulinum toxin, yep.
Having what kind of what experience? Putting a needle into a muscle?
Doing EMG.
Doing EMG. Yeah, I mean, you basically denervate the muscle. So initially you get spontaneous activity. And then later on, usually the sort of motor units look a bit, if it's only a one-off and then you sort of sample quite some time down the line, usually the activity looks fairly normal again. The only thing is you get a jitter. So if you're doing single fiber EMG, you get jitter for quite a long time, a lot longer than the clinical symptoms might suggest. So I often have the problem that patients get sent with, is this myasthenia? And they forget to tell me that the patient had Botox, a month before. And then clearly this jitter will be abnormal because of that. But yeah.
I have the experience some oversight by the client. So like having in shoulder dystonia or facial spasm treatment for a long time, people that have obvious atrophy that you can see that the muscles atrophic have a dip on one side of the face or the asymmetry in the face, and somebody was worried about the stroke and they do the electrophysiology. I think the electrophysiology has been the one I done, not one off, but people have more than one injections is permanently abnormal. So
I do remember a case as well that was very sort of neurogenic looking, EMG pattern in somebody who had quite a bit of Botox over the years, and we never really established, is that really the Botox, or was there some other case? There wasn't much in the literature, actually, when I looked at it.
They can interpret the electrophysiology.
Yeah, it becomes difficult. I mean, theoretically, there shouldn't be much, this is different. So although you're denervating the muscle in essence, and you're creating new neuromuscular junction after Botox injection, it's not the same like an axonal lesion, somewhere in the neck or on the chest where the whole of the axon have to be out.
Muscle atrophy, denervation, but you have preserved power, so the trend is completely normal.
Yeah.
After the 3 months or whatever. Clinical effect.
But it's difficult to understand because obviously the lesion here is at the neuromuscular junction, and although you get like a formation of a new neuromuscular junction, there shouldn't be so much of, in terms of the axon is suddenly now, one axon is innervating a lot more muscle fibers, which is normally what happens in reinnervation, if you have a lesion of the axon a bit further down the line. So that's why it's kind of difficult to understand, the electrophysiological pattern, and I don't think people really know what
toxin is acting down the stream, maybe, not only in the junction.
More questions?
I have a question about the respiratory activity of these muscles. Are they active in both phases of respiration, so inspiration and expiration, or they differ regarding the participation in these both phases of respiration?
Of course, they're differ, and of course, they are active in both phases. So it's never an on-off phenomenon. It's always, so if you bend your arm, you activate one muscle, but at the same time, the agonist and the antagonist. So to bend the arm, you need control. So you don't do it completely. So the antagonistic muscle is firing at the same time, but with less activity to steer this movement. And it's the same here in the larynx, that if you try to open or close it, you always need both muscles to control it. And here we need a lot of control. So it's always activated in both ways. But yes, if you do, for example, a sniff, fast in breathing in, more the PCA is activated. And that's a nice technique to have an agonistic movement relatively specific for the PCA. But you get also activity at the same time from the TA if the needle is there. And the other way around, if you say most activity should be in the TA muscle, but getting this muscle in the right position, it's not only TA, but someone has to hold it and stabilize it, and that could be only the PCA. So it's always both. So it would be nice to do a multi-channel recording, and there are things done like this with multi-channel hooked wired electrodes where really both sides, 3 muscles on each side were recorded at the same time. And then you see, and you can compare them. Was it your question? It's really, yeah, but that's difficult to judge if you don't record simultaneously at the same time, because then you get activity by opening and by closing, and then you have to think back, okay, there was a little more activity by opening than by closing, so it's the right way. And if it's synkinetic, then perhaps it's the other way around, or it's mixed. So getting to the last topic, synkinetic activity, and then everything gets more complicated because then opening and closing happens at the same time. So to make the larynx much more simple than it is, I just broke it down to 2 functions, opening in blue, PCA, and closing LCA, TA in green. And the green fibers fire if I want to say and the blue fibers fire if I want to sniff. But as mentioned, you need both to control this movement. It's not so easy. So phonation would be activation of the blue. And simple, so if you put a needle in, there should be a little activity in between. Here, when there's no activation, but most of the activity should be recorded when there's a phonation. When you say you see it in the EMG recording, and you see activity if the needle is really in the healthy vocalis muscle. So far, so good. So try to get it there. How to get it there, Gerhard will tell you later after the break, after the coffee break. So when we go into the details, Berit will give a talk about how to put needles into the vocalis and Gerhard about the PCA, and then we can do it in each other or in phantoms. Are there phantoms around this time? Great. 4 or 3? Good. Super. Yeah. So more than enough, because these phantoms are multi-use. So we can really do. And tomorrow, so it's nice this way. There's a company or there's a startup starting making very nice silicon phantoms, and that's actually the perfect way to talk about it, but then do it once in plastic to get an idea, and then sleep a night over it, and tomorrow do it into the pics. And then if you are very sure what you do, then you are allowed to do it in the afternoon here. And there's a stretcher and there's some paramedic equipment if you don't feel very well afterwards. But it's the end of the course, so it doesn't matter. So yeah, don't feel stressed. It's really, if I have any problems with vocalis EMG, it's more that the patient understands too much about it. So this is one of the procedures. So you know much too much about it. If you see what your colleague is doing, you know how dangerous it is. It's not dangerous, but how deep it goes in. If I do it with a patient, I explain him as little as possible, because it's really, the needle is thinner than drawing blood, and it's only here in the larynx. Don't worry about it. And then it's out before he understood what I do. And it's not painful, and it's possible. But if you would explain him that you go in with a 5 centimeter long needle and close to his vertebral column, and how big important vessels are close by, they would feel well. But luckily they don't see. So if you go down here, it's fine. So this really, this procedure looks nice, but you see the long way and how to reach it. And yeah, but Gerd is an expert for it. He will teach you. So if you are there, sniffing activity should be the test to know that you're in the right muscle. And if you bend your needle a little bit, it could happen that it looks like going to the right side. In reality, it goes to the left side. That's the important thing, why you turn your needle a little bit to be sure that it's still straight and that you are really at the right area. So now a little bit damage. So a conduction block, so not all activity goes through, and you scope the patient, you see, oh, there's little or no movement, vocal fold immobility or movement impairment, however you want to talk about it. But if you put a needle in, you see some activity, and that's good. That's good for the patient and good for the surgeon, because you know whatever has damaged it, it was not killing the whole nerve, and at least some fibers are still firing. And even if some of these fibers would be cutted, there's a good chance of growing through it again. And hopefully the fibers are not cutted, but only the myelines are not working for a few days. Then it gets better, hopefully next time. But you don't have to cut it open again after a week and do some revision surgery. If it would be cut it and 2 centimeters in between, then in theory it would be a good idea to reopen it and resuture it. But yeah, in such a situation, doing an early EMG, don't worry. It could be that it's an external damage, but you can't do it any better by a revision. So at least, yeah, you're not under stress to improve it now. So again, you can classify it, and perhaps it would be somewhere here or here. So a little bit of activity. So now you're a little bit more intense in this damage, cut it completely. And now, rarely we have these clear cases. Normally it's always something in between. But to keep the story simple, we start with a little bit damage and complete damage, and not with all the mixtures in between. In this case, ask the patient to phonate, putting a needle in, you should get some insertion activity. You know, I'm in the muscle. It feels good. The needle seems to be at the right position. The patient says, ah, but nothing happens. So that could be the EMG. But there's a flat line, no activity. And that's,
except after 2 weeks, you get spontaneous activity.
Genau. And less than 14 days, so less than 10 days, 14 days, you should get a flat line. And because we do the damage, we as ENT doctors, I sometimes have the chance to do an early EMG. You very rarely get these patients because they don't get appointments the next day. Or you try to avoid it, huh?
Yeah, we often do, yeah. It's kind of convenience as well as.
There are people who say it doesn't make sense to do an early EMG. There are people, it has more, if you have only one time the chance for an EMG, please do it after more than 14 days after the lesion, because then you get both. You have an idea about how much fibers have survived and how much nerve fibers have died and how much pathological spontaneous activity is there. If you do an early EMG, you don't get any information about this pathological spontaneous activity.
But you do get, if there's still continuity, if there's still some signal coming through, that at least tells you don't have neuroatmesis. And obviously then the chances for recovery are a bit better. So it depends a little bit what the question is.
Exactly. And in our department, if we do a damage, we put the needle in and already write it in the discharge letters. And instead of inviting the patient in a few weeks later to get more information. So it's more a question of your workflow, how you do it. And both is interesting. Of course, doing several EMGs would be the gold standard, but that's really gets very time consuming if you do an EMG.
Not like it. Patient may not like it. That's
the other thing. Yeah, that's it.
You put off after one.
So after 14 days, after 2 weeks, there should be certain pathologic spontaneous activity, putting the needle in, no activity in any rhythm of his volunteer activity, by sniffing, by saying, it still stays the same. It's only tuck, 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 tuck. So this is pretty sure to be pathologic spontaneous activity, as you have already seen. So this is proving that there's some serious damage.
Perhaps can I just sort of add, you said about the pathological. So one thing to differentiate between volitional activity and pathological activity is the sort of rhythmicity. So when you voluntarily activate a muscle, there is some semi-rhythmic activation as well, usually not in the larynx so much, but in limb muscles. But you can see usually there's modulation, whereas these ones tend to be very dead regular. But not only that, also if you have some really slow activity, so if you're firing something at 1 hertz, 2 hertz, you cannot fire a motor unit voluntarily at that speed. You always start at about 4 hertz. So if you have something that fires at 1 hertz or 2 hertz, you know it's pathological spontaneous activity. It cannot be volitional. So not all pathological activity fires that slow. So if you get a lot of pathological spontaneous activity, you have often a mixture, and some actually fire irregularly. And you know, they're not all doing the same thing. And sometimes, if the whole of all the muscle fibers are fibrillating, when you put the needle initially in, you think actually the muscles, there's additional activity. It takes a little bit of time to listen into it to realize, no, this is all spontaneous activity. There's no correlation between activating the muscle and not. It's just a full interference pattern in essence of pathological activity. So you then really have to sort of listen a little bit and identify, no, this is spontaneous activity and these are not motor units that you're looking at.
And it's also related to your movements, so to the needle movements. So sometimes you can fool yourself by putting a needle in and ask the patient to phonate, and then perhaps the patient tries to phonate very much, and then the activity goes up, but because the needle is moving through the denervated muscle and causing more pathological spontaneous activity. So you really have to, in that case, wait a little till it gets less and less activity, and then you realize, okay, it's not a full interference patterns, but it's really tuck, 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 tuck. There are several pathological spontaneous activity. So it's really sometimes, it can be a little bit tricky to differentiate it. But if you see a little bit of activity like here, it's very easy. But if it's really a lot of activities and it's get mixed.
And sometimes people also think about the size. I mean, theoretically, if you're in the same position with the needle to the signal generation, then of course the pathological spontaneous activity, which are action potentials from individual muscle fibers, are smaller than motor units potentially. But because the size of the motor unit is a combined signal of all the muscle fibers, contributing to that action potential. But of course, if you're a bit further away from a motor unit, it can look the same size as spontaneous activity. So the size does not always guide you towards is this a motor unit versus a fibrillation or positive sharp waves, which is
that's sometimes in the literature that they say it's so much difference from the size, but in the larynx it isn't.
You can be, and then the other thing that happens, of course, if you like, for instance, you see sometimes in the facial muscles. Where if you look at that, let's say a year later, and there has been no reinnervation, the spontaneous activity becomes really, really small, because of course the muscle fibers atrophy and the action potential that you're recording is related to the size of the membrane. And if the muscle fibers shrunk, then your action potential becomes also small. So sometimes you have these tiny little response, and then I mean, so there is a size kind of contribution to recognizing what is the signal, but you cannot take pure size on this is a motor unit versus spontaneous activity.
Officially, this size depends on your machine and your needle. So you need standard values from your machine, and of course, no one has standard values from his larynx, because we don't do so many larynx EMG from the healthy side to get a standardization. What would be officially necessary to say some quantitative thing?
Freshly innovated muscle.
So don't measure too much. It's
Let's go for we always say, because sometimes patient, you only have one chance before they're going to start fainting on you. So we always go for the bad side first. So in case if anything goes wrong, you have answer. Although it's good to have both sides to compare, to have a healthy side, but we always go for the bad side first. And if that's okay, then you get the second side, which is normal one. Do you do the same? Or do you do the other way?
Normally if there's little movement or no movement, I often start on the healthy side to be sure that I'm on the right level and that I know the angle to get into the muscle, because then I know insertion activity and volunteer activity on a healthy muscle, and then hopefully go to the other side. But you are right, if the patient gets pale before I just showing him the needle, then sometimes I go directly and say, okay, I only get one shot in that case, directly go to get an answer, and don't be the safe way or the long way with both sides. But it's really, officially, I would try to get to a standard, but because of the patients, sometimes it's necessary not to do the full assessment with get a full picture, but with the most urgent question first. And then you make mistakes if you do it different. So it's Gerhard, what is your way? Most of our patients are pretty brave, huh? They tolerate most of the.
So we often only do the disease side, to limit, and rather do a few more muscles on the disease side, but there's limits to what the patients can take. Especially if you want to examine the patient, let's say half a year later, again, you shouldn't overdo it the first time. So, but if you're a beginner, I think that doing the healthy muscle first is a good orientation. So for instance, if the muscle is almost dead, as a beginner, you will feel uncertain. Am I in the muscle? Am I where I want to be? So if you have the orientation from the first side, that helps you on the diseased side. Because with a strange signal, it's maybe very confusing.
Well, Gerd, does that always help? Because I get the impression that when you have sort of atrophy or when you have, you know, an abnormal side, that sometimes it's not, that the muscle also might not be in the same level, that you actually might need a slightly different
Especially
angle.
if the paralyzed vocal fold is standing very lateral, then it can be quite challenging actually to hit a TA.
So does it actually always help you is what I'm trying to ask.
Not always.
Not always, no, yeah.
I mean, you're not orientating in a sub-millimeter range from the healthy side, yeah? It's just, yeah,
to get a feel.
Just to get the basic feel, whether you actually hit the thyroid, cricothyroid membrane. So some beginners even miss the cricothyroid membrane and try to measure the trachea, which doesn't offer much signal, yeah? So, yeah.
In series, it could also rewire in a very different shapes, in all shapes, because it's random. So if you want to be sure that your needle is at the right position by the maneuver and the rewiring is by random, it could be that the maneuvers are just the opposite. And then you have to be sure what is, or have to decide, is my anatomic skill so wrong, or is the rewiring just so wrong? So it's really, you end in a place where you would like to confirm the position of your needle by something different than, you're palpating the larynx. What could be an alternative? So you put your needle in, you're pretty sure that you're in the TA, but the activity looks like the PCA. So could be that you are completely wrong, unlikely in that constellation. Could be a synkinetic reinnervation. How do you double check? Ultrasound would be a possibility, or checking from above, or turning the needle that it's not banded. But sometimes it's nice to have something to double check, to have something to get more secure signal in it. But in such a case, if it's randomly, then it's pretty easy, because you get activity by phonation and you get activity by sniffing. And so you know this is, you don't see in a healthy muscle, but only in a reinnervated one. And that fits to this pattern, green and blue at the same time, being by reinnervation mixed. And that's, okay, then you can trust your anatomic skills and say, okay, it feels like being in the TA muscle from the angle and from the depth of the needle, and from the activity fits to synkinetic reinnervation activity when opening and when phonating. And so you can say, okay, this is a synkinetic reinnervated larynx. And for the PCA, the same would be possible, and the signal would look pretty much the same. And again, you can go from one needle EMG to one needle EMG plus chest belt and microphone, and then it would look like these. Phonation activity here, and the muscle is PCA, and that's wrong. And here you also see by phonation a little bit movement of the chest belt, and here by the sniff maneuver, a little bit sound, strong chest movement, and also EMG. And the EMG is pretty similar in the different maneuvers. And here in this long, you can very nice compare it. It's difficult to count it, to say how many milliamps it is or how many fibers there are, but just by rule of the thumb, you can say it's similar. And it shouldn't be similar, because it's opposite maneuvers. So one should be stronger than the other, depends on your needle. Okay. So that's the reason why we ask you not to do it only once, but perhaps 3 times, that you are really sure that the maneuver is fully done or normally done. That sometimes if you go in and ask for only the patient just gets into it. And if you ask them 3 times, do then you can compare this on and off, and then 3 sniffs with a little bit pause, and then you have something to think about or to analyze, and to also, if the patient coughs in between, you can exclude one task. And yeah, but again, if the patient is very nervous, often you don't get to 3 repetitions from all maneuvers. Good, and that's the last thing. Agonistic, antagonistic maneuvers in the larynx. And then you can say something about, is it synkinetic, reinnervated, how strong is the activity in the one, and how strong is it in the other. So under our website, lemg.org, you find a sheet, and I can also send it to you by email. It's a Word document. It's not easy, but it's at least a one-pager, and they can make a lot of cross to if you do all muscles on all sides and want to create it in all things we have talked to you in the last 2 hours, you could fit all in here and do great papers with it. Thanks for your time. You're a little bit faster than expected. Fast learners. Questions before having a bio break? The weather is so nice, I would recommend you to go outside for a few minutes. So the food hasn't arrived yet, so we are still very good in time. So we get some water, we get some coffee organized, but it ask them to come a little bit earlier. But first we go once down, show you the beautiful garden, and yes, yeah. Yes, please. That's also a good idea. Yeah.
Without presentation. So hello again, also from my side. We together organize this workshop annually, and we are happy that you are here, find a way to Jena. And so after this morning, I guess you have an idea from what LEMG can give us additional information. So we learned from the courses before that if we discuss patient cases into detail and look on the live EMG of this patient, and all the experts have different opinions, so it's a little bit strange for the participants. So that's why we started to give this basic introduction additionally. And after the break, we start with practical guidance. So we will have a master place together with Doreen. We will show you how we stick the needle in. We give you some theoretical information. You can use the time here. There are the directions of the needles to the different muscles of the larynx. And we want to give you a short introduction how to stick the needle in the TA, the PCA, and the CT muscle. So, and because as we started, so you're a little bit afraid what's happened with the needles. So we start with the forearm. This is not really painful. You can see that. And you can derive your first own EMG on the forearm. And then if you have this experience, we start with a larynx muscle, and it's up to you to decide if you try to stick a needle on each other. And then if you have enough experience with this muscle, we start to the next. So we have these 3 muscles. So, and we have 2 hours for that. This is after the lunch break. And after that, the highlight of our meeting this year will be a discussion of what information we can derive from the visual point of view and what from the EMG. There are different informations, or go they on the same directions? And we assembled 6 cases. And we start in showing you, without many information about the patient, the laryngoscopy. And our main speaker, I welcome James V. Thomas from Oregon, will explain you what he is able to see, and I promise you he will see more than you. So, and you learn something, how to add some points to your laryngologic examination, laryngoscopic examination. And then we start with Gerd, and he explained the EMG of this same patient we derived on the pathologic side. And we discuss what information this EMG add or not. And after that, we explain the case, what was really happened with the patient and what we have done. And then we start with the next. And if you help us, so we stay in time, it will take around 2 hours. And then we are free for an evening event.
In the Noll, that's a restaurant in downtown, directly next to the marketplace. We can go there together if you want, or I can show you the location. It's put in a slide later on. There will be an evening event, and there's a list. And please, you already have paid for it, so you can, even if you decide later you don't want to come, you are feel free to put your signature there. The other way around, our administration is always stressed if there are more food than paid than people who have signed. I think we made a private party visit, so yeah, I need your signatures for it. So we just realized that the food for today was not ordered, so I not ordered at all. So we have only food ordered for tomorrow. It's a 2-day course, and it's since 12 years, and the first time that someone cut our budget to only 1 day. And but there's some places around where we can get some food. So I would recommend that we all get a Thuringian sausage together. So it's just over the street. Yeah, but we have to tell him that we are coming and that he had to prepare a lot of them. Who needs different stuff than pig sausages? Because it's not vegetarian, it's not halal. There are other shops we can go on, but it's, yeah. The first is the closest thing would be this one. So you need something different. Yeah, don't worry about it. Yeah. Yeah, there's also some bakery stores, and we can do a small sightseeing round and try to get food for all of you. Sorry for the very short notice inconvenience. Coffee and water and juice will be outside, but yeah, just warm food isn't ordered yet, or hasn't arrived yet. Very surprising, always something new.
Yeah. And sorry for that. Yeah.
Okay.
And a small outlook for tomorrow. Tomorrow morning, we met each other here in this room. I give you some information about your behavior with the living animals, and then we divide in 4 groups. You can pick after the lunch. I put your badges here with your name. There is a color, and with this color you are correlated to a group. And you need that for tomorrow, that we have a circulation from place to place. You find in the program the content. So what we promise is that you can see a real EMG on the living animal. You learn how to electrical stimulate muscle activity to open up the vocal folds with the ECA cap we explained today. And we have a place where you can stick in the PCA muscle also for electrical stimulation to open up the glottal gap, like in the laryngeal pacing. And we have a fourth place where we dissect the larynx, and we are happy that Shiying from London and Floyd from Vienna will tutor that. They explain you how you can find the nerves, how you can inject for augmentation, how you can place a window on the thyroid cartilage for thyroplastic for good results in thyroplastic and so on. So these 4 places, and you change over these places. And during the morning, hopefully we have also some sun. We have, like in this year, a photograph of the team outside. Yeah. So sorry that there is no food prepared, but we take the time and use the benefit from this situation to see a little bit around. See you later.
No, we'll see.
Ja, gut arrived.
The Weine getreut.
Diesmal war Zimmer reserviert.
Ja.
Okay.
Okay. That's here. Very good.
Thank you for coming again.
Not at all. I was just saying to Doreen, I felt bad that, you know, I haven't got time, but then I love it.
James stays London here, so we have nice tours.
Your clinic, I saw.
Yeah, also patients together.
Lovely.
Yeah, you know. Yeah, she has a lot of first treatment works now 5 days.
Ja.
That's where you get sick.
Also der eine Mobil gehabt. Ja.
Macht's langsam Fortschritt.
Also langsam schon Fortschritt, ja.
Ja, bei dem Webinar waren ja so viele nicht. War nicht schlecht, aber viel war es jetzt auch nicht.
Ja.
Es gibt immer noch viele welche.
Aber dieses Jahr haben wieder mehr Kliniken die Luft ernst als letztes Jahr. Ja.
Das haben wir ja auch nochmal deutlich gemacht. Ja, mit dem geht ja der Preis keine Rolle. Ja. Und sonst bist du noch viel unterwegs?
Ja, immer noch viel.
Macht es in anderen Ländern?
Ja, also in Südostasien, da geht es eigentlich und so weiter, also vor allem in Malaysia. Da haben wir ein Investment vor allem für Beamte. Darunter zählen dann noch medizinisches Personal, Häuser und so weiter. Genau, ja. Und nächstes Jahr haben wir dann Japan. Ja. Und von unserer klinischen Studie finden nur mehr 2 Patienten. Ja, also langsam auch in den Sicht gehen.
Habt ihr das nicht noch so weit auf den Bock oder
aufgegeben? Nein. Ja, also wir haben jetzt im Stadt Cliffhanger haben wir dann jetzt noch 3 weitere Kliniken dazu gefolgt. Ja.
Sonst wird es nicht.
Ja, sonst wird es nicht. Weil Berlin ist mehr oder weniger also schon kurz vor Retirement. Ja.
Kostet natürlich eine Menge Geld. Der Markt ist so.
Ja.
Ja, dann das Essen kriegen.
You don't know, I think so when we see it, and then we can see, but it's interesting, not because we did session. You know how it's moved a little bit, right? But when you're still in the team, but that obviously the territory. That's why you couldn't come to us here and be something that you see it if you just come back and see it. You would be like, it's a work that, yeah, but actually there are areas we move along the TA and they actually not looking. So I think that would be very useful for all of us to also see where we are. I don't really know what anybody No, because I think actually you can help with the law. So
So I want to welcome also our online participants. We hope to get the feedback down. So we have, to my knowledge, 11 online visitors to the course and 24 here live in Jena. So we want to start with the 2025 course with our main topic, of course, neurolaryngology. And there is a focus this year on visual laryngology, laryngoscopy versus EMG. So what we see with the laryngoscope and what we see with the EMG. And if we look at the history of this course, So then you see here the local faculty with the team of Jena with Fabian Burk, you learned knowing this morning, and Professor Orlando Guntinas-Lichius, the head of the university department here in Jena, and my team in Gera with Gerhard Förster, Kathleen Klinge, and Fabian Burk. And we are happy to have a really distinguished faculty today. So with our guest speaker, James Thomas from Oregon, with the longest distance to us. And yeah, and then we have with Berit Schneider-Stickler, very experienced neurolaryngologist from Vienna, and with her colleague Matthias Leonhard, and Guan-Min Ho from Vienna and Taiwan, the inventor of the voice implant, will also join us, especially tomorrow during the hands-on courses. And we are happy to have again Shiying from London here and Doreen from London, who gave us this morning some basic instruction to the EMG, and Shiying will join us during the course and also during the hands-on tomorrow. So why we do that, I can say that we are really experienced in trachea and laryngeal surgery. I have a strong interest in laryngeal topics since decades, and we came together, the majority of our faculty, with interest to the laryngeal pacing program. And this course starts early as some experimental course to learn how laryngeal pacing could work on living animals. And then we start in 2011 with these courses, some publications of us. You see, we had a lot of distinguished guests like David Seeler, the pioneer of the laryngeal pacing, and also Klaus Bergmann from Berlin. And we had a variety of experts from neurologics over the inventor of the synkinesis, Roger Crumley, and of course our friends from London, Jacopo. We had Jonas Heidmann from Sweden about nimotipine, and a lot of guests. And this year we are happy to focus on what we can see in visual laryngoscopy versus EMG. So these are the guests of the last years, and this year's you see this spread out over the world. And so you are now at the end of the lunch break, and we start now with the practical course. So it's up to you how practical you do it. We will start with a short introduction of some anatomical guidelines, how to find the right point on the skin of the neck to stick the needle in, how to direct the needle to a certain laryngeal muscle. You will have the instructions right after my talk. And then we want to go step by step to have a master demonstration place. So usually in the last year's ongoing topic, I sit here, but if there is a volunteer who would like to feel how the needle is sticked in, you are welcome to do that instead of mine. And then we split us in small groups, and you have guidance on these places, and up to you, you can stick the needle in the forearm, or you can also try the real laryngeal muscles. So after this, we have a break, and then we start with our online transmitted presentations about visual laryngoscopy and about EMG, about electrical test simulation of the larynx. And then we have a case discussion, pro and cons, these methods, what they help us during examination of a patient. And hopefully we can sum up at around 7 this evening. So let's start. And I would like to invite Fabian to introduce the practical laryngeal EMG course.
Again, hope you got some food, even it was a little bit short notice and improvised. As Andreas already mentioned, we can split up the groups, and getting from a course that was very much talking and discussing, we try to get more hands-on also in the first day. And this is something we started 2 years ago, that we were not meeting in a lecture hall, but meeting here and having the possibility to get short talks and then split up into 1, 2, 3 EMG machines and number 4. And the idea is to talk for a few minutes about what we do in the larynx, and then ask someone, and if no one volunteers, Andreas will do, if Gerhard can put a needle in, then we all of us see it, and then we can split up and do an EMG of the forearm or of a facial muscle, up to you. So you don't have to do anything. And if you are really afraid of putting the needle to the skin, just put it on your tongue. You also get a very nice activity, but it's less than drawing blood. It's really not very hard. Then we come back. Then we get a second talk from Gerhard Förster, how to get to the PCA muscle. And then again, we can split up, and there are 2 places where we can do PCA EMG on each other, not very likely, or on rubber models, silicon models. So there's 2 silicon models. So you get a first idea how to get it in. So it's not 4 places, but only 2 places who are running. But anyway, we have to rotate a little bit and to get a first feeling. And if you don't make it immediately, you can do it in the next break. And then the last thing, that we will get together, discuss the stuff, and then finish this practical part and sleep over it. And tomorrow we can do the same stuff downstairs with alive animals who don't have to volunteer. And there you can put needles in, you can stimulate, and you can go into the direction of pacing. I missed one talk, but this is in the afternoon. There's also a little bit going direction of stimulation and pacing, and there's something in between, just very new stimulation of the larynx as a diagnostic tool. And Matthias Leonhard will give us a talk what is already available, and in the future will help us to diagnostic for pacing, but at the moment already helps us for diagnostic for perhaps renovation surgery. Okay. First talk from Matthias and Berit, but I think Berit will start with a TA, and please come on stage. You are already connected to your cables, I think. You have a microphone? Yes. Black on black. Great. So as mentioned, the microphones are only for the Zoomies, but we have some. The talk is so nice. Ich muss den zweiten Bildschirm noch zum Laufen bekommen. Gucken, warum der nicht. Weg.
So, very warm welcome also from my side. Thank you for this very nice introduction. And it is a great pleasure to be here again in Jena. I think it is almost like a big family of neurolaryngology. So it is great that you will join this family in future as well. So wonderful that you are here. Thank you. Maybe just the first question that I can know what you already have done. Who performed the EMG already in your departments? You have experiences? Okay, okay, good. I would like to start with a very short comment on when do you perform the laryngeal EMG. And in our working group in Vienna, we always consider the time course of a nerval damage. In the past, we sometimes performed the EMG only to identify synkinesis. That means earliest after 4 months, because we had to learn that it is not so easy to give a prognosis. On the other hand, and this maybe you will hear also from Klaus Potocznik, on the other hand, you want to know, do you have a damage, a complete damage, or is there maybe partial innervation left? And maybe you see pathologic spontaneous activity. That's why we consider the time course, what we differentiate in acute, intermediate phase, and chronic. In the literature, sometimes the time windows can vary. So we consider 2 weeks earliest time for the acute phase and then follow up. Then a little variation to define the intermediate phase. And usually after 4 to 5 months of a duration of a paralysis, we call it chronic paralysis. What do we want to know? We want to know, is there still partial innervation? Is there a re-innervation going on? Is there maybe a synkinetic re-innervation? What type of synkinesis? That's why we perform the EMG several times during the time course of the paralysis. I have heard that you learned about the anatomy this morning a little bit, and of course from the intrinsic laryngeal muscles. Oh, gee, only good.
They know nothing about that. Well, I talk and nothing about that.
You mean here are only audiologists? So what is important for us to know, you have to develop a 3D style of imagination where you can find the muscles. If you see the muscle, then the EMG is easy. The problem what we have is that all our muscles are hidden somewhere behind cartilages, behind soft tissue. And so you have to have the imagination of a picture. Where do you have to insert and guide the needle? The CT, the cricothyroides, it's easy because you can palpate the cartilages. And again, don't go directly in midline because there's no muscle. You have to go a little bit to left or right to find the bodies of the muscle. And then usually if you go a little bit more to the side, you can expect the fibers of the LCA. These are maybe not the most important muscles, but they are important even to understand in synkinesis, especially the LCA. The most important muscles are the TA, of course, and the PCA. I would say the TA is quite easy. As soon as you realize if you take the height of the cartilage, of the thyroid, then you know that the vocal folds are in the middle. And again, is somebody doing thyroplasty? Type 1? Good. Then you learned that you should not take a horizontal line from the midpoint of the midline. Sometimes you have to palpate the lower rim of the thyroid. So it can be that the line for the TA is not straight, maybe a little bit downwards. So try to palpate the larynx first Sometimes, like here, you can see, wait and see. Sometimes you can see here's a superior notch of the thyroid cartilage. Then it is easy. You can also palpate the lower rim of the thyroid and then try to understand where is the posterior rim of the thyroid to understand the dimension of the cartilage. Female and male are different. Sizing, angle, and this you have to consider by guiding your needle. My task is to tell you something about the anterior approach. So we do most of our TA EMGs by entering the TA muscle through the median cricothyroid ligament. We usually, and in almost all patients, we perform a local anesthesia in preparation to avoid pain and to reduce the coughing and to even make the feeling better for the patients. You can use xylocaine or prilocaine, lidocaine. It just depends what you use in your departments. Don't take too much. I usually take just 1 milliliter. If you take more than 2, then it's hard to palpate the membrane. Yeah, so just use maybe 1 milliliter of your local anesthesia. And then you need to insert the needle at first, straight. And as soon as, this is still on the next picture, as soon as you feel the inner part of the thyroid, then I turn the needle up. First go in 90-degree horizontal and then straight up, left or right. You can always do it from the median line. This is really hard with the pointer. There it is. Yeah, you can come from midline, but then you have to turn the needle more to left or right, or you'd come from the paramedian approach, a little bit 5 millimeters right or left to the median line, and then you can go up straight. There's a wonderful publication by the working group around Fabian, and he introduced here the muscles. If you come from the anterior approach, then again, either from the midline and you turn to left or right, or you go paramedian and then you can go straight up to the muscle. I guess that we will have tomorrow the availability to do the insertion of the needle in a fresh frozen larynx of a pig. Pig is a bit different, of course, shape and size of the cartilages and the muscles, but you can try about the angles you can put the needle up and so to see where you are. What we learned, if you don't go straight up, you may be in the ACA muscle. And ACA and TA have different tasks in the phonation maneuvers. So sometimes you see at the end of when you ask the patient as an agonistic maneuver for the TA to phonate an A, and sometimes you see at the very end a very intense signal, a very dense signal. We assume that we then are closer to the ACA fibers than the TA fibers. We preferred to ask for an A because if you ask for an E, what you are used from the stroboscopy, you have a stronger elevation of the larynx, and this might cause a dislocation of your needle tip. So we try to reduce the movement in the larynx as much as possible. So we use an A. And if you go to the literature, it is always difficult to identify what is normal, because very often we get the question, what signal is normal for TA, what signal is normal for CT or PCA? What you should do is to ask the patient to phonate as loud as possible so that we can really test the maximum activity of the muscle. And then we can calculate even the turns per second, so the density. I had this with our working group many years ago. We recorded signals and discussed them here during the course. And Klaus always mentioned, this is not dense. It was a healthy muscle. And I told him, it is a normal healthy muscle. No, it's not dense. And he was right. And this is what I learned at my beginning. If you do not ask for maximum loudness, you get not a dense signal. Yeah, so this can be that you have a moderate reduced signal then. If you just ask for, say, yeah, this is not maximum activity then. And of course, you have to ask for the antagonistic maneuver. I don't need to tell you what is the antagonistic. Sniffing. But don't do it too strong, because here we also learned if you make most patients hold the breath. And how you can hold the breath? You close the vocal cords. You have again activity. And this gives you the wrong information on synkinesis. Yeah, do it moderately. So here's again the publication, what I already mentioned. More in detailed, more detailed, how you should go in with your needle. Of course, these are recommendations. The numbers are recommendations. Every larynx is slightly different to the other, so you have to find out the proportion of the larynx. I'm sorry, it does not work. Yeah, so, and it is not always so easy. I showed you the picture of this young man here. This is very easy to know where is the anatomy of the thyroid and where is my expected TA muscle. But in the elder people, in the older people, in the elderlies, you see that the skin line can be different. And also here, you have to consider to adapt the insertion position and angle of the needles. Just an example of the transcutaneous approach. So you see that we inserted the needle here.
Schön laut.
One mistake in this demonstration here from my side. I hold the needle, and if I hold the needle and I move a little bit, you can create insertion activity.
Okay.
Try to hold it very, very strong in position. The best is that you insert the needle and don't touch it anymore and let it like it is, and then ask for the maneuvers. Sometimes you have to slightly support the needle that it does not dislocate by elevating the larynx if the patient is doing the maneuvers very strongly. And you can perform such a transcutaneous EMG. I have an echo, I like it. Also in the tracheostomized patients. Yeah, you see here. You see here the tracheostomy, and usually if the tracheostomy is performed in the right way, then it is 2 to 3 tracheal cartilages below the cricoid. So you can palpate the cricothyroid membrane above the tracheostomy. It is sometimes a bit difficult if there are scarring processes which maybe cover the membrane and you cannot enter easily. But usually you can do the EMG also in the tracheostomized patients. And this is what I want to tell you here at the beginning of the practical course.
Thank you very much. So, any volunteers for doing it? I think I would start again, not directly the larynx muscles, but again in the arm. We have seen it this morning, but I think it's worth to start slow. If you are really want to come, that would be great. And Gerhard or Doreen, and both of you close by. I will give you a microphone so that you can comment on it, what you are doing. Whoop. That can be put. Yeah. And I always tell my students, try to sit if you do something in a standing position. So we are a little bit more people now, but mostly lecturers, they know what we do. So you're allowed again to come close and look over our shoulders to see how the setting works. Before you do anything, shall we ask them what to do first? Because we already did it. So we can see one, talk through one, and then. So what do we first? So get the patient in a sitting position, get the doctor in a good sitting position, and then tell him what is going on. Don't tell him too much details. Grounding is important. Yeah. So
should we do the full cabling then? Yeah.
We could do, yeah. Let's do it once for the full cabling, the scientific support with a chest belt and the, yes, it will help you.
Okay.
To get it.
Leg du da mal an, dann sage ich ihm, was wir jetzt machen. Ja?
Then you have to.
So, I'm Gerhard.
Yeah.
Where from? Belgium. Okay. So, we are wiring you up now with a chest belt.
Oh.
For recording your breathing. And do we have a nose thermistor as well?
We will also have one, but I think one is fine.
One is enough. Yeah. So whenever you breathe in, your chest expands. We can see afterwards what maneuvers we've done. And there's a microphone here that will record the sound.
So
breathe in and out.
Movements. So in contrast to the British guys, it looks very nice here, and it's not too stiff, isn't it?
It's okay. Yeah.
So here, inhalating up, down. So, and the other thing, microphone, on and off. Just the arm. Okay, we have some microphone signal in here also. So if he says we should see it. If he sniffs, we should see it. Please sniff. Okay.
50 Hertz filter ist ein, ne?
Oops, yes.
So what we see now is the 50 Hertz from the electric noise in the room there. The less noise there is in the room, the flatter this line will be, but we know this is not a signal. It's electric noise. Yeah?
Such a nice microphone, what is catching up the whole room. You can also try with the snoring microphones. So you know them perhaps from the sleep labs.
The snoring microphone has the advantage that it fits directly into the preamplifier.
But it has to be attached to the close to the larynx because it's only recording the vibration of the body. It's only getting a pure signal. This one's a little bit nicer to get a full signal.
So I will do some disinfecting first. Yeah. So
one bottle up.
Yeah. So usually we use verbal anesthesia, so keep on talking to the patient all the time, yeah? So, and we would do the local anesthesia first. You can do TA without local anesthesia, because ideally you're not penetrating the mucous membrane, which makes a cough, yeah? So, but for the PCA, which we are not doing to you now, but we have 3 phantoms to test that, so everyone can have a go.
Shall we start even slow with the hand, or?
Oh, we want to start with the hand first.
No, we have the time, and I think we've done it once this morning, but I think repetition is nice.
Okay.
Start perhaps here or here.
So you are lucky. We switch targets.
Can do 2 in one.
Okay.
Because we have more times. So for the technical stuff, I don't want to put a needle in here and then tell you, oh, we forgot to make to ground the patient. This is better to do Yeah, I will also not do it.
You have
because
not
it will
grounded
never-
him.
Yes, I know. So now I can give him the ground cable, but it's drying, so it will not work. It's completely dry. It was wet this morning, but now it's drying. So this ground cable would be a mistake. We would connect him, but it wouldn't work. So we could put it into water, or we could spray some alcohol on it, which also works.
Yeah.
Okay. Or we have to send someone else to do it. Great. So middle part should go to the patient, and if you just do it in a spiral way, get a lot of contact. And for the other places later on, we don't have these ones, but can you give me the big one? This one, okay, thank you. So here are stickers. We can put stickers somewhere, and these stickers work fit very well here. But we have only one box with 20 stickers, and we are more people. So please perhaps reuse it. So you can put the stickers back on it, and yeah, so that everyone has a fun to get a good ground signal. And we have only 20 in total. All this reusable one, but only one reusable. So then we check the signal. So there is some noise on it. We can unmute it. It's not so bad. It's fine. Now we want to know if the wires are alive. Oops. Sounds not so bad. So there seems to be a signal, and if you touch them, perhaps the signals get even better. Yep. Yeah, so not bad. Microphone, they are. Great. And yeah, movement of the light. That sounds good. Now you can choose your needle.
Oh.
There's big ones and small ones. First,
Since we only do oh, so they're really small. Is there something in between?
Natos was giving us the small ones because they're saying that no one is afraid of it. The small ones work, don't worry. Ja, wir passen den vom Anschluss.
Was?
Nimm doch die schmale kleine. It's okay to take a small one. No one laughs if you use a small one. So now be careful for taking it out if you have the right cable. That's the thing. Gerhard brought some needles, I brought some needles. It's really dangerous that you choose needles that don't fit. But these ones snip in together very nice. Now it gets a little bit more noisy. But if you touch them, with your hand, with your arm, always with your hand, that's fine enough. It's funny, even if it has gloves, a lot of electric smog gets out. It's really, don't touch them. Back. Cool, huh? But really do it always. If I do every Tuesday 10 patients, and I always check it, because it's so stupid if you're in and then realize, damn, it was not wet, or it was not connected, or so it's always checks these things, get in a routine. It's so fast. Just touch the patient, perhaps tell the patient why you touch them, and then but then if the lines are changing, then go on. But if it's not changing the noise, then perhaps the loudspeaker is not loud enough, or the cables are not right. So it's really getting this routine. Good. Then a piece of cotton, you have it close by. Because if the patient is starting to bleed. What was happening now? What was this funny noise? Very easy. What has he done at the same moment? He was opening a plastic pack.
Okay. Yeah.
This was creating a lot of electricity. It's like putting your pullover over your head and creating sparks. So this was the EMG machine was recording this event of plastic being ripped into two parts. It's causing nice electricity. So it's really sensitive. It's a nice toy. You can have a lot of fun with it. One is for the patient, and a second one for you. So you have your hands free, and if one falls down, the patient can still stop the bleeding. And I always tell them, if it hurts, you can throw with a cotton ball to them. Just to disturb them, just to,
Yeah.
as you mentioned, to so they start thinking about it and then forget. And I'm already ready with my procedures. Okay, I turn the microphone on again.
So we just go into the radial group, yeah. And it's like acupuncture.
Insertion activity. You've heard it, so he was not only getting through the skin, but directly into the muscle.
Feels strange, yeah.
Feel it.
Yeah. And if I move the needle, you get some brief activity, but it vanishes after less than 150 milliseconds. Yeah.
And now you can activate perhaps the muscle.
So, and now try to tense your fist or push against my hand. Try to increase the pressure slowly. So he's recruiting more and more motor units. That's what in the end recruitment means, yeah? If you increase the force, you are recruiting additional motor units until you have full recruitment where you can't see the baseline at all.
Sounds a little bit like pathologic spontaneous activity. But not, yeah? It's a little bit arrhythmic already, but it was for a few seconds, it was dot, dot, dot. It's not, yeah? It gets out of, yeah. You can't do it in a perfect way. So you can't fake pathologic spontaneous activity, you can't.
To be able to see it, it should not be in full recrusion, yeah? In full recrusion, you can't see the pathologic spontaneous activity. It won't be there, but you can't see it either. So you have to examine in a relaxed state, which means in case for the PCA that you have to make them phonate, which would be the situation when the muscle would sit quiet and then the baseline is uncovered, yeah? So take the needle out.
Also, well, any questions?
Do we go for?
So normally you have to put the mute button, but in this case, the environment is so nice that it's not getting too loud. Perhaps you find a sticker. Sink in one of the drawers in the first, yeah. Oh, you hold your finger on it.
Ja, gleich noch machen.
Up to you. Man
muss dran lassen.
Yeah.
Oh.
Just do it.
Oh, so that you won't, so that you don't bleed to death.
Thank you. If this is okay for you. Yeah.
Yeah. So it's really a tiny needle. Yeah. So you hardly feel it. Yeah. So usually you would have done the local anesthesia. You can numb the skin a bit, which takes off some burden, and then you spray the rest to the subglottic lumen, yeah, in short squirts, and then you make the patient cough at the same time, which will distribute it, and then you numb the larynx so that you can touch the mucous membranes for the PCA EMG, yeah, where you penetrate the mucous membranes and where you penetrate the cartilage, yeah. So you start with palpation. So in him it's easy, yeah. So in case you're not so sure, you first identify the Adam's apple, and then you slide down from the Adam's apple, and the hard bit that you find there, that's the anterior part of the cricoid arch. And so in between, there's the cricothyroid notch, yeah, with the cricothyroid membrane, and that's your target structure, yeah. And depending on the stiffness of the needle, it might be difficult to bend the needle, if you're within the tissue, a thin needle will not follow your movement when you think you're going up, but your needle may continue in the direction you put it. Yeah, so sometimes, especially if there's a bit more tissue on top, it would be sometimes a good idea if you start to penetrate the skin slightly below, so that you hit your target on a more or less straight line. So, but sometimes if you are through the skin, then you can redirect, but you want to go up from if you are through the cricothyroid membrane, then the steeper you go up, the more sure you can be that you are actually in the TA. So I have a thin needle now, so which might not follow exactly the path. So I will start from slightly below, so enter the cricothyroid membrane and go straight up. So then it's always a good thing to leave him breathing quietly, yeah, not starting the maneuvers straight away, because once they've done the maneuvers, usually the patient cannot relax as much as he's relaxed now, yeah. So you watch quiet breathing first for a while, and then you start asking for the maneuvers. Can you phonate Oh, I slid out. Sorry. Sorry. I have to do it again. Sorry. Once more. Okay. Phonate A. This is wrong.
See his hands supporting the cable, but leaving the needle.
Can you do a loud Louder? And can you sniff? You never had anything done to your vocal folds? Weird. We are in the muscle, yeah, but from these maneuvers, we can't be sure where we are, yeah.
There are a lot of people in the room, a lot of social tension on him, so it's okay to have a little more activities than normal curves.
One last go, and then it will stop, yeah. Stronger? And the sniff? Okay, let's stop.
Without phonation.
Yes. But if he's,
Without phonation.
yeah, so if a person is tensed up, then this could be at times that way, but he didn't really seem too tensed up. So I would rather doubt my measurement. So actually, I am in doubt now. So, but we have to stop somewhere, yeah? So I wouldn't go on for half an hour, neither in him nor in a patient. So there are patients where you may not be able to find it, although it seems so easy, yeah? So I was pretty sure that I was at least close by, but from the signal, we can't be sure at all, yeah? Sorry.
How was it for you?
it was okay. I could feel the needle, but it was not really different than in the arm. And
yeah, so like taking blood, yeah. The needle, I usually keep saying to the patients that the needle is thinner than the blood sampling needle, yeah. Don't know how much that helps. So, but continuously talking or have someone else to talk to the patient, that helps a lot. So
step would be splitting up. Or questions?
You never put the people to lay down? It's always seated.
Some departments do, we don't. So, but we have a reclinable chair. So, and some patients that have the tendency to collapse, we would put them or half supine, yeah? So like 30 or 40 degree, depends on your preference. So I usually have them sitting, especially if I'm on my own, then it's easier to operate.
In the neurology departments, they normally lie down to get the patient more relaxed. So that's from that point of view, I think it's right. But in our setting, I think it's, we as ENTs are used to do it fast in the chair, also examination. And if you then ask the patient, oh, now we do something different where you have to lie down, I think that's already makes it a little bit more, why is it so painful? Why do I have to lie down? And again, it's a lot of calibration. If you start to do it in the sitting position, for me, it would be very complicated to do one in the lying position because my angles as a doctor would be completely different. So it's, yeah.
Whatever you're used to.
Yeah. Just get used to one setting and do it all or try to keep it as standardized as possible.
And women less often faint. So, yeah. Young male are dangerous.
There's a lot of muscles and a lot of tattoos.
Yeah.
And then they collapse. Yeah. One more question.
So, how that you are telling to maneuver more when you're going to midline? Did it make sense to go in a paramedian position?
Yes. Especially
because otherwise you have to angulate.
Especially if you do not use local anesthesia, then you should not go through the midline, because through the midline you will always penetrate the mucous membrane, which makes them cough. But
even like paramedian.
Yes.
Then directly.
Well, as I told you, you either have a stiff needle and you redirect the needle when you're through, or you start from slightly below to go straight up. The thinner your needle is, the less it will follow your maneuvers. It will just continue straight within the tissue. So you could aim on a straight path to your target. Yeah.
Shall we split up into 4 groups?
Yeah.
And try it. So
one group is staying here, and the other
group is Berit and it's going that room. There's a room around the corner, not upstairs. One group goes there. So 5 paying people in one group. And one group can stay here, and one group is going there. Tension, and so the breathing was so unimportant. Background that actually, if you're relaxed, why should you use much to patterns? It's not like throwing blood, it's different because it's a muscle movement. It's a different pain. Yeah, so keeps the setting. Don't change it. But get used to it so that the patient realize that you are used to jump around. So you can do it like let's get your badge. Warte, noch niemand gesagt, ja? Ja. Wir haben es schon mal versucht, aber wir haben es nicht hinbekommen, deswegen haben wir gedacht, bevor es etwas miteinander ritzen. Achso, But we have not very many, so please reuse them.
Reuse them.
Yeah.
Okay. This one.
Yeah, I think that they asked about in your room also. So.
Okay, sorry, I didn't see.
So maybe you do one.
And so in the first room we have green, so you can choose this one, the yellow ones.
Ach, du hast es einfach da abgestöpselt, ja. Ja, muss ich ja. Komme ich nicht ran. Der Eingang. Ja, aber dann haben es die Zoomies ja nicht, oder? Doch, das ist ja der Rückkanal.
Der ist Rückkanal, ja, stimmt, okay. Aber wir machen jetzt ruhig aus für ein paar Minuten, weil wir jetzt ja aufgeteilt sind in die Gruppen. Ja. In the future even bite piece of bread without blocking. So you can learn like this. So there's a biofeedback training. You can just put your finger on top and then learn. So you get relaxed and then differentiating upwards and downwards. Okay. Löst du dran?
Ja, also die Zoomies haben jetzt überhaupt nichts gesehen.
Okay.
Von dem ganzen
Okay, then we do it again.
Man hört dich jetzt im Raum quasi nicht, aber die sehen alles.
Ja, und die sehen den Blast. Okay. So for the Zoomies, I try to repeat some things here. So it's not useless to do this muscle. And the same, you can do it with a hollow needle. not the concentric one we do now, but with a hollow needle, and then you can do Botox in it. So if you're in the middle of the muscle and you know this muscle is restricting your smile because of this frozen face, synkinetic antagonistic DND evasion, you can put a lot of Botox in, and then you get beautiful smile, and you will have problems to talk and problems to brush your teeth without drooling. But on the pictures you show on the conferences, you can show hey, the smile is beautiful. Yeah? So it's really, it's always a question what you want to show. And as a plastic surgeon, it's nice to show good smiles. That's the rest of the function is not so good for saying, you need this muscle. But it's better to do it with Botox or with lidocaine and then go on with
reversible.
Yeah, with cutting it. So you know each
grounding?
other. Grounding, yeah.
By the way.
Or ask your beautiful nurse to help you.
Wow.
Nurse
or nurse. Okay. Is it wet enough?
Yeah, it was very.
Was still a little bit wet. Gerhard was very intense.
Yes. Seen it.
It doesn't have to be exactly.
No, just has to be some contact. Yeah.
So it doesn't have to be stiff or.
No, it should be a little bit loose. If the hand gets blue, it's too dense.
Why is it so long? I think ours is.
I don't know.
much shorter.
Perhaps for the body
Okay.
also. Yeah.
Okay. So, do we do it with the full?
No, I wouldn't. Also, if you want, you can do it.
Okay. We just need some.
That's a question. If you want to see it, we can do the chest belt and the microphone, but it's it's more a setting question how to get the devices, how to set it up, but how to put it around your chest. I think that's if you want to do it. Yeah.
Oh, let's do the right one.
So if the patient has a facial palsy, never spray directly in his face because he can't close his eyes. and even if he hasn't one, it's not nice because it's really
and it's burning in
yeah. And if you want, you can turn a little bit. You are anyway too far away from it. And if you turn your chair, because we are only a small group and you want to learn something and not only suffer. So it's a good idea so that you see the second line, the third line is useless. It's here. Only the first line is important. Shall we change to a one channel, perhaps? So now it becomes complicated. Test beenden. Nope, it's not a touchscreen. Old-fashioned. Can you perhaps your electrophysiologist first time? One up. Or ask your old electrophysiologist, experienced electrophysiologist to do it. Okay. Yeah, it's this one. Yeah. Yeah. I don't know, but looks good. Okay. So now you can put this button. And now the notch filter is out, so there should be more activity, but it doesn't change too much. Turn it on again. Strange, nothing at all. So, if you have a good room, you don't need it. If it's noisy, you want to get rid of this. Strange, that doesn't change anything, but it doesn't matter. If you touch her, oh, sorry, here's your cable. So if you touch her now,
oh, we have more.
Yeah, it already gets better because
oh, strange.
That's cool.
Oh, but cool.
Yeah. So it's now you can choose your needle, the smallest you want.
Yes.
It's a good option.
And we have still another problem.
First, you could show the largest one.
You are the lucky position of. Yeah. So we have a nice picture, but we have no noise. Why?
Because we're muted.
Great. Yeah. Good. And we hear something.
Yeah.
Good.
So.
And it fits together. Yeah, that's good.
Fits perfectly.
And here you have even a safe. That's something funny.
Yeah.
It's one of the most scientific stuff. You can put it here and then you can park your needle in this special made sterile thing. And if you don't miss it, if you miss it, you don't poke your fingers, and it's clean. So you can.
Oh, that's cool.
Oops, wrong. Yeah. So it's really an invention.
So recapping is allowed here.
Recapping is only allowed here because you're.
Okay.
Yeah. But if you miss it, you have to throw it away because it's unsterile.
Oh,
yeah.
True.
But actually, it's not bad. I put it that way. I've glued it here so that I can put it in and out. No,
this direction would be better.
Yeah, doesn't matter.
Okay.
So face.
Face.
Yeah. Don't touch it. Yeah. And touch her, yes, but don't touch the exact point where you put your needles because you're on tape. Oh. So you are in a muscle. So now lower your corner of the mouth. Look a little bit ugly. Exactly. Much less. So it's nice and crystal sharp. So you're really in the muscle. Yeah. If you are outside the muscle, it gets a little more dull. The activity gets more round. Perhaps if you retract it or push it forward, you can get. Actually, it's so nice. You should perhaps do some analysis here. You can get a little bit more loose. Yeah, hold it that way, and then she can turn her head and look at it. Yeah, and then you can. I try to hold it that way, that I'm connected with her.
Okay.
You have to be a little bit careful. No, not electrical, but just that my arm not gets.
Okay. It's just to have some
support.
Yeah. Support.
Yeah. So now try to get only one fiber firing. So 2 fibers are still firing. One more. So there's a big one and a small one. There's still a big and a small one, and perhaps try to get even less. Yes, now it's one, and there's already the second coming in, but 2 different motor units. Yeah? You see the big one and the small ones are a little bit perhaps green and red in that case, but no, she
is doing it.
She's going lower and lower. Yeah, she can. The needle is very stable because they look the same. If you push the needle forward, you change the orientation, and then the shape would change. Like with a ECG, if you would change the cables, it would flip.
I wouldn't be so relaxed.
Yeah, it's really good. So that's one activity, and there's this double shape. There's also somewhere a freezing button. I don't know where. Yeah, very crispy, very in the middle of the needle, in the middle of the muscle. Very nice.
The red, yeah.
No,
it's the same button.
Terminating the back and yeah. So here you also see the same, but 5 times. So you can go a little bit backwards and forwards and have a longer chance to understand it. So really very nice one muscle fiber. And now you can push it a little bit forward to see how the activity changed. And now we're perhaps out of the muscle.
Out of the muscle.
It is okay. Stay there. Okay. And now activate it again, the muscle. So now it's different. Now it's dull.
But we have still some readings.
You get something, but not from the middle of the muscle, but just outside, and you're looking back perhaps to the muscle. Yeah. And here everything a little bit filtered. It's a little bit. Yeah. But often you are only get that position. But there's also already another fiber. The small one, the sharp one. But the big muscle, the depressor anterioris, you're already through.
Cool. And you can
use activate it again. Okay. And relax it and smile. And smile should be the antagonistic maneuver. But anyway, for a smile, you need a little bit control. So it's always both. So it's not so
together.
But for a good smile, you need for Julia Roberts' smile, it's both. She's smiling like this. So it's upwards and downwards. So it's any other stupid ideas what we can do?
If anyone,
you can try to get back to the muscle to find the muscle, retract it a little bit. If you get the activity gets better, you can activate it a little bit. So it's easier for him. Okay. Now it's still a little bit dull. It's not perfectly sharp. It was better before. You activate it all the time, and he tries to get back in the middle of the activated muscle.
Activated.
Look at it. Yeah, now, yeah. Have you heard it?
Yeah.
The change from the close to the muscle, a little bit dull, in the middle of the muscle, crystal. That's also very nice to hear.
Do you
This.
look at the needle or
I hear it.
Yeah, it's easier to look at the needle and hear the sound getting.
Oh yeah, I just push the needle a bit forward and backward and look if the patient is still talking to me. And
Andrew Blythe in New York, he had some monitor. He only had a loudspeaker.
Okay.
Okay.
Hey, you really don't need it too much. It's nice to talk about it, but it really the difference is you hear more than put us. Yeah. Forgot about this.
Pressure for
a few
minutes.
Yeah, because it's not too much the skin. It's more you are in the middle of the muscle. You have penetrated the muscle. The muscle can get some bleedings, and if you don't stop it now, you will have a little bit bulb of blood in the middle of your muscle, and it will hurt for the next days. So really, stop. You are not. So don't run away too fast. So I'm a not very well trained nurse. Sorry. Okay, but it's good to get in, get cover. Thank you. Who wants next? Is there any more we need to do, or is it fine for the moment?
If anyone wants to do vocal follow-up.
You already had one. I'll be careful if you do too much, you get this repetitive discharge. So, like it's a PICS. Yeah.
No, I would volunteer.
Okay.
To be the patient, because I'd like to know what I'm doing to my patients. To be honest, if anyone wants to.
Do you want?
I have.
You've done them.
Yeah, all right. Let's guarantee nothing.
No mind.
We have a stretcher and we have a,
Yeah, you can save me if I start joking.
We keep it like this, or
I would keep it running like that to focus on the one line. If you want to do it for a scientific project, yeah. Actually, we could do the full setting because that's the reason we are here. Yeah. Can you try to change the machine from this test to another test? And test? Was hast du denn länger?
I think the end test. Yes.
Bei der Frauenhälfte.
And then
Steht hinten drauf, guck mal auf hier.
I think that will click.
Yeah, exactly. Now we have 3 channels.
37 mm.
Ist schön eigentlich, es reicht für ein TA. Ja. It's here oben. I like it better if it's up there.
Ich würde gerne einfach wissen, wie es sich anfühlt, wenn man das mal mit anderen Leuten macht.
Das finde ich auch richtig. Also das immer noch geht. No, das klingt gut. Yeah. Okay, it's moving. Here's the microphone. It's also running. You don't have. It's so sensitive. Yeah, you even get the activity here. That's a nice thing with this active microphone, but there's a battery in it. So the battery is running out of energy.
Someone was guiding me a little bit because I never did.
Here's Planet, I've heard.
Yeah.
No, he's working in Gera since 2 years now and got, I think, much more training. Have you disinfected the lungs? Not yet. Close your eyes. Yeah.
Would always make
Yeah, I would really recommend it. Then give him a
because it's myself.
But first, perhaps have a sure palpation where the yes.
I'll give one to him.
Yeah.
Then he can. Because it's good for the patient to hold it, and it's good for the patient to have it if you're out, because then you are as we have to do. It was very calm our whole thing, but at the end you were standing up, you were bleeding, and you were still cable, so it always gets interesting at the end. So do it slow.
different.
So in women, it's sometimes easier to go from the sternal notch upwards and then hit the cricoid. And yes, but here in men it's mostly easier to have the incisura and go down.
Do I have to check something before with the needle?
Yes, to turn the sound on. That's the point. And then touch him with your other arm.
Do I have to uncap it?
No. It's a great thing. Should already get better signal if you just touch him.
And better means more?
Less
noise.
Less noise. Yeah, that's right. It's working.
Untouch him?
Should we have the microphone?
Microphone is
working. But the large signal, what's that?
Yeah. That's the EMG. And if you touch them, it gets better.
Ah, okay.
I wouldn't make it too small, yeah. So that's the disadvantage now. There's a microphone and chest belt, but we don't want to see the signal. We were only interested in that one. So if you want, I can turn it on. When the microphone is flat, and then you can focus on this one. Because you are, this is for science, but if everyone talks, can we jump back to the one channel one?
How did you do it?
If you want, you can go to test beenden and go back to one channel EMG.
Yes.
As always, it's nice to have a lot, but it gets more complicated. You have so many decisions. So touch him again. Not good, but 100 perhaps. It's very fine. Kannst du mit dem Maustasten draufklicken.
Also kleiner.
Ich würde es hier größer machen, auf 400.
Ja.
Und da von der Zeit auf 100. Warum wieder das nicht? Den Stop Speed, also the speed, the gets newer, keep it to 100 high.
It shows 1 second.
Ja.
2,5.
Müssen wir es mal hier machen?
Das ist für die Kaskade.
Ja, aber vielleicht irgendwie zusammen. Seltsam.
Hä? Okay.
Also, so yeah, I don't know why, but it seems to be perhaps that they can't go too much. I like both more or less the same. But some people like this one faster and this one slower, because this is for the look back into the past. So it makes sense to have this slower to have a far look, but I like if they look similar on both and they have just the 5 repetitions. So I think that looks good. 100 for the whole and 100 for, I think it's only one. And the funny thing, it's not funny, it's really
annoying.
There was one company doing these numbers per square, and the other one was doing it for the whole screen. And now Natus bought both companies, and to do it right for everyone, you can choose in the settings which it is. And here in the room already, in 2 of the machines, it's one way and the other way around. So I think we really have to get adjusted to it, look at it and see, okay, I know in Germany it's 50 Hertz, so there should be 5 cycles if you get electronic noise. And that's really, or you have to go to the settings, it's really complicated to find out, have you crossed for, it's really, okay, but it looks good. I think from the speed looks as we are used to it.
Yeah.
Say it's better not to experiment with all these things. Better to get used to one setting every time. And
I would really recommend this 100 milliseconds or tenths of a seconds for one screen. Then the motor unit is still big enough, but you also see some motor units. And the other thing is from the size 100 or 200. That's nice for here and for the face. And then I would try to keep the setting. But if your neurologist says, I want something else, then it's okay. I would normally, I think for the needle EMGs, that's fine.
Okay. So did you do also already
Yeah.
disinfection? Okay.
But
Yeah.
Yes. Because it's already a long time ago.
If you want, you can
Yeah.
spray also your fingers.
Yes, spray your glove too, so that you can palpate again. And then, yeah.
Don't touch anything before.
Oben drauf. Das ist ein komisches Ding.
Yeah, okay.
Sorry. Yeah, you have to,
Not as
you have to read the manual before
And
getting it open.
does it matter which direction it's pointing?
No, I don't think so, no. So now palpate again. And be sure to identify the conical ligament, yes. And you can think of you go, which side do you want to do?
Right.
Right or left? Right, okay. Then you go paramedian right in and aim more or less for the ear.
The angle like this?
Yeah, like you would aim for the ear. So a little
Okay,
so
so
to the side and up.
Louder. They are.
There's something, but
Not bad.
say very loud. Perhaps a little bit. I mean, the needle is shorter than I'm used to, but perhaps a little bit more in.
Make it louder.
Yeah, there was some insertion. It sounded like insertion activity. Can I say something happens, but we also do not get microphone potential. So
Could be that it just slipped outside of the larynx.
yeah,
The
say No, you're not in the CT. Perhaps
touch the larynx a little bit and try to get anatomic information where you are and turn the needle a bit. Could it be that you slipped outside of the okay, inside a bit. Turn a little bit. Okay. Okay, yeah. Then retract a little bit and then go more down with the wanted to go steeper behind the larynx. If you are really in the right place and try to get directly deeper. Well, the bottom of the needle should be as flat as and then push it a bit up. Yeah, so that's better.
A little bit back again. So yeah,
there was
where this strong signal was. No, but I mean the needle is very short. I don't think that you're really. I think
I do a sniff. No, and the R again. And hold your breath. More activity.
But you think I'm not?
I mean, I can't really say because I think the needle is very short. So it also could be that it is still platysmal. No, not.
If you move
Feels deeper.
Yeah.
It feels deeper. Okay.
You have gloves and the gloves is still clean.
But it does not. The signal doesn't change when you phonate. You just sniff again.
Just less by sniffing. This gets more.
Yeah.
Say R again.
Painfully.
You have been in some point.
Right now, in the beginning.
Or
The beginning.
no, at your second try.
I mean, it's definitely a muscle.
Yeah.
But
Don't know which one. Okay. Okay, but first time, so
Yeah.
doesn't have to be perfect.
That's slowly out.
So
let's see how much is in.
out.
Yeah.
Half of it.
Yeah. It would be deep enough if you really
go behind the larynx in and then directly up. And you were not bad from the direction. I think it was.
Yeah, maybe I was too far straight and I have to bit late. And
Yeah, so perhaps to the side and even better. But that's really.
Yeah.
Just let's see. That's great.
But it's really
I think
difficult
most
because
inside.
I would think I have to go in like 1.5 centimeters and then go up.
It's really directly behind it, but yeah, it's always done. Best it's here, here, so that we just really get. But then, yeah, it doesn't matter. Could be that you have also it's a muscle.
Yeah, but I felt like I was here and you started. Yeah, I know it's different because your head is in between. Yeah. Great. I'm already happy that I didn't cause any bleeding or I don't know what. So, like you fainting or.
Stop. We have to disconnect.
Yeah. Yeah.
We will reevaluate the respiration in 5 minutes.
Yes.
Right home with all the night here. Welcome.
Okay, for like you as a patient.
It's okay. It's not that painful. It's strange kind of pressure.
It's not side, huh? It's deep. Also it's funny that it's in your arm. It's different. Here's painful, but here it's really. And I had the same.
A needle in my arm is like you know it from blood but inside your larynx.
Yeah, the larynx is immediately inside.
Did you swallow now the needle in? Yeah, you have to actually swallow like one time, 1 or 2 times a minute. So you can.
But you managed to not remember. Keep it.
Yeah, it didn't move a lot.
Jumping. Yeah. What else?
First. And it was I'm already not too later. My arm. Maybe it's all my larynx. Depends. I drink one glass of wine. I get brave. And then I make promises.
No problem. How do you want to?
You are? Yeah. Yeah. On va bien anglais. Mon collègue Simon Dumont, c'est l'horreur pour moi. Je retrouve 2 jours en anglais.
Ja, Dicke muss man sich keine Sorgen machen, dann geht es ja eigentlich, dass man irgendwie den Knopf schwitzt oder so.
Ja, die dickste Nadel für den.
Aber ich glaube es nicht. Weil ist es nicht mehr als 5 Probleme. Aber das ist halt schon deutlich.
Ja, so hohe Nadel, die sich voneinander schneidet.
Which one you just covered?
We took
the green one for
the green, sorry.
Yes.
Genau, eigentlich ist es schön mit der kleinen Botox-Nadel erst noch Wald.
For the arm.
Yes.
Yes,
Das wird halt so grün. Ja, dass du halt. Yeah, I normally spray lidocaine on the backside, and I don't go through, but just spray numbs the skin. Then I go with the same needle into the airway and spray on the other side. Yes.
When they cut, you know, you're embedded in your.
No, you do an aspiration, then there comes air, then you know you're inside, then you give a little squirt, they cough. Yes, sprays, then you give another squirt, not 15.
No, I would. Right.
No, because you want to subglottic space and also you wouldn't reach the back side of the triglottal plate, but reach it by spraying. Yes, okay.
If we do Botox like this and we anesthetize everything.
Yeah, but it's not logically.
Yeah, and it's not necessary. You don't have to spray everything for. Yeah, it's not so nice to have spray for hours.
Oh, that's a nice trick, yes. Because actually, most things are so easy that you never think of it. Achso, ja, gut.
Eine Lymphknoten bei einer
Just some muscle. You can ask her to do the maneuver, then you see the muscle perhaps like this one.
Okay.
Yeah.
Ja.
Generelle Muskel haben wir noch. Yes, okay.
Okay, used to.
Like zero. I mean, zero. No, you would hear it if you were in a muscle. You get this crisp signal, the insertion activity.
So
yeah, perhaps. Yes. I mean, it could be a little bit crisper still. Louder. Perhaps try to shift the needle a little bit so that you get crisp sounds like rain on a metal roof. Yeah. And now relax and try to titrate so until there comes a lot of activity. Enough. Yes.
Find fingers. No, because with the other ones, nothing happens. That's...
So it's trained the most.
Didn't hurt at all. Thank you.
It's still alive.
Schön gemacht, oder?
Ja.
Ja. Willst du diesen Vortrag schon drauf spielen? Gerne. Ist das der Refill? Ja. Kannst du noch mal raus? Windows. Dann kannst du auf den Klaus. Also das glaube ich, ne?
Klaus Schmidt muss sein, weil
Ja.
du startest und dann.
Also machen wir vielleicht beide Vorträge hintereinander weg.
Ja.
Genau, und dann teilen wir uns nochmal
Was ist ein IC?
Was sind gerade Verhandlungsreize?
So, okay.
Nee.
Good. Everyone back to the... Gut, alle zurück auf die Plätze?
Ja, er muss noch.
Okay. Can open the... So, what is... It's from Gerhard. Gerhard, they already asked if they can buy it. Do you have the masterpiece still?
Yes.
So you have to. He can send you the original, also the PDF. It's because really nice. He's the second person who
I mean,
asked for it.
every year they ask the webs.
Yeah.
Do the webs do the PDF in the
On the website, ja klar.
Ja.
Ja, gar nicht. Ja. Das ist eher auf die zweite Seite, da kommt schon keiner mehr hin.
Dann ist es mit den Vorträgen drin.
Können wir auch machen, ja.
Das ist vielleicht besser.
Das ist wirklich nett. Das ist wirklich hilfreich. Okay, let's go on. Hast du ein Mikro schon? Ja.
Ja, eben. Sage ich nicht. Das ist sicher.
Lustig. Ich finde es gut, weil man es dann halt verliert. Aber es ist halt, ich hätte auch ganz gerne eins mit. Nicht das machen auch mit aus, oder? Hello, everybody. Back to your seats. Stopping the discussion and going on with some talks. Please come back to your seats. Das ist ja kein lustigen Soundeffekt. Alarmglocke. So, thank you very much. Everyone survived the first larynx EMGs. I've seen a lot of very talented people. So we will go on with 2 more talks and then a little bit more hands-on and then a coffee break. Okay for you? And if you need a bio break, toilets are outside. So Gerhard is telling us how to get the needles into deep space.
PCA EMG. So TA EMG is a little more common because many departments use it for spasmodic dysphonia to apply the Botox to the vocal folds. So PCA is less common, but at least we are fan of doing PCA EMG, and I want to tell you why. Doesn't work? Doesn't matter?
Click into the picture.
Okay. So, because
how it should also work with this. No.
Often we have the case that not all the muscles are damaged in the same way, to the same extent. And you may have a complete immobile vocal folds and you do the TA EMG and it looks pretty normal. But if you do then the PCA EMG, it might be completely gone. So there is, especially after iatrogenic lesions where you have traction on the recurrent laryngeal nerve, you get this preferential damage of the PCA. So you miss that if you don't do a PCA EMG. So especially for PCA EMG, it's an important thing that your needle is not too weak, because otherwise it will be difficult to penetrate the thyroid cartilage. The way we do it is to penetrate the cricothyroid membrane. You pass the subglottic space here with your needle. Then you have contact to the cricoid cartilage. And these are also milestones you need to encounter during your examination. So you get your needle through the cricothyroid membrane. Then you hear this white noise of the air, yeah? And then you get contact with the cartilage. These are all steps to orientate yourself, because you might get lost on the way in the otherwise, yeah? So once you have cartilage contact, then you slowly penetrate the cartilage, and beneath the cartilage, on the back side of the cartilage, you find the PCA muscle. So, and that's how you orientate it. We will show you a little more if we train on the models. And as I said, a stiffer needle means better access. A thinner needle is patient comfort. So, but if you use a thin needle 10 times to find your spot, you've done more harm than using a thicker needle and hitting your target at once, yeah? So this is a video showing how it's done. Needle has not the best contrast here. So this is a male larynx, so air sound, reorientating the needle, cartilage contact, and a brief, so let's have like drilling movement. The drilling also prevents that you bend the needle, yeah? As long as you can turn the needle, it's not bent. Yeah, that's it, basically, yeah? So the sick. Yes. I mentioned that before. You are not able to do that without local anesthetic. At least in very few patients, you would be allowed to do it. So, and then you do the maneuvers. So the forced inspiration, the sniff, should give you the densest signal, and then phonation, there should be less signal. And the question is no signal, or is no activity or less activity. So if you do a relaxed phonation, in most healthy patient, the PCA would fall completely quiet in most patients. In some patients, somehow it doesn't, yeah? And if you increase pitch, you get more and more activity also in the PCA, especially when the CT starts to pull, then the PCA is needed to prevent the collapse of the arytenoids, yeah? So if you want to see the baseline, you need to make the patient phonate in a relaxed manner, and then you see the baseline. The baseline is a bit rougher than in TA, and that's because right next to the PCA is the cricopharyngeal muscle. So you get quite a bit of background noise from the cricopharyngeal muscle. And if you make the patient swallow this, the baseline flattens, yeah, because the CP relaxes. So if the patient breathes normal, you cannot see the baseline. You cannot really look for small amplitude signals. And then you make the patient phonate, and then the baseline is revealed. And because the baseline is so rough, you then have to look for small amplitude signals which are hidden in the baseline. Yeah, so you look for really pointy, short, low amplitude signals if you look for pathologic spontaneous activity.
And often you can hear it better than you see.
You hear it better than you see it, no? So there they are. And that's how some examples look like. Phonation in a fresh paralysis where you don't have synkinesis yet. So this is a single fiber activity. And during phonation, this is only the background noise, which is compressed. That's why it looks like this. So during phonation, background noise only. And here you have during phonation some activity. So this is synkinesis. And sometimes you have like a constant activity, which with very little variation between inspiration and phonation. This sometimes happens, and you only get a quiet signal during swallowing. So maybe there is some aberrant reinnervation from the CP. It's difficult to prove, yeah? Or you have combinations of that. So here, like this. So, and during a swallow, that's how a swallow looks like. You got this quiet baseline there. Sometimes you have this, or quite often, there's right in the middle of the swallow a short burst, which is normal. And here down there, there's synkinesia again. You can see during the swallow, fibers from the TA. Usually there should not be activity, but the TA would be active during a swallow, yeah, to close the vocal folds. So you can, during a swallow, also see synkinesia. So, and that's, I think, most there is to say about the specialties of the PCA. Oh, your turn.
Now we hand over to Klaus, who teached all of us how to do it. Don't get too close. Ja. Kann man das dann mal gucken, aber
yes, please.
Here's the microphone.
Yes, there's also.
Yes, because you go by the lumen of the larynx and the needle is the foreign body. Can you expect the cough preceding the muscle activity? The cough due to irritation of the mucous.
That's why we use local anesthesia.
Yes, okay.
Not do that
Because this is the foreign body in the lumen of the larynx. Yes.
So these 2% lidocaine, or if you have 4% sterile, then 4% would be even better. So you just a small part in the skin, and then you penetrate the craniosacral membrane and spray in small squirts to
the lumen
to anesthetize the subglottic lumen. Yeah,
thank you.
Membranes, and then you can work.
Okay, Fabian asked me this morning to give you a short insight in another application technique of the electrodes. We use this technique in cases we have an uncertain result in the transcutaneous technique, or if we want to do some simultaneous multiple muscle recordings. We have the transcutaneous technique, and what I want to show you is the endolaryngeal technique with hooked wire electrodes. This is the application set for the transoral technique. You need a 90-degree optics, and here the application instrument with the hooked wire electrode, and it's only to be done in local anesthesia. this is the situation with the patient, and the next is a short video clip, because otherwise it's not to understand how it works. I hope this goes. The patient has a bilateral vocal hold palsy. And
jetzt mal kräftig ein- und ausatmen, so ganz schnell hin und her.
das hier ist Rival.
Okay.
And also in this cases, it's possible to do the examination under the local anesthesia. And you need to make the local anesthesia of the tongue, the pharynx, and especially of the vocal folds.
Ganz entspannt, wir machen es wunderbar.
And then the hooked wire electrode is placed for the vocal fold in direct view. And so you can be sure that you are in the right muscle, in the vocal muscle. No other chance for another muscle if you see it where you are. And you can do it in multiple muscles, in this case, also on the contralateral side, under the same examination. And the patients do accept if they have a good local anesthesia for this.
Jetzt mal ein- und ausatmen. Tief einatmen.
In the area very sharp signals because you are really inside the mechanism. So what's the advantage of the technique? You have an exact positioning of the electrode under direct view with a good fixation. So it doesn't matter if the patient swallows during this time, the electrode will be in place also during this movement of the larynx, and you have a chance of a simultaneous recording of multiple muscles. It's more time consuming. Change of the electrode position is not possible, but you see where you set the electrode in the larynx or in the muscle, and it might be an increased stress for the patient. Okay, thank you very much for the attention.
Thank you very much,
And that's it.
As already mentioned this morning, at the moment, we don't get these long hooked wire needles get through this application device.
But you can take normal hooked wire electrodes, the normal needles you use also here with grasping forceps you use also in foreign body removal. And this works the same.
And as mentioned, everything goes in waves. So hopefully, they get available in the future.
Okay.
Is it the magic atomizer you use for spraying the larynx? Magic atomizer?
No, it's a normal spray, and the same you use for the mouth. That's xylocaine, yeah.
So maybe we can switch the light on. Are there urgent questions to the contribution of Gerhard and Klaus? So if we follow our, yeah.
The installation of the electrode.
Yeah.
Change.
With the hook wire knot. Mm. Yeah, and this, yeah, initially, if the local still works, you can have a second chance, but usually the patient are happy if it's done. So you have to work with that signal you got from this position you decided. The benefit is that you have the direct vision, and you could really place muscle of the vocal fold, so you are sure that you are on the right place. And this is the difference to all what you have seen before. So there's an uncertainty that you are really with the tip of the needle on the right place. Tomorrow you will see one option what you can do, especially if you are a beginner. What I advise is, especially in this next you get admitted in the clinic without neck and thick neck, and so use the ultrasound. And my colleague Kathleen Klinge will give you an instruction on that to mark the position, the heights of the cricoid, the thyroid, the midline, and so on. It helps you a lot for the beginning. And we will also show you the possibility of ultrasound-guided EMG. You can magnetize the needle, and then you can see how you direct the needle in the ultrasound view. So, but you need another hand, so it's also not easy. But you see, we all look for opportunities to have a control where we stick the needle in. So, and this traditional, we all started with the direct view. In children, we still do that. During general anesthesia, we put electrodes in. And during the awake phase, we derive the EMG. In the adult patients, usually not. And we have these maneuvers, but we have no control. And if you look at the literature, there are a lot of ideas. For instance, you can put a light wire in the EMG needle to have a visual control where the tip of the needle is and something more. Yeah. So, if we follow our guidelines, you should now start to stick the needle in the PCA. And in this condition, you know, you have to experience with the TA. This is not the right condition outside a practice or a hospital, so someone could collapse or so. That's why we want to give you the chance to learn how to direct the needle to the PCA. And for that, we have the opportunity to try that on computerized models. And there are two colleagues from the FH Linz in Austria who developed this model and are going to found a startup company with this model. So it's a beta version. So sometimes something happens with the software. So, but it really helps you to have in control of which part of the PCA you are reached. Yeah. So we have 4 places, but small rooms, and we have now half an hour, 15 minutes for training and 50 minutes for coffee break. That's why I suggest we split us. I don't know who's most hungry, so maybe the blue and the yellow group start with the training, and the green and the red group makes the coffee break. And after 15 minutes, we change so that we can really start in time, 4:15 with our main session. So let's start.
Sollen wir die zwischendrin aufladen? Weil jetzt sind die runter. Ja, gut. Dann machen wir die aus und laden wir es nochmal. Weil es ist ziemlich jetzt die Wiederholung von dem, was wir.
Also fast gar nicht.
Du kannst anders mal.
Kannst du ausmachen? Heute ist hier mit Mäuschen spielen lassen. Okay.
Ja, wenn die beide. Da wird aber ziemlich leer gesaugt.
Dann wundert es mich.
Ja, vielleicht haben wir es.
You need some so it's better to have a longer ones. And you also need the stiffness. And then you direct it. And this is also true in the neck. This is not this upright lateral position is more horizontal. Keep in mind the cricoid ring is in the same level as the plate. So it goes horizontally to the cricoid plate. And you don't want to reach the joints or the supraglottic tissue. It's painful and not helpful for the signal. You try to reach the middle of the PCA, which is green. Yeah, that's our target, left and right. And then you try to stick the needle in. And in this case, first horizontally, yeah. And first you need take some needle, stick in the skin. Infiltrate a little bit local, wait a second, go through, and then spray and let the patient cough 2 times. So go out, wait a little bit, and if he can speak again, the patient, so everything is fine, then you can start. And then you...
Because that's the atomization effect that you're creating with the patient coughing. It helps spread your local anesthetic around.
So you go slightly to this target side, so now to the left side, horizontally, look on the monitor.
So this is the model that we have created. So green is where you want to target, yeah? This is your PCA muscle is like a fan from the back. But your cricoid is like a signaling. So the back plate is taller than your front plate. So if you come to the cricothyroid, go straight, you will go into in the middle of your cricoid plate, stereo.
You're supposed to be to inject the anesthetic.
Yes, yes, it's possible.
Border of the cricoid, true. The lower part of the cricoid, then
You go to the cricothyroid, yes.
the GA is over last part.
So you hit the target.
Just go straight. Because your cricoid back plate.
These are Botox needles, that's why they are for hollow. You can use it for injection line thing. So that's the target.
You can see you are here on the red, on this where you're targeted.
So, and now it's your task to try. Take it out. Try.
I will how centimeters.
Yes, depends on the soft tissue. So a female larynx has about 25, 26 millimeters in diameter. If a male about 29 to 30. So and look at this. So feel now you reach the trachea, and then it should go for another 2.5 centimeters. And if you are there, you are too deep.
You are chair. Behind, yes.
Yeah.
Yeah.
So it's but
may of the pharyngeal muscles.
Yeah.
Encourages and maybe also the activity.
Yeah.
Pharyngeal muscles.
If you should be introduce the needle carefully. If you are in the airway, you have this turbulent sound, and then you reach the cartilage, and there is silence. So, and then be careful to form a small drilling and forcing, and the next signal you got is the PCA. But keep in mind, our patients have damaged PCA. Maybe this is a 2 millimeter muscle. So if you hit through the cartilage, of course you can reach the pharyngeal muscle. Then you have activity during swallowing. In the PCA muscle during swallowing, you have silence. This is the difference. Oh, that's.
Is this your larynx? So,
Yes, yes.
yes. The first sound.
You scan.
They printed it based on Andreas' neck. So it should be a very easy larynx, okay? No complaint about the larynx. Another one.
Third position, light position or sitting position in the patient?
We perform it also in the sitting position. A lot of colleagues around the world use more 60-degree position, so a little backwards. So the best is that the patient has something behind the head.
Double size.
Okay, so just above the clitoris or just below the clitoris?
The upper portion of the clitoris.
Upper.
If you go straight on in the
Which muscle do you want to reach?
because it's a prevention, that's when you want to go straight.
Yeah.
One side.
You have a left and a right.
Which one you
Now
want?
it's left. So here's the resistance.
You should be able to go straight.
And let us go drilling.
The other way around.
And the best way is in addition. One you can come through. Take a finger to hold on the neck, and then
you will hear the sound and color a bit.
yeah, you rotate, push, but have a finger on
the
larynx or on the trachea.
Slightly drill a little bit because microphone is hitting quite hard. Once you finish,
Because you feel the resistance, and if you are through the cartilage, the resistance goes down, and if you don't have a finger on the neck, can come through. Yeah, you're now in the midline. Yes. So there's no. You can retract it a little bit and go more laterally. Yeah, you need break more and then go more laterally. Yeah, you can.
No, this is all in.
Yes.
They printed many times.
Still in tissue, then you bend it on.
Then you have to go in
change the direction.
There is no muscle. If you go straight in the middle,
Yeah. Fine.
expansion. So you want to go little flex.
And you have to stick.
Straight through the drill.
Yeah, so when we keep the three direction, so the first convincing activities from this muscle.
Yeah. Okay. But you need a control maneuver, snipping. If there's an increase in recruitment, then you're on the right muscle. If there is increase during swallowing, then you're on the
region.
Sorry.
Come through an empty space, which is
How long is this?
The distance is
So
about,
for imagination.
yeah, it's
Two
a muscle,
centimeters.
it's about 1.5 centimeters in height, 1 centimeter in width. But 2 or 3 millimeter in thickness. Okay. Yeah. Perfect.
So from what it says, penetration of the skin.
You can from run penetration if there is both lines.
And the is very the description of the technique. Rotating the larynx, brutal,
It's not brutal,
Yeah,
it
not
works.
percutaneous.
Yeah.
Direct percutaneous without movement of the larynx.
The truth is that it's not a rotation problem. The problem is the carotid artery. You have to palpate. You have to palpate on the carotid artery that is going to stay medially upper, and then you reach from the lateral point of the muscle. The benefit is that you reach muscle from the side. You have a larger area where you can derive signals from, but it's more dangerous and it's more uncomfortable for the patient. So I think this is safe. In this midline, nothing could be happening.
So this technique. There is the possibility of the loss of the
Yes.
from the artery.
Yeah.
From the artery. So not from the
And
vein.
you have
Support them.
and
It's not many years ago, which is great. It's not good in the midline. It's good in the midline. Unless without actually the name. You're going to EG needle is unlikely to get the very
So and then the middle also thick through the skin to the membrane.
Your needle will come straight
And
to the air
there is a point where you have no resistance.
Yeah, straight.
Only the adhesive of this silicone. And then again you feel the resistance. And now you have to decide. You're in the midline. You should decide. So it's more for the right side. No. And now, yeah, it's good what you do from your fingers and drill and force.
So here we are going in the midline, right? So thyroerectomy we're doing in the lateral venous.
You insert in the midline, but you go lateral.
But nice is wrong with
You're quite in the midline.
You can also do if you do it in one session. So what we do is you have this medial position to the TA strength. So this is with ECAs and then it's going to more strength when you go to the CT as well as but in
It's not that easy.
So there's only one function point.
Yeah, that's swallowing.
Quite a lot of times.
For the CT,
you not swallow those one.
My comes to directional. The more they start. Directly from the here.
So the more natural, bigger the surface is.
Because it's and it's
like
only necessary.
The other one,
if you
yeah, it's more natural. It's more natural, exactly. If you go to the midline, there's no muscle. And we can puncture through it.
Maybe too lateral.
To you, or not deep enough, maybe. Yeah. It's yeah, you are lateral, and if you go more medial, then the resistance is not so strong. But you have to retract it a little bit. Then you only bend it. So if you want to change more to this position, you have to retract it 5 millimeters. You need it.
Yeah,
I can read.
And there's not so big. This is true. The upper part of the tongue is thicker, stronger, get deeper, and medially it's softer.
Okay.
The normal recipe without provocating.
This is not.
You need to insert.
No silence. This muscle. There's no silence. Keep in mind that the muscle is very thick. And the surrounding muscle is also from the muscle. Only during the and then again activity and brings everything and then building you see it.
Perfect. Thank you.
Ach so, habt ihr das gemacht? Das ist ja interessant. Oh, hört man bestimmt noch.
Das ist so. Ja, das ist nicht fair. Entschuldigung. Kommt hier mal rein. Ähm, So hello again. We come now to our main session of this year neurolaryngology workshop. So the idea behind was all of us see the larynx, more or less good. And we have now the introduction to the EMG. So in the next 2 hours, we want to learn what we can answer with the laryngoscopy, which additional examination we need for special indications. And then we want to share some cases. So we start with the main lecture. I'm really grateful, James, coming to us, to Europe, to hold the lecture on your experience on visual neurolaryngoscopy.
Yeah. All right, thank you. Well, thanks for having me here. I've spent a nice 2 weeks here from Berlin, Dresden, and here. So here I thought it was kind of goes along with this idea of visual neurolaryngology. How do we as a process? It's a hand-drawn one. It's not. So, in this short time, do a single case, show how I think through it. That's what I have time for in 15 minutes. And particularly, I'm going to focus on LCA muscle just because I think it's the most ignored muscle that laryngologists miss. So here's a patient I was sent a video of about 2 months ago. And when you look at it, you see some sort of impairment, right? Sound.
Can you
We have sound. Okay.
more? The emergency car is still out.
How many think this is vocal cord paralysis? I mean, I think that's the first word that comes to everyone's mind, that it's paralysis. And if it's paralysis, which side is paralyzed, right or left? Okay. If I ask that to both people, who do you get? Left. And I think the problem is that's the wrong question. A little bit what we alluded to this morning. Paralysis being complete lack of motion. This has motion. And we're going to delve into the motion with our eye focused on what's going on with the LCA muscle. And we're going to think of the LCA muscle is what runs the vocal process specifically for adduction, and it should be rotating the vocal process inward. And we're going to try to figure out what is causing her hoarseness. So we're going to glue our eye to that spot. And all of that we just saw happened so quickly that I'm not sure I could tell you what's going on. So the ability to take this and put it on a computer and then slow it down, I think will help us get to the answer of, on the left side, is there a weakness, a paresis, or is there perhaps some sort of reinnervation where fibers have crossed over, where PCA fibers, which I've made blue, instead of growing back where they should, maybe they grew to the wrong place, and that's what I'm implying with the drawing here. So I'm showing you now at 25% speed, this person taking a breath. So we've gone down to a single side. We're going to look at the left side. We're going to look at a specific task, inspiration, and we're going to look at it in slow motion, and we're going to look at it repetitively. Inspiration, 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 inspiration. So clearly it's not paralyzed. There's motion there. And that motion happens to be in the right direction at the right time. If I ask you to breathe in, the vocal processes should go open, but it's incomplete. But it is, in fact, moving at the right direction. And I could speculate that either the PCA muscle is weak, or the PCA muscle is weak and it has some resistance because maybe some of the PCA fibers are going to the LCA and keeping it from opening. So I don't know yet, but I have now these two hypotheses in my mind. But the patient is not complaining of dyspnea. She's complaining of hoarseness. So in a sense, we don't really care about abduction. We just looked at it. And we want to look at phonation. And phonation, we can watch this vocal process move medially. And in fact, I would say it's actually moving past the midline. So probably this left side moving in is completely normal. That is, during phonation, it looks like there's enough signal to get it all the way to the midline. Or if anything, maybe there's some PCA fibers slowing it down, but the predominant effect is complete movement of the vocal process to the midline. So now we're looking at the very same film again, but our eyes are going to go to the right side. So let's ask her to take a breath in and focus our eyes on where the arrow was multiple times. There's complete abduction on the right. So maybe the PCA is completely normal. It has gone all the way lateral. And now we're looking at phonation. So we expect this vocal process to rotate to the midline. And this vocal process is moving medially during the onset of phonation, but we're not seeing the rotation. So a couple of hypotheses. One, the right LCA is doing nothing and the interarytenoid is pulling it over. Or maybe there is a tiny bit of LCA motion plus the interarytenoid brings it towards the middle. And then I can briefly take a look at the TA muscle. Here's during stroboscopy. And if I watch the oscillatory wave, I can see that it's spending most of its time lateral, but it is crossing its axis. So I can say that the right TA muscle has some tension, but it's probably incomplete and weak, because compared to the left side is oscillating around its axis, spending half its time medial and half time lateral, and this side is spending more time lateral. So compared to the other side, oops, now that is way too loud. Let's go down with the volume. Well, we're getting distortion there. That's not a hoarseness, that's distortion. There we go. So in conclusion, for looking through this one, we have something on the right side in terms of the adductory muscles, TA and LCA, but it's clearly weak. And on the left side, we have some sort of impairment by reinnervation, but we have plenty of adduction. So I would have to say that the left-sided injury was probably old, and she has reinnervated, and the right side appears to be a current injury, and it gives her a gap, so she leaks air. So I think her current problem is from an injury to the anterior branch of the right recurrent laryngeal nerve. So that's sort of how I get through this thinking of visual analysis, is by getting a good video that includes the vocal processes on both sides, that includes inspiration, expiration, which is really hard to sit there and record. I know all of us go in, we look, we see it, and we come back out. But if you go in, get it in your view, and sit there for 3 breaths, you'll get much more diagnostic information. And you add that together with the strobe, and you can deduce, I think, what's going on. So how would I think about the LCA? Well, the brain fires, sends a signal to a muscle, the lateral cricoretinoid, and it does it at 2 different times. One is during expiration, and one is during phonation. So we should see this vocal process coming to the midline during those 2 tasks. Does this make sense so far? Sort of a thinking process, breaking it down? And I have how much time left here? Because I can stop anytime. Stop here? Stop here. Yeah, that's good. Okay, so that was just a general overview, and we can talk more if we need to.
Yeah, thank you. Excellent talk, and sorry for
interrupt you,
you, but this is a closed case you present, and this gives us an idea. It gives us an idea how you are looking on the larynx. So, questions from the auditory. Yeah.
Did you make an application on the right side?
So that is what I would recommend doing. This was not my patient. Someone just emailed me the video. So yes, I would want to deal with the right side. It could be that you observe it for a number of months. It could be that you put an implant in the right side. Yeah, something along that line.
One question from my side. Did you saw a level difference between both sides?
Well, this is shot with a rigid scope, and it's hard to tell level difference. So I would say no, but if I were using, I prefer for neurodiagnostic examinations a flexible scope where you can get in and look along the axis, and I think you can judge that a little bit better.
So maybe we can go further during the cases, and if we have some time, again, you can show your concept of dipping and looking, turn in the endoscope, and so that the idea is that you take some experience home, what you can improve on your examination technique, and what should you record. And if I understand you right, you look after the examination really careful on the slides with slow motion, and you see more than during the examination.
Yeah, I think hopefully you see it during the exam, but there are many times when I'm reviewing it afterwards in slow motion that I do see more detail because I've slowed it down. I even, when I take a rigid exam now, use an AI program to slow it down, and that helps smooth it out. The smoother and steadier the image, the more your brain can process what's going on. I think I would add to the first part that lidocaine is the laryngologist's friend. Putting lidocaine in opens up the whole world because you can get even close. This was an outstanding rigid exam, but if you get close, you will see a lot more.
Thanks to this point.
Yes, thank you very much for this contribution. I know that we discuss the value of stroboscopy in comparison to the EMG at every conference meanwhile, because I know that you teach us that we can see all the changes from the muscle point of view just by laryngostroboscopy. And I started, I would say, 15 years ago with the EMG, and I would take it on the other way. I learned to see what you have seen here by doing EMG. So that's why I'm very happy that we have in our program the next presentation on the EMG and what do we see in the EMG. Dear Gerhard, do you want to come closer?
Which one is yours?
No, no, this is not the next one.
Yeah. That one.
No, yes.
That one. Okay. There we go, and we hit that, and it's ready. There you go.
So switching a bit back and forwards, what do we need laryngeal EMG for? I think this is our list where we believe that EMG is useful, and I will browse through this list quickly. First of all, we can prove with EMG whether there is a neural lesion. From an immobile vocal fold alone, you sometimes may not be able to say that. Or in some cases, a surgeon may say, oh, maybe I have cut the recurrent laryngeal nerve during surgery, and then you can do an EMG to prove whether there is still some integrity of the nerve or not. We can differentiate, if the cause is not known of the vocal fold immobility, we can differentiate between vagal lesion, recurrent laryngeal nerve lesion, or joint fixations. We can, after thyroid surgery, or so we can also look for whether there's concurrent lesion to the superior laryngeal nerve, which might add a little burden to the hoarseness. We can estimate severity of the lesion and therefore have a little bit insight into the prognosis, which can aid us for timing of potentially irreversible procedures. And we can, after reinnervation, detect pathologic reinnervation pattern which contribute to the poor voice and could also guide us in our therapy. In spasmodic dysphonia, we use it for injection, but we also, in some cases, use it to detect the spasmodic dysphonia pattern. It's not always abductor and clear adductor dysphonia. There are mixed types also, and sometimes you need to inject more than one muscle to get a good outcome. And whatever you do, before you start doing EMG, you should know the time course of nerve reinnervation. This is really important because that makes you able to interpret what you see. Yeah, a fresh lesion in the first few days, after 2 weeks, after 4 weeks, after half a year, it looks different because you get reorganization processes, reinnervation, and that changes the signal. So you should know how the signals, what signals to expect after what time. So in the first 10 days, the only thing you sometimes can say whether the nerve is intact or not. But if you don't see anything at all within the first 10 days, you cannot say really a lot at all. You cannot differentiate a complete nerve cut from a neuropraxia. Usually, this is not the case. In many cases, especially in iatrogenic nerve lesions, there is not in every muscle the same damage. So often the TA has retained less damage and the PCA has taken more damage. It's a common finding, especially in iatrogenic nerve lesions. And if you have in one muscle activity left, you can say this muscle, this nerve was not cut. As I mentioned, you can differentiate between vagal lesions and recurrent laryngeal nerve lesions. In a vagal lesion, the CT muscle, which is supplied by the superior laryngeal nerve, which originates from the vagal nerve, is damaged as well, whilst in a recurrent laryngeal nerve lesion, the SLN is intact, the CT is intact. If you want to identify joint fixations, you should do both TA and PCA EMG, and if the EMG is normal, then you could conclude maybe there's something wrong with the joint. The more severe the nerve lesion is, the more pathologic spontaneous activity you get. Yeah, the more nerve fibers are gone, the more pathologic spontaneous activity you get. And this puts a burden that the regeneration gets less good, and synkinesis, so pathologic reinnervation, becomes more and more likely. So how does pathologic spontaneous activity look like? We have seen examples already from Fabian's talks. So it's usually, because it's a small muscle, in a small muscle, it's low voltage, very short and spiky signals interspersed in the rest of the signal. Yeah, you sometimes have to look carefully if the baseline is rough to identify them, and they should be strongly rhythmic. So some other sign you get after a few weeks is that you get collateral reinnervation, that within the muscle there is collateral sprouting, and that makes the potentials polyphasic. You can see that as early as 4 weeks, and it's not a real reinnervation, but it's an intramuscular reorganization. And this polyphasia often remains even if the nerve has recovered. And if you then do years later in EMG and you find increased polyphasia, then you know there once had something been wrong with that nerve. So then time continues and the nerve fibers regrow in a random fashion. And then you start seeing nascent or so emerging muscle units. And these are prolonged, low amplitude, but repetitive. That's how you identify them. So then you know the nerve is starting to reinnervate. And if you have this is a positive sign. You know the nerve is regrowing, so the voice is likely to improve in the next few weeks or months. And if this is synkinetic, which means during the antagonist maneuver, then you start having signs for poor prognosis for recovery of vocal fold movement. So which brings us to the next topic of synkinesis, which has been topic today already. So just briefly, you compare the activity during an agonistic and antagonistic maneuver, and especially for TA, there is physiologic antagonistic activity. And if this ratio between agonistic and antagonistic exceeds a certain limit, it's related to poor prognosis. In PCA, there's often no activity during the antagonistic maneuver if you phonate relaxed, and if there is, it's pathologic. And sometimes you get strange patterns, which I'm not commenting now. So, and this, if you see synkinesis, you know there will not be a really full recovery, and you can use that to time the possible procedures which might not be reversible for voice improvement. And in some cases, you may find activity that is much stronger during the antagonistic maneuver, and in those cases, it could hamper the normal function. of the voice as well. So this would be my list of indications, or our list of indications related to the changes over time. So now we're switching back to visual versus
and electrical stimulation. Yeah, thank you. Are there questions or remarks, Doreen, from the neurophysiological point to EMG? If not, we go further to Matthias Leonhard and want to find out which value have the direct electrical stimulation in the neurophysiological assessment of the larynx.
Thank you. Does this work? Okay, understand. Okay, so thank you very much for the invitation. I feel very honored to be a speaker here again. And we have seen now the EMG and we have seen the visual laryngoscopy. And I would like to introduce you another option that we have now. It's the neuromuscular stimulation with a new device that I would like to show you. So a big thank you to our sponsors, because otherwise we wouldn't be able to conduct our studies and we wouldn't be standing here. Neither would we have a product or a device. Just a short recap so you can imagine what is going to happen. So if we have damage, then you see that the recurrent laryngeal nerve and its branches stops working. And depending on the type of the damage, we can have neuropraxia, axonotmesis or neurotmesis, and we can expect different results. But we do have a regeneration process going on, which you have seen already. And depending on the regeneration and on the time course, we can have a vocal fold immobility that we see in visual endoscopy. And this can have either a denervation, meaning that we have no signals coming into the muscle, or it can be inappropriate reinnervation, like a synkinetic reinnervation or aberrant innervation. And it also is possible that over the course of time, we have another balance of regrowing axons, and it might be beneficial. Then we have a partial recovery or full recovery, and or we also see less movement of the vocal fold. And in all of these cases, not always is the cause of the vocal fold immobility plausible from the medical case history. In all these cases, there might be also the possibility that we have a mechanical etiology of this. Now, where does this put us with our examination techniques? On the one hand, we have the visual laryngology, which is easy to use. Everybody knows it. We can look at all of this, but it is difficult to distinguish between, for example, denervation or synkinetic reinnervation. Some of them can, and it's a training, but it's not easy. And we have the laryngeal EMG that, on the other hand, gives us a very precise result from the innervation, but also provided that we have a training where we know where our tip of the needle is. And what I would like to show you now is a neuromuscular stimulation, which is a bit a different concept, but it's the focus of my topic now. Neuromuscular stimulation. What is the point of this? We have a device and we are trying to stimulate a PCA muscle, and neuromuscular because we are trying to find the nerve entry into the muscle, because it's much easier to stimulate the muscle contraction with this. And there is a new device, and it's called the ECE50 endoscopic cap, and it's 50 millimeters in length. And it's now available for the market. And it's the first time we have a not off-label solution for doing such an examination. And because up to now, we did also perform stimulation, but the devices were off-label. So what is it? The key principle behind it is that we are trying to find viable nerve fibers that connect to the PCA muscle. And how to achieve this? We have a cap that is bendable and has electrodes in it. And some of you might be familiar with the concept of laryngeal pacing, where we have the PCA muscle and we are trying to implant an electrode in the caudolateral quadrant of the PCA muscle, because we expect there to be a nerve, a hotspot, which we can stimulate and thus elicit muscle contraction. And before we do this and go on with surgery, we have been thinking about making a device how to check this without cutting the patient open. And the idea is to place electrodes exactly on this hotspot and to preoperatively diagnose the functioning of a hotspot with the confirmation of the function of the PCA muscle. And this looks in real like this. We have this cap and we can mount it on an endoscope. And the nice thing about it is that you can use the endoscope to navigate to the region of interest where you want to go, meaning the backside of the larynx. And there you can position the electrodes and try to search for the hotspot. It's atraumatic, made of silicone, and you can at the same time take a look at the glottic action. So this is how it works in the illustration. The patient is prepared just like, for example, for intubation, but it's spontaneous breathing, so it can be performed in sedation only. And you introduce a laryngoscope and elevate the tongue base, and then you can introduce the endoscope under controlled endoscopic view and position it. And by using the second device, that's the NemoStim, you can administer pulses and impulse patterns to the PCA muscle. And there you have different modes. One is like 3 Hertz, where you can like tuck, 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 search for the hotspot. And you can also administer a tetanic contraction in order to verify the contractibility of the PCA and the function of the cricoarytenoid joint. So this is the way it looks. This is performed in a similar setting, like a gastroscopy, for example. The patient is lying on his or her back, and you can either have 2 examiners, one controlling the advance of the endoscope and the rotation of the tip, and the other one, for example, just the tilting of the tip. And here you see it is introduced transorally, and you can then see the endoscopic view and control the action. And I have brought you just one examination video so that you can see how it works. This is the endoscopic view. This is our EC50 cap, which is mounted on the endoscope. And you can see we are positioning on the back of the larynx. And at the same time, we have an overview of the laryngeal hiatus. So this is the view. And you see, we can advance past the tongue base and through the pharynx. And here we already have the positioning over the region of interest. And now by gently readjusting the position, you can see a starting twitching of the arytenoid on the right side here. And then you know, oh, we are in the proximity of the hotspot. And then we can administer a tetanic impulse and you see an opening. And we can also go to the other side again. And you see this was already a longer pulse. And you still can apply and remaneuver until we have a nice opening. And you see also the movement of the vocal fold at the same time. So in this case, we have on both sides a functioning hotspot, meaning that we have viable fibers entering the PCA. The whole procedure takes about 10 to 15 minutes, and we can check the function of the whole chain, meaning from a viable nerve until the opening of the glottic gap. So for us, it is interesting to find this hot spot that may or may not be, we don't know before. And we find maybe a distinct location so that we can say this is a possible location to implant an electrode. we check if this hotspot is able to induce the opening of the glottis. And we can also check if the parameters are very high or not, and try to deduce if this is something that we can use as a result for further implantation. And all of those information that we gain from this is necessary for the implantation or for the identification of patients who might benefit from a laryngeal pacemaker. So what did we do? After we developed this cap, we were thinking about, well, how can we position the results of this device in comparison to established examinations like the EMG and like the visual laryngoscopy. So we took 25 patients who were interested, who were eligible candidates, we thought, for pacemaker. And most of them had bilateral vocal fold paresis. And we checked the case history and the endoscopic view, EMG, and the EC50 stimulation. And down to the bottom, all the patients were possible to examine in sedation with the EC50 cap, and we had no severe side effects. And in about 70%, we have seen that we have kind of a value because either we confirmed the visual laryngoscopy or the LEMG, or surprisingly, we found an abduction of the vocal fold. In 5 patients, there was the suspicion of a mechanical etiology, and it was confirmed. And in 45% of this population, we could find possible candidates for implantation of the pacemaker. And if we look at the results a little bit more in detail, then we see that in 44%, we have a confirmation of the results from endoscopy and or EMG, but if it's possible to perform the LEMG in the patient, and this was confirmed by the functioning of the PCA. And additionally, in 26%, we did see that we have an induced movement with the EC50 stimulation, but we wouldn't have expected this based on the results from endoscopy or laryngeal EMG. In one case, one PCA, we had an obvious problem with the positioning, but still in another 28%, we had no inducible action of the PCA. Well, we would have thought that there would be, because we did see something in the LEMG or in the laryngoscopy. Now, if we think where to put this examination method, this highly depends on the question. But if we have a vocal fold immobility with the visual laryngoscopy, we can see try to see the action. We can say if there is a mobility or not. We can tell if there is a special position of the arytenoid or of the vocal fold. And we can try to examine the tension or the changes of the tension. With the LEMG, depending on what kind of state we have of the PCA muscle, we can see if there is a silence, a denervation, or we can detect a synkinesis very well. And we also can see reinnervation, kind of synkinetic or not synkinetic. But you cannot induce an abduction and check the functioning of the PCA. I mean, Gerhard can. But LEMG is not such a procedure that is tolerated by all patients. And for myself, I wouldn't try searching for a hotspot with a needle. But it's possible and it's off-label. But if we have the EC50 cap, there we can just kind of examine and judge if there is an abduction or no abduction. But what it helps us to understand is if we have an abduction, then we know that there is an existent innervation in the PC muscle, that we have a hotspot that we can locate, that we have an abduction of the vocal fold, and that we can kind of see what stimulation parameters might be applicable. And all of these are strong indicators for patients who receive who might be able to receive laryngeal pacing and benefit from this. So coming to the conclusion, what does the neuromuscular stimulation help us? It can confirm the whole chain from a viable nerve to the contraction to the opening to the gap, opening gap of the glottis. Patients who do not tolerate LEMG might still have a benefit, and we can get results. Inconclusive LEMG or vocal or visual laryngoscopy results can be maybe understood with the help of the EC50. And we can differentiate neurogenic from mechanical causes. We can identify patients for the pacemaking systems and functional rehabilitation. And it's comparably an easy procedure because you have to put the endoscope there. And once you have established the setting with an anesthesiologist, you just see opening or not opening. So you don't have the interpretation like an EMG signal, for example. So what does this mean for us? This is just a novel, but it's a complementary tool for diagnostic decision-making. It helps us in patients, especially for bilateral vocal fold paresis. When you have a bilateral inducible abduction, then you see that you can choose which side to implant and choose the better side. When you have an unilateral abduction, then you can choose whether the patient wants to implant a pacemaking system, for example, or you can preserve it and go to the less functional side and do a glottic enlargement surgery, for example. And if you have no inducible action, then the patient is not eligible for pacemaking implantation, and there might be also the mechanical etiology behind it. So I hope I could have explained in this 15 minutes the basic principles, and thank you very much.
Thank you. As for all three of you, it was a challenge to put this in 15 minutes. The reason why I restricted that is to come in clinical discussion. So, and I really thank you to invite in this new method. Tomorrow you will have it in your hands during the course. You have an idea of what electrical stimulation can do. And maybe if you see us again in the next years, we will also have cases where the decision-making is based on this. The cases we prepared are traditionally based on the laryngoscopy and the EMG, but you can discuss with us where you could include the electrical stimulation additionally. Yeah, thank you. So then, are you ready? We would start in the battle between visual against LEMG. So we present the first case, and James starts to interpret.
I'm starting first.
I give you the mic.
You want to yeah. So we'll go to
case one.
All right, so I was given this video to have a look at, and I can run through it here and just personally look over it. So we're doing the task of phonation, and there's clearly something on the left side that's not correct. And on the left side, when I'm watching this, I can see that there's this twitching on the left. So then I want to ask myself, when is that twitching occurring and which direction is it occurring in? So in adduction and phonation, the adduction is incomplete, and I also want to know why it's incomplete. Why is there a gap? She's leaking air. So those are kind of the two questions that come to me. And one of the things that I want to do then is to try to really watch this, and breathing is a nice time to do it. So when she breathes in, and by breathing in, I'm watching the vocal process on the right side. So this is inspiration. It's moving laterally. That's the normal side. And when I see that on the left side, I see adduction at that moment. There's some irregular movement, but when she takes a big sniff, then I see inappropriate movement. So to me, there's been some reinnervation here. So as I looked through all of that, I kind of came to a conclusion that I think the PCA is weak. She can't open, he or she can't open very far on that side. The LCA, in fact, is near the midline, and we're getting adduction when we don't want it. So there's been some aberrant PCA fibers going to, I think, the LCA muscle. And then I kind of look at the mass of the TA muscle. I can't say that I got a really close look at it, but she's got some tension in there. And I think the thing that surprises me is, well, if I assume that the right side is normal, then I would expect that with the left positioned in the midline, that, I'll go back to where it's upright, that she should get complete closure here. And so I don't know, maybe there is an injury on the right side that I don't know about. And I think one more conjecture that might come to mind, but I have to admit that we've talked about it a tiny bit, and I didn't consider this at first, is maybe there's some physical obstruction here that this joint, by being collapsed forward, might be obstructing the closure. I don't think I have an answer to that, but I think you can consider neurologic problems and physical problems.
Absolutely right. And you see this contact rather.
Contact.
Maybe this could be a hint that there is supraglottic hampering of the pressure.
Yeah, and I think I see the ulcer almost always on the injured side. It's the good side is over closing. And so if you put your endoscope in, you probably would even see an efface view of it. A lot of times you will see an ulcer on that side. Those are my initial thoughts.
Okay.
I will flip. Yeah, I mean, I thought that, I did to some degree comment on it. I think that there is mass to this, and that during phonation, here's the breath, and there's some Bernoulli effect. So clearly the TA does not have normal tension. I mean, it's in the middle, but the air going past it, that makes it a little bit weak. And when we watch the phonation, it's hard to see the stroboscopy here, but there's at least some tension on that side. And so I think that's why when I draw this up, I can't say what is supplying the tension, but there is nerve input into the TA muscle during phonation. Could be TA, could be LCA, could be a little crossover. It's being held tense even during inspiration. So I'm putting down that I think probably some PCA fibers might have gone to that muscle. So these are my educated guesses, and they are guesses.
So these are conclusions. Do you accept this?
Yeah, that there is some sort of crossover, and it is synkinesis, but it's actually for sure dyskinesis. There's a heavy influence of PCA fibers going to the LCA muscle, because we have inappropriate adduction during inspiration, and that there's weakness of the TA, but it's incomplete, and that the LCA has also activity that makes it almost functional. And the question is, why is it not completely functional?
Okay, now look on what the EMG results. Which muscles we should examine in this case? Question up to you. Which muscle you would like to examine?
We got TA, LC, PCA, both sides.
If we started this question a few hours before and you had sending more muscles. So now you are experienced what effort it is, so you reduce it.
Case one, the battle is on. Yeah. So we've just seen the video. So this is TA for you. On top, you see the overview. Inspiration, there's activity, which is strongly decreased or on the, so almost single fiber. And during phonation also, so kind of single fiber activity. Here you see down there, you see the detailed view. So it's just 2 or maximum 3 different motor units. So single fiber pattern during inspiration and phonation. So which means that the TA is weak. And it's synkinetic. Because the ratio of activity during phonation and inspiration is about the same. It should be less, but it's about the same, so it's synkinetic, but weak, very weak. And PCA, there we have kind of a constant activity that runs through, but with very small, very small muscle units. So, and during phonation, there are some bigger spikes. So this is also synkinetic. And if we see this small amplitude activity that runs through, no matter whether inspiration or phonation, I sometimes have the feeling this looks a bit like an aberrant reinnervation from the cricopharyngeal muscle, but we can't really say so. But we have in all quite weak PCA with some synkinesis there. And in this case, with this highly inward rotated vocal process, we tried an LCA EMG, which we haven't explained to you now before. So Berit briefly mentioned it. So you puncture the CT muscle and follow up the cricoid arch, and then behind the CT muscle follows the LCA. So it's not that easy to find. So I'm starting to get to it more often, but sometimes I still fail. So, but it's worth it. Maybe we should do it more often. Yeah. So what is the LCA showing? During inspiration, it should be quiet. And during phonation, it should be active. And actually, even if we do a sniff, it's actually far more active during inspiration than during phonation. So this, you hardly see the baseline here. So this is mildly reduced interference pattern, but during an antagonistic maneuver. So this is a strong pathologic reinnervation, so a strong synkinesis of the LCA. Yeah.
One remark from one side, you learned new words, and I don't want to that you mismatch all these things, but in this case, it's not only a synkinesis, it's an aberrant innervation. So the LCA has much more innervation during the wrong maneuver than
antagonistic
maneuver.
Yeah.
So
which we call
therefore I really like your term dyskinesis.
Yeah.
So we saw slightly movement on that side.
Well, we don't see kinesis in here. Yeah.
No, but we saw kinesis visual. So, and we saw during the wrong maneuver, the adduction.
Yes. So, but if we look at our chart, it's pretty even. We both predicted correctly. Yeah.
Yeah. So now Kathleen can
show the clinical case for that?
Do we need the mic?
Steht doch alles an der Wand.
Everyone can read. So she had suffered a malignant disease, and initially the voice was hoarse, but that improved. But her main complaint, where we've seen her, was dyspnea on exertion. So as my colleague has shown already at the LEMG, we've seen a strong synkinesis of the LCA, and we sort of told you our plan here already. I initially thought to ask you what you would be going to do, but so we're planning to do Yomin trial, so putting Botox into the left LCA, and finally a non-selective re-innovation with the end-to-end procedure. Questions? Anyone wants to be doing anything?
Discussion.
I'll start one thing, and that is, I don't know whether a complete non-selective reinnervation is any better or worse than a anterior branch selective reinnervation, because I would do the selective reinnervation. But I don't know that one's better or wrong, or they both have equivalent results. And one of my concerns is we already have that in the midline, and she's hoarse and can't get it closed. Is it possible that that arytenoid is still going to block it, even if we re-innervate it? So which procedure to do neurologically, and what to do about the persistent gap that might not be closed by any neurologic procedure?
Maybe this arytenoid disposition, let's
say, yeah,
would speak in favor of a complete non-selective, because
yeah,
with your selective anterior branch, you would not re-erect the...
Yeah, you wouldn't give any more to the PCA. And maybe you want, so that's a good way to think about it. Yeah, maybe you want to try to get that PCA tight. Yeah.
So this is typical. This is what we like to do, to decide what we can do.
Yeah, yeah.
Yeah, but first of all, I congratulate that we came nearly to the same results. So, yeah. Shiying, you had a comment.
Well done for I love the picture between the battle between you two. I love how one is holding LEMG, one is holding camera. And so with this case, I agree that the synkinesis is the problem, but given that her problem is her breathing, and I know you can trial with LCA, but I know research tells us that when you inject, particularly in LCA, it could be leakage of the Botox to the surrounding tissue with the seepage. So that's, of course, that will increase your chances of make her dyspnea better. But I also wonder with a re-innovation option, because with that, are you going to overcome the synkinesis though? Number one. And number two, would it be better to consider, if her problem is dyspnea on exertion, electrolyzation option, suture electrolyzation of the arytenoid, because that means you preserve the structure, but at the same time, you can also improve her breathing in the posterior glottic inlet. Just my thought.
We have done an EMG here, and we know that re-innervation of the vocal fold is poor. So what do you want to preserve? You want to preserve a poor re-innervation? Yeah, but it's single fiber, so it's a very weak re-innervation. Yes, it is. Yeah, but it's like a reset. You put the whole vocal fold in a better position. Apparently, or supposedly.
Well, I have two thoughts. It's always important to clarify dyspnea on exertion or out of breath with speaking. And I didn't know the history here, so I don't know which she has. And then if it's dyspnea on exertion, what I would do with this patient on endoscopic exam is I would take her out to the stairs and go up and down the stairs with her 4 or 5 times, come back in and scope her. I do, when we have time, I have an example patient, and that vocal process moved over further and further and further. And so that clarified it. And then I injected Botox, got it back to the midline, improved her symptoms. So that diagnostically was outstanding. I did that 3 times in her and said, okay, now it's time for reinnervation and a permanent solution.
Yeah, I totally agree with you. This was also my intention in this case. To your comment to lateralization. So please keep in mind the direction of the suture lateralization is because of the thyroid more anteriorly. So, and you still have anterior prolapse of the arytenoid. And so this will not perfectly help her in this case. So I would go for the first step with the Botox, beside the hoarseness could increase but for a certain time. But she has the impression what could be improved. And if she is willing to have more, then we would go for renovation. You could do both, but in this case, we have a so weak PCA with the non-selective end-to-end. You also compensate a little bit the PCA, which improves the arytenoid. So this would my intention. But I want to focus not on what we can have a surgery on. So are you missing some additional examinations in this case? So I would put her on a spirometry respiratory function test because she complains on respiratory distress. There was a comment. Yeah, in my eyes, it won't bring us new information. So keep in mind, a modern MRI has 500 to 500 pixels for all the neck. And then you have 200 pixels presenting you the larynx, what information you really get that. This is important to see tumors in the course of the nerves, something like that, or if you be aware that there's an external tumor growing in the larynx. But in this neurolaryngologic indications, I don't see a benefit from that. Yeah, Matthias.
Usually the LTA, so the closure is not so tight, right?
She has respiratory distress during exertion, not during phonation. So if we do that and she improved for their daily life, then we go to treat the LCA. If she complains more with the voice, we have a new decision. So next case, please.
Case 2.
All right, so yes, and in the interest here, I do not know the patient complaints here. I only have a video to look at. So I'm looking at a video here. I see the left vocal cord moving during inspiration and expiration. I see the right side twitching. I don't know yet, without looking at it, whether it's the twitch is direction appropriate. But that's what I will want to ask myself. I get up really close here. This is a great example of mass of TA muscle here versus mass. And mass is 3-dimensional, and there's not only the loss of mass and tension this way, which could be from this shifting forward, but you really want to get in and measure muscle bulk from here to here, and even on this overhead view, but if I got up really close, I would want to see the thickness of the TA muscle. So the TA is an easy one to see. And if I stop the video right here, and like the earlier video, I'm going to want to keep my eyes on this and see if when she takes this big breath in, what is that right vocal process doing? That's happening pretty fast, but that is what I want to know. What's going on with this angle here? So that's something I focus on. Bernoulli effect. So a lax TA, when she takes a big breath, I'm going to watch to see if this vocal cord draws inward, and it does. So that's a sign that the TA is weak on the right side. And when she breathes, I kind of am not seeing a lot of motion here one way or the other. So I zip ahead. Here's another view looking at, it's a good close-up view of looking at Bernoulli effect and what are the vocal processes doing. We get some phonation here. And what I want to capture during phonation is, especially the onset of phonation, if I can slow down my video here and watch the onset, and I follow my eye on the left vocal process here, here's the closure, it's coming in. It looks like that side is coming at least to the midline, and then it's probably going past the midline. And I don't know her symptoms, but if she tells me she can maintain her voice for 2 hours, and by 4 to 6 hours in the workday, her voice is gone, the explanation for that is likely that the overworked left side is fatiguing by the end of the day. And I looked at 1 or 2 more things. I think watching the right vocal process, it's slightly moving in the correct direction when she takes a breath in. So when I looked at it all, I didn't see dyskinesis. I think everything is weak. I think the TA is thin and weak. I think the LCA doesn't move much at all, but if it moves, it's moving in the right direction. And I thought the PCA doesn't move much, but if it's moving, it seems to be slightly opening. So I think there's a tiny bit of function on the right. Left is compensating.
What do you say about this anterior prolapse of the arytenoid? Is this in correlation to a certain muscle?
I could change my mind in the future, but in general, I think as you get a weaker and weaker PCA, the more this goes forward and the more the level, if you end up getting in here and looking at the level, the more it drops, the more the PCA is intact, the more you could have the lack of rotation and opening, but if it's upright, I think there's PCA function holding it there. So that's why I came to that conclusion that if there's anything, there's not much PCA fibers. I don't know the timeline, but this would be compatible with a fairly acute one or something that's not recovering. And if it's more than a year out, I would say it isn't going to recover. It just is kind of dead.
But these small twitches to the arytenoid could also be from the supraglottic muscles.
Yeah, I guess that, I mean, it's possible. I think it's the arytenoid, but yes, you're right. It could be. Yeah. I think one reason I think it's from the arytenoid is I think they match up. If I watch it for a while, I think there's motion on the right that's it is abduction when that abducts. And to me, that's the nerve.
This synchronicity would speak for you for the...
Yeah, that's why I think you want to watch everything twice. You want to watch this side, and then see if they're synchronous.
Okay.
Thank you. Good explanation. Sorry that we did not provide you the information
No, it was
the patient history. This increases the challenge to interpret what we say.
Yes, it does. Yes.
So we've just seen the video. Yeah, that's her TA EMG. On the overview, we hardly see much activity. At least there's not really action potentials. During phonation, the baseline gets a little rougher. And this could be from supraglottic muscles, or maybe there's the reinnervation just about starts. So maybe in 1 or 2 weeks later, one would see nascent motor units, or maybe not. And there's some fibrillations, so not very many. So assuming that this is not background noise, but reinnervation, one would guess that the paralysis is not very fresh. So, but all in all, there's not really any muscle activity in the TA. And PCA, during a sniff, there's inspiration, there's activity, and during phonation, it's more or less background noise only. Yeah, if very few muscle units, the pointy parts are the muscle units, and the more rough stuff is not muscle units, it's noise. Yeah. So if you look for muscle action potentials, they need to be really pointy so that you count them. So, and during inspiration, there is much reduced activity, but there is activity there. Small, and so much smaller than usual, but there is some activity. It's a weak PCA, and it's not synkinetic. So, and I haven't done the LCA in this case.
So we've seen another lady, she's 62 years old, and she suffered a surgery to her thyroids as well. And when she presented to our clinic just recently, it's been 7 months down the line due to the injury, and complained about hoarseness. And this time this lady complained about dyspnea during talking. And she had speech therapy, but did not improve very much. So as Gerd said already, the TA, there was very little innovation. The PCA has been less damaged. So after a permanent treatment has been 7 months down the line, and because of the EMG too, but she couldn't decide. So we postponed the final decision and did a hyaluronic acid augmentation. And finally, we'll see how this will go. She might up ending with a reinnervation or a voice implant. Anyone that would have done something different? Other suggestions?
This was a retrosternal goiter. So the query lesion site is further away than in normal thyroid surgery. So maybe that was the reason why there was no reinnervation after 7 months, or query beginning. Yeah. So with the longer distance. So, but after 7 months, such a poor reinnervation, so one could offer her a permanent treatment, but so we did an interim solution to give her more time to think about it.
If we look on the table, so there is no really disagreement. What you cannot see with the laryngoscopy is the prognosis. But we have no clear hints at the moment with the EMG also for the prognosis. That's why I can really understand the patient to postpone. Maybe she got a renovation, maybe not normal, but improving her complaints. So that's why I would say good decision to an augmentation and follow her. The other point is, and we have patients in this situation, you see from the EMG ongoing denervation. And if there are some more clinical information about bad prognosis beside EMG, and there is a strong effort, for instance, a patient who is dependent on the voice for profession or so, and you can decide at this point for a renovation, but in this point we do not decide for cutting the recurrent to leaving the chance for recovery, and we perform in this case an complementary nerve muscle pedicle renovation with the ansa cervicalis. This is possible, but it is not mandatory at this point. Questions? Comments?
Why was there no spontaneous activity? Why was there no pathological spontaneous activity? It's only 7 months. You would have expected some fibrillations or something. Did you not get it? There was?
Yeah. I don't know. That's what I saw. So I don't know for how many months nerve fibers can remain dormant. I don't know.
Surprises at 7 months, nothing to expect.
If there's severe, axonal lesion.
Of course, it could be that she's maybe starting to renovate and then she leaves spontaneous.
Yeah, so maybe maybe that is the sign why there is nascent renovation. So maybe renovation is just about to start. So the tips are gone, but we cannot really identify the muscle units yet.
Doreen, what do you think? Sign. Do you think it's a positive sign then if she doesn't show that much pathological spontaneous activity? Yes. So if you would have watched, so if you've been seeing this, sorry, if you've been seeing this EMG, would you rather recommend waiting as well? Would that be your conclusion? So, not sure. Okay.
Was horse afterson, not before.
Yeah, I'm looking forward after 3 months what we see visually.
Reports.
And if she is willing, it could also be interesting to have another ENG at a later time. Yeah, if it's possible. So let's go to the next case.
All right, so we will get out of that and go to this. All right, so we're on 3 now. So let's see, here's the video that I got. All right, so we've got a lot of motion on the right. We have that ulcer on the left arytenoid high up. Not much tension on the vocal cord on the left side. That's cricothyroid muscle helping to make up for it. So if someone comes in talking to me in falsetto, I know they're compensating. And I'm wanting to ask myself, what's the TA doing and what's the LCA doing? So here's phonation. I watch this more slowly. Here comes the right side past the midline, and then the right side strikes the arytenoid, and the left vocal process actually probably gets pushed laterally. So her voice gets worse the more power she puts on it. So I'm seeing the LCA is extremely weak on that side. And I don't really see any rotation inward during respiration.
Aha. Ganz sachte, nicht so doll. Genau. Nochmal.
And I can't say that I see functional movement, but here the arytenoid is shifted, tipped forward, maybe not as far as some of the other cases. And as I scan through it, there's even worse collapse the louder she gets. And I looked at this here, left vocal process, active lateral motion. So I watched I think I tried to watch. I don't know if I can show it. So here, when she sniffs, so between seeing that the left arytenoid is kind of upright and that when she does active inspiration, it opens slightly, I kind of came to this conclusion. There's not much in the TA, it's quite thin. There's not much in the LCA because it collapses laterally. And there's definitely some PCA function still there. So for one thing, this is incomplete, the injury. And unless I see a complete injury, I generally don't order any kinds of scanning of even the pathways of the nerve. If I've got a partial injury and a clinical story that fits, I don't usually examine that. So I think it is a partial injury, and I think there's some PCA function left.
If someone has different opinions, be free to say.
Ist meistens das Schlimme. So. The EMG of the healthy side. So where we have a dense interference pattern, you cannot see the baseline. So that's a good TA. And this is the TA of the paretic side. And there you have a strongly decreased interference pattern. And during the sniff, the activation is not more than normal. So this is also, sorry, that was wrong. So that was the activation of the healthy TA for sniff. So, and if you compare that with the phonation, it's a normal ratio, normal mild activation during a sniff. So the right TA all in all is normal. This is an example for a normal examination, sorry. So this now is the diseased muscle. And there you have no muscle units, but a lot of pathologic spontaneous activity. So much that you cannot really say or see the rhythmicity. You cannot be really sure which one is belonging to which, to draw lines between them. So it's much easier to hear this rhythmicity than to prove it on a chart. So a lot of pathologic spontaneous activity. This is also interesting. If you sometimes have your needle very near to or very close to the surface of the mucous membrane, the frequency of your signal matches the frequency of the microphone. So it's actually so-called microphone potentials, which are caused by the vibrating mucosa. So these are not action potentials. So in between, there were some polyphasic, prolonged, low voltage muscle units. So these are nascent motor units or regeneration potentials. So and during a sniff, not really activity. Yeah, so all in all, this is almost denervated TA muscle. So the CT, was normal in this person. And this is your PCA. So you have a single motor unit during respiration, quiet breathing, and also pathologic spontaneous activity. Yeah. And during phonation, there is the line gets a bit rough. So there's probably regeneration potentials there. And during a swallow, not much is happening. So we have a very weak PCA in this case, and query beginning pathologic reinnervation. Yeah.
So, and we do not perform the LCA in a regular base, so we don't have this information. We can only compare the TA and the PCA.
Yes, this is a patient we've seen a while ago in 2022. And she's another female patient, 51 years old, and suffered a Marfan syndrome. And during her history, she had to have very different surgery done over the last 25 years. And in November 2021, she had a bilateral replacement of the subclavian arteries. And during to this, she suffered a vagal nerve lesion on her left side. When she presented, of course, she complained about her hoarseness, as she could hear in the video already, and poor projection of her voice. She had shortness of breath during talking, as she had a very, very wide glottic space. And she had as well gastric paralysis with involuntary weight loss of 10 kilograms. So very slim but dynamic patient. She was still working in the sales department, so her main complaint was the hoarse voice, and she wanted to come back and go back to her work. So she came for really improvement of her voice. And when we saw her was May 2022, so 6 months down the line. And as we've seen, what we've just got presented, so very little activity in TA and PCA. We had query beginning synkinesis in the PCA, pathological synkinesis, and still ongoing spontaneous pathological activity. So we decided to re-innovate her, and we went for a nerve muscle particle technique. And as we're now 2022, we can say that we watched her closely, and she did very well, got back to work.
So this is an example that we had an early intervention 6 months after paralysis. So that's the reason why we didn't cut the recurrent to be sure. And with the particle, we had the result we wanted. Other opinions to this case or diagnostic options? No? Then we can go further.
Reach 108 decibels. So she had a good voice. Definitely afterwards she was happy. And we did an EMG afterwards as well, showing a good innovation during phonation and during quiet breathing, constant activity. And when you press the chin down, you can also see an increase in activity, proving that the ANSA has thrown in. Yeah, so maybe it's partly natural reinnervation, and it's definitely partly reinnervation from the ANSA cervicalis. So she was happy.
So we have to prove that what we have done has effect with this neurophysiological examination. And this is also in our publication, a discussion with the reviewers about yeah, this is not the result of your innovation. This is natural innovation. So, but anyway, if the course of the patient was going down with ongoing denervation, we never could repair the muscles. And if you do that, you hold the chance and you can improve that. And the result with the voice is very good. Go to the next.
Okay. So patient 4. Here's the video that I got. We're watching respiration. Right away, I can see that there's some fasciculations, which I think are mostly on the left side. There's a difference in mass between the vocal cords, and during expiration, the right vocal process comes to the midline and the left is not coming in much at all. But the left during inspiration opens all the way. So PCA already I can see is working really well. On this side, you get both abduction and that's staying upright. So the problem seems to be with TA and LCA on the left side. And we get some adduction, but most of the amount of rotation here is greater than the amount of rotation there. Let's see, zip along here and look at phonation. So we have a gap. We can tell there's a difference in tension because the looser vocal cord, the left one, is oscillating through a large range at this pitch, while the right one is not oscillating at all. So there's clearly a difference in tension. So the TA has to be weak on the left side. And of course, the hoarseness is from the gap. So when I looked through this, I would say the PCA is functioning nearly normally. Maybe I hedged my bets and said 80%, maybe it's 100%. And I thought the TA and the LCA are weak, and I saw no dyskinesis. I saw no activation of the LCA during inspiration. So I put this as an anterior branch injury that's milder than some of the other ones we've seen.
Hey, what have we got in EMG? So the left TA in the overview during phonation, there is single fiber activity. So indeed, this is a weak TA. And during inspiration, there is a single fiber, highly polyphasic. So what we learned, polyphasia is an early sign of intramuscular reorganization, so that the single remaining nerve fiber collects muscle fibers, neighboring muscle fibers to enlarge itself and compensates a bit of force, but so at least some axonal lesion should have happened. But all in all, there is not very much pathologic spontaneous activity there. Also here, there's very few fibrillations, so you can't really be sure. So not very much pathologic spontaneous activity and very little activity, so single fiber pattern. So it's indeed a very weak TA, yeah? No synkinesis yet. So, and the CT is not very good, but likely quite normal. So at least not a vagal lesion. And that's the PCA. During phonation, no activity. And during inspiration, there is a strongly decreased interference. After a swallow, the activation is somewhat denser. Yeah. So maybe the sniff was not hard enough, so it was not maximal activation. So one should always look at the strongest activation that can be produced to comment on the status of the muscle. So this is a mildly reduced interference pattern, which would mean that the PCA is only weakened a little, so which makes for an anterior branch lesion. Yeah.
Yeah, we saw initially this disagreement, but with your comment, it explains what you have seen on the forearm. The effort is important, which interference pattern you result in. That's why usually if it's possible and limbs and so you usually have a maximum activation or electrical stimulation of the muscle. So in our situation, we can only ask the patient to have the maximum effort. And as you showed, from the time before and after the swallow, it changed a lot.
Mm-hmm.
So this gentleman presented to our clinic after he's seen several doctors who didn't know what was going on with his voice. And when we saw him 2 months later, he said he had suffered a sudden hoarseness, so couldn't find any cause. So he had a staging CT and MRI scan, which did show any causes for this lesion and her hoarseness. So when we've seen her, as you've seen the EMG and the laryngostroboscopy, he has suffered a vocal fold paralysis or a recurrent laryngeal nerve lesion on the left side, which was sort of been a bit better already, presuming that when would have been first presenting would have been worse. He had very predominantly TA lesion, as you both stated too. And what we've done was doing an augmentation with hyaluronic acid, and he's done very well, could go back to work as an engineer. And when we watched him, he recovered 8 months later.
One question, can you remember in this patient that he felt after the renovation in a period where the voice was weak again, or was this ongoing renovation overlapped with the resorption of the hyaluronic acid? So, by the way, what is your experience? How long does hyaluronic acid augmentation last if it's a permanent paralysis? The effect of, yeah. 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 Thank you for this. This is also our impression. But if you look, but if you look in the literature, you see that some people tell you that it lasts for 12 or 15 months or more.
No.
So, and this is not true. No.
What's a bit odd again, that a low-grade, presumably low-grade nerve lesion, very little PSA, lasts for 8 months to recover. So very little pathologic spontaneous activity. So apparently formed
this point.
Yeah, but but the speed of the recovery depends on what the mechanism of the recovery is and how far the lesion is. So if the mechanism of if the recovery is mostly because of reinnervation of the originally damaged axons, then you have to basically wait until that axon, so we don't know where this lesion is. So although it's only part of the recurrent laryngeal nerve that is involved clinically and electrically, it's quite possible that the actual lesion is quite high up in the vagus nerve, because the nerves are already organized. Yeah, but it is an axonal lesion, right? So you have reinnervation signs of no pathological. Yeah, okay. But you've clearly got sort of reinnervation changes in some of the motor units that you showed, right?
So we saw this polyphasia as yes, there must have been a certain amount of axonal lesion because we had polyphasia. Yeah.
So when did we do the?
Just 1 or 2.
But the EMG was done when? 2 months.
8 months.
At 2 months, he was already better.
We don't really know. Maybe he was good at 6 months.
Yeah, he might have. Well, he had to probably be getting good by 4 months because you put hyaluronic acid in. It was fading.
We haven't seen her.
So recovery began earlier than 8 months, but it.
It'll be interesting to have post-recovery LEMG and see what happened.
Yeah, if the patients are happier, they don't come again. That's the problem.
So case 5.
All right, case 5. All right, here's what I got. Let's see here. Well, on the left side, we've got some of the area epiglottic fold. We've got some spontaneous fasciculations, but I don't know what that is, and that could be an injury, or that could be that left side is working so hard there's some muscle fatigue. And clearly the left side otherwise goes to the midline, opens completely. And when I watch inspiration on the right side, I think the two things are the right arytenoid is remaining upright, and when that is abducting, this is abducting. Not to the same range, but the timing is correct for the abduction. Now we have a pretty big gap. So, and when I watch the closure and I slow this down, the left vocal process comes to the midline, goes past the midline, keeps going, and I would say there's really been no adduction of the vocal process. Now, ideally, I would love to have the endoscope in under here to look at that vocal process. That would give me a little more information. And when I get up close like this, I can see that there's almost no muscle bulk here compared to this side. So there's the muscle bulk there, and we're starting to get the view. So there's really not much going on in the TA. And the closer you get, the easier you'll see that. Zipping along here. Let's see what else I picked out. There's a sniff. So it's happening pretty fast. I'm trying to see what might be going on the right side during the sniff. So I slow that down. This is patient number 5. So I wanted to look at that sniff really slowly. So I ran it through an AI program that slows the speed down, and here it is at 33%. And I can watch it with just the left side, but when I watch the right side, I think there is at least some motion laterally. So slowing the sniff down helped me to look at that. Go back to the regular motion. Oh, that's still the sniff. Anyways, I came up with, watching all of that, I thought the TA is pretty weak. I don't know if there's anything or there's a tiny bit of reinnervation. The LCA, there was the second video here. And is this second video? I don't know if this is the same time or if this is later.
Yes, same time.
I thought I saw on the right side this hint of adduction during a sniff. So I thought there must be some, like here, that's during a sniff. And I just see this hint of this rotation rate here. So very tiny. Watch it again. And the right vocal process in general is not collapsing far out laterally during phonation. Maybe a little bit because I'm not seeing it super close. I looked at one more thing here. So seeing that, that's why I came back to that. The LCA has some either synkinesis or slightly abnormal movement. So something, some PCA fibers must have grown in there. And the PCA still has plenty of PCA fibers and or reinnervation from the LCA because it's being held upright. So that was my overall feeling, that the main hoarseness was from the glottic gap. The TA has almost nothing in it, and the PCA still has something in it. So that's kind of my overview.
Thank you.
Okay. So this is TA. During inspiration, only noise, and during phonation, only noise. So a few fibrillations in there, but and some, so the insertion activity was a little prolonged. And during phonation, hardly any muscle action potentials. At some points I had the impression, I can't even really show that, so that some of these patterns were slightly repetitive. So this might have been query early reinnervation potentials. This is always a little more a feeling than something to prove. But no activity at all. So the TA is still has no activity. The PCA, alike, nothing.
Nothing.
Yeah, nothing but background. But also not very much fibrillation. So either one would say the paralysis had lasted longer, or again, it's not so much external lesions.
So then how would you explain it? Remaining upright, the joints fixed, or would you explain, and would you explain the motion? In other words, are there things like your needle wasn't in the right belly of the PCA, or wasn't
Yeah, that's what we discussed. You never, so the PCA also has different bellies, yeah. So and different the recurrent laryngeal nerve issues several nerve branches to the PCA. So maybe I hit a region of the PCA which is dead, but we clearly saw some abductive motion. So maybe sampling the PCA in one position was not enough in this case. Yeah. So, but also our general impression is that in cases where both muscles are very weak, TA and PCA, then you see less prolapse.
Less of the, because you were saying TA pulls it.
Because then compared to nerve lesions where the TA is in good shape and PCA is gone, then we have rather the impression if you have a very strong prolapse, often the TA is a little better and pulls in the
I think that's plausible.
Arytenoid, yeah. Especially when the CT kicks in as well. Yeah.
So in this case, this is the first out of 5 where we have a discrepancy in the interpretation. So that's why you have this discussion. So we have some explanations. The question is to Matthias, in this case, maybe could you solve this discrepancy between we saw a normal upright arytenoid individual and think there is not so strong lesion of the PCA, and the EMG we have a strong lesion. If we had the possibility to electrical stimulate that and we don't see any opening, is this a result or what do we think? Hey.
So this is an information
we did.
have now.
Yeah. Okay. Yeah.
We can do with the ECG, if we manage to look at the hotspot, because this is actually the problem about. If we can find something contact, then I have an idea what to look for. And again, this is other muscle contractions. Then I would guess that we have some fibers. And if we position, if we get an opening, then
yeah. Okay, but for that we need an examination during this is only one examination.
And we see the video once again.
The video.
How you want to evaluate not the vocalist processors, but we also look at the processors muscularis, the other one. Because we have think that there is another activity.
Yes, that's what he said. Yeah. So maybe if I had hit a different spot in the PCA, we might have seen a different EMG. During phonation.
Okay, during phonation.
What?
Yeah.
You need this.
How do you interpret this?
Yeah, I interpret it as the belly tightening. That's I think you're looking at the belly of the PCA back here. Yeah. I mean, it could, I agree. I think of it as belly because I think I do see people collapse in here at times. But yeah, it's like, yeah.
So at least we couldn't prove it. Yeah. Because unfortunately.
Yeah, I think, you know, in EMG, the absence of a finding, it always has two interpretations. You're not in the right spot or there's nothing there. Yeah, and you get around that by maybe changing where the needle is, changing your equipment, or doing it at another time. Yeah, I guess you could do it.
If I had looked at the video more closely before
Before.
the EMG, I wouldn't have believed my EMG result. I would have repeated the PCA EMG, and maybe we would have revised our result.
Yeah, I mean, I think they're complementary exams. Yeah.
We don't know. Yeah.
Okay.
But that's the query question here.
Let's present the clinical.
Well, we don't know if that would have changed anything in our decision. So that's just a query here. So this has been another female, 47 years old. So she suffered that walk of fault paralysis on her right side after another surgery. That was a spine surgery this time, and presented with hoarseness of voice and some lump feeling, and didn't got better with her voice after speech therapy. We couldn't see any relevant reinnervation in the EMG we've done. And as it's been 8 months down the line, we decided to offer her reinnervation, which we've done as in a non-selective matter with answer cervicalis and the end-to-end technique, together with augmentation with hyaluronic acid in the same operating procedure.
Of the PCA, if there was no reinnervation in TA and or elsewhere. So it was after 8 months, more or less denervated larynx in our measurement. So we went.
Maybe it developed much later. We have very often twitching of the symptom over months. 8 months is not sufficient to say it stops here.
Well, we didn't see any synkinesis, yeah, yet. But if there was a query type 4, why was there a type 0 in the TA? So that doesn't also make sense that it would have a strong reinnervation in the PCA, but no reinnervation in the TA. Could be some unusual.
But sometimes we often have such a case, what we have tested in the EC50 went cross innervation from the other side.
Maybe.
And the answer, because every muscle cries for nerve innervation.
But that this activity is maybe that was from
It could be from the collateral.
It's a fair explanation. Yeah. I would guess I would want to keep seeing it over time in other people, but yeah, it's plausible. That's.
But if you say it was a good decision, give her the crying muscles and nerves. So,
so we're waiting with yeah. Okay, our last and final case.
All right, number 6. Here's what I got.
Tief Luft holen lassen.
So left side opens completely, probably goes past the midline, and the left side has a super bulky TA muscle. So maybe it's even been going on a while, or the person loves to talk, but big TA muscle. And we have maybe a tiny bit of tension there. Watching the right side, like here's at low pitch, and the right muscle is not, it's not collapsing outward. So I'm starting to think there's at least some tension in the right TA. It's quite weak, but there's something there.
So you look at it, especially on low pitch. Yeah.
Well, I think one of the things is everything should be dynamic. You should do low and high pitch because you're trying to separate out CT compensation. You should do soft and loud. So if you do one pitch, say a low pitch, and you have not much pressure, you can get a sound. And if you go loud, and then it flutters, now you know it's weaker. If they can be the same tension at soft volume and loud volume, then you know you have tension there. So I think your exam has to be dynamic. Or you get more information from a dynamic exam. And then I watch inspiration. I think it's harder to deduce what's going on from here than it is if you're looking at the vocal process. So you can make something out here. There's some muscle fibers there. There's some twitching. And with the sniff, there's some PCA function on that side. How much, I don't know. Following through, let's look at. Now you're getting a double pitch, so clearly there's a difference in tension between the two sides. Your strobe can't lock in. That's why you get the fluttering. Now, as you go louder and you hear that, then it is weak because it's fluttering when they're putting extra air through there. So increased subglottic pressure, it flutters.
Und Tief schafft er eigentlich zusammenbringen.
So I looked through all that. I came out with the conclusion that I couldn't see any LCA movement, but I never got a great look at the vocal process, but I never really saw adduction at the onset of phonation. TA is weak. Maybe there's a little something there because he could hold a low pitch. And as you go lower, you take off the CT compensation. So you're depending entirely on the muscle. So I thought there was something in the TA and maybe a little bit in the PCA because I did see the slight opening during sniffing.
So this is what we saw in EMG. And in fact, so he could not relax very well. So, but we saw a strong activation during phonation. So there's hardly any baseline visible there. So this is almost a dense interference pattern during phonation. And so one would call that synkinetic, but since this is not really maneuver specific, but it's more, it runs through this activity. That's why I would be cautious to call that synkinesia. So maybe it's just that the patient could not relax, so that he was tensed up, and so the activity runs through, and is a bit more activity during phonation, but this inspiratory activity is a bit difficult to judge. There's no baseline, so we cannot really judge on pathologic spontaneous activity, but with this amount of activation during phonation, there is not much room for any axonal lesion there. So, and the PCA, nothing. Pathologic spontaneous activity, so which means the lesion can't be that old, yeah? And no whatsoever activation during respiration, during sniff. So if we discuss the discrepancy there, I told you we often see that these strong prolapse in the cases where the TA is not weak but rather strong. So, and maybe this, if the arytenoid is pulled in and the vocal muscle is shortened so much that it becomes functionally insufficient because it cannot tighten anymore. Yeah, it is. Maybe that's what makes this muscle in your case appear weak.
Yeah.
Although it's not.
Yeah, and then I would want that. I mean, to make a good statement, I would want to get in and get a super close view of it. So a little bit of a handicap to make a statement about it. I'd be willing to say that I'm wrong, partly because I'd want to sort of
not the best video for you
a little bit closer.
But on the other hand, it surprised me what you said on low pitch, that you could make out some tension there.
Yeah, I think
so. This is something I will pay attention to next time.
Yeah. So I don't disagree.
Just a good discussion. Could be both. The TH2 could be big, or the PCA doesn't stabilize vocal folds.
Yeah,
but I have some doubts because there was also this was not a straight line of the vocal fold, and I would assume that the T muscle moves the T should be this in a line. So,
we don't know. It's quite a nerd talk anyway.
Yeah.
To cut it short, because you already probably referred, this is a male patient, and he had spinal surgery done as well and suffered a vocal fold paralysis on the left side and the right side, as you've seen, and came to us because of hoarseness and couldn't have any improvement for speech therapy. So we had in our EMG and in our mind, he had a almost normal TA, although he couldn't relax as we couldn't really judge about spontaneous, pathological spontaneous activity. And we had almost no activation on the PCA. And when we see him was 7 months later after the injury. So we decided to operate on him and offered him a re-innovation. And he's just in progress, so we don't know finally what he's doing.
I have one question for you. We talked about when you put a needle, I have it in my mind. When you put a needle in and you get nothing, you don't know if there's nothing or you've missed it. Now, you showed us that you got activity continuously during inspiration and during phonation. It was really not much different. Yeah. Is there any other way that an EMG can be wrong? Do you question your EMG?
Synesthesia, yeah.
It could be, it could be synesthesia. But also, do you ever say, is my needle in the wrong place? Am I picking up something else?
Well, we always question that.
Yeah.
Once you got no signal, you always think, oh,
well, no signal, yes. Right. But I'm saying when you have a continuous signal, do you question that, or is that?
You saw a clear difference during phonation.
Some different, yeah.
So, but we did not see that this maneuver inspiration was separating itself during the whole course. Yeah, and that's sometimes a bit difficult. Yeah. So if there if there were synkinesis, clear synkinesis, you would get an increase in activity during phonation, okay? Yep. And you would also get an increase of activity during inspiration, then you know maneuver-related activities. But if there is no relaxation between that's the part that so that makes us feel that it's a component of tension on the patient.
Okay.
Or a component of the most of the reanimation after fighting surgery, PCA was still there. And why we went end to end was mainly because if we would use medical to reanimate, we would even further strengthen
the TA, but
TA. That's why maybe
Maybe next year we could tell you whether it was a good decision. Maybe in the case we thyroplasty reduce the good hypertension.
Yeah, okay, that's another way to think of it. Yeah. All right. Well, I'll look forward to that one. Yeah.
Yeah. Thank you all, Kathleen, Gerhard, James, for all the effort to prepare these cases and the nice discussion. Yeah. That you don't get the wrong impression. So we do not treat every patient with renovation. So we have quite a number, but these are clear hard indications. So we do that. This is a selection bias because we need for this course cases where we have good laryngoscopy and good EMG to explain you all these details. And we had the same amount of patients with thyroplastic with same good results. And the majority of the patients we treat with augmentation and follow-up and do not do permanent therapy so that you don't go home and think in Gera every patient is running for renovation. So sorry for that. So, but we are good in time. I would like to have a final discussion between Matthias, Gerhard, and you. And what I would like to discuss with you is if our delegates went home and look for the next case. So what would be your take-home messages? So if you perform a laryngoscopy, which maneuvers you should include, what should you record, on which parts of the larynx you should have a special look on. I know you have published on your website so 8 points, and I really like these ideas, because we didn't mention that. Maybe you can add this. And after that, I would like to ask Gerhard and Matthias, so for hard indications, so if you look at this, the majority of the answers are still there after laryngoscopy, in which indications we have additional decision-making usable informations from the other examinations. So, but
well, I think one thing would be is if I were in a clinic next door, I would be probably running everyone through EMG because I get something out of comparing visual to EMG. It's great to rethink things, and then maybe things alter the next time. I think from a laryngoscopy standpoint, the thing that the whole world could do to improve their exams is to get closer to the larynx, number one. Number two, use lidocaine. You can get closer with it, but the more comfortable you make your patient, the longer the time you have to observe. And then I think if you're going to do...
sorry if I interrupt you.
Yeah, go.
In which part of the examination you put on the lidocaine, because it changed the saliva control and you have also some drawbacks. So do you start with lidocaine, or do you perform initially examination and go further with the lidocaine?
Well, I mean, I had the opportunity to be in your clinic, and I think one of the things is as soon as I'm done talking to the patient and look at the nose, I put my lidocaine and decongestant in the nose, and then I have a few more 5 minutes that I'm still either talking or setting up, because when the patient is comfortable, even if you're not anesthetizing the larynx, when the patient's comfortable going in, they are more relaxed. And when they tighten or pull back, your airway gets, your visual space becomes narrow. So getting the patient, I also heard the verbal anesthesia thing, but you're making them calm, get their nose decongested, get your lidocaine to run a little bit in the back of the nose so they feel nothing when you go in, and then that starts to get a good exam. I think initially I used lidocaine more than I do now, partly because I know what I'm looking for, And I can also dip in and get extremely close to the larynx without touching anything. And that takes, I think that comes with time. It comes with positioning of the patient, way forward, they're relaxed, and you get in, and I can get closer views than these in almost all cases, and I think that's your goal. But when you're not as good, then you want to put the lidocaine on the larynx, and you have lots of choices. Injection, it's quick, easy. Even if the person's gaggy, they're going to get anesthetized. And if they have a problem that you haven't seen and you want to see it, transtracheal is great. I frequently use through an Abraham cannula. It's cheap, and I have 4% lidocaine, and I drip it, and I probably take 5 minutes to anesthetize. I drip a cc, I squirt a cc in, patient coughs, I wait, I'm chatting with them, and I'm using up my time, and then I put another cc in, and then I have them phonate E while I'm putting it in, and I get it to the point where they're going E, and they can gargle. That's how dense I make the anesthesia. Whenever there's this kind of neurologic problem, and I want to see up close.
I think the alcohol in our
You can't,
is also
10% lidocaine has alcohol in it, and you don't, I would sooner use 2% if I don't have 4% than to use the 10% with the alcohol. In fact, you should just put it in your own throat, and then you won't use it again, because you know how much it stings.
Yes, I like this discussion. So we used to, of course, we talk to the patient because we need to learn his really complaints.
Yeah.
And we learn to hear his noise, his voice, and then you give the advice with the decongestion, the local anesthetic. So, and your take-home message is to go near. We learned that we can see the LCA much better if you come behind the arrhythmia. Yeah.
Yeah.
And what I learned from your talk today is you look more than me on the opposite side.
Yeah.
And this gives interesting additional information. Maybe you can add this.
I think you also want to record, you want to sit there and record respiration for a while, and then you want to record phonation. And then you want to record low-pitch phonation, and then you want to do high-pitch phonation. I think that my average exam of recording comes close to 4 minutes of video recording. Maybe it's 3 now, but it takes me about 4 minutes to cover everything I want to cover in this exam. And I put this back on because if you can see the tip of the epiglottis, you're not close enough to see what you need to see in neurolaryngology. Your scope has to be down close to the level of the petiole. And then I think that's when you, so that could be an aspiration. See if you can get your endoscope in past the arytenoids.
And then you look on compensation. So you wrote that if a patient lost function, he compensate, and you want to see what is behind.
Yeah, I think this is for all voice things. A patient comes to you with hoarseness, and the last thing they want to do in front of you is sound hoarse because they think you're going to judge them that they have a bad voice. But in fact, you have to make you want your exam to be during the worst phonation possible. But they're always going to compensate with supraglottic squeeze. You have to get rid of it. You can get rid of it with lidocaine. They compensate by going up in pitch. Cricothyroid works. You have to look at low pitch. They compensate with one side crossing over, and I was going to show a quick view of this, that when someone crosses over, when you, I thought it was, you can think, this is something different, you can think it's completely closed here and that these look normal, and when you get inside, you find that they're not. So, you want to get in, this was the talk I was giving earlier, and the next video was, if you only look at this part from here forward, if you're above the arytenoid, you can think that they closed completely. And like if your view stops there, you would say both vocal processes are reaching each other. And it's only when you get to that posterior aspect that you can see that this vocal process has pushed over and this one is angled out. So especially, I think, in fact, one of the things, one reason you should do this is because when you start to find the LCA paresis, you find so many more people you can treat. And that means you get to do more, which is kind of fun. And it means that more people are happy with your care. So it's a win-win for the patient and for you if you can look and see when the LCA is weak.
This is what I learned from this. It is not so easy to reach the LCA for EMG and to interpret it. And I really like this index finger. If you can really see that in the video, you see what's happened with the LCA.
I'm not saying I get 100%, but I get a lot more views back there than other people. So.
Okay. What about rigid laryngoscopy? Is this necessary for neurolaryngologic examination?
Well, I personally reserve rigid for two things. The main one is because you're always looking down from above, most of us. Some of us can get quite close with a 70 scope, but that's pretty rare. You're generally looking from above, so it's great for edge lesions. So anytime a singer comes in and I hear a squeak or a catch, I know there's an edge lesion, I go straight to rigid. So I do rigid because it's the clearest view, the highest resolution, and it looks at the margin of the vocal cords the best. And for everyone else, they get flexible. And if it's neurologic, then I really like flexible because on a rigid, I gave you the one example that someone sent me, but in general, you're going to miss the vocal processes unless you get in under the arytenoids. So I love flexible for everyone, but especially for neurologic.
Then if we look on additional examinations, so we have quite a variety of equipments. You can use troposcopy, you could use NBI, high speed. For this movement disorders, for neurolaryngological cases, do you see a benefit? Do you add this?
I think high speed is for academic interest. I don't see the point of it. You could see things more precisely, but it takes up so much of your life to look at it that for me, it's not worth doing. You can get the information from this. I think if I had the ideal setup, it would be to have my office adjacent to someone who does an EMG, because I think these are two really complementary studies. But
so thanks for the statements, and I think all of us take something home for the next examination. James, in which situations, if you had in the office near to you an EMG guy, which patients you would send to him?
Well, I would start out doing it in everybody who has a nerve condition, because I think even coming here, I've learned things potentially, maybe my interpretations are speculation. They're based on a thinking process, not on absolute data. And I think the two exams, if I were a neurolaryngologist and either I did them myself or I was adjacent to somebody, I think doing both exams is going to move the next generation along to say, like it would be great, the exam where you got the TA, the last one, and we don't know why, and I'm asking why. So then I would re-examine that person, and I would maybe have you re-examine it. Maybe we would come to a different conclusion.
And we have 4 cases where both examinations came to the same result. This is also a validation.
Yeah, you could pick one or the other that you're good at.
If you have 2 examinations and they are comparable in result. And now I would like to switch over, which are indications where only the EMG brings us informations for decision making. You mentioned that during your presentation.
I mean, mild or starting reinnervation processes are probably hard for you to pick up.
I don't think I would
because you only can see processes that are strong enough to cause some movement. So in some cases, we saw beginning reinnervation, which made us wait a little. Yeah.
So where I would wait on everyone, because I can't tell that, you could move ahead, I think, with EMG at times. Yeah.
Yeah, I think on timing of irreversible procedures, I think the EMG, what we learned today, can really help us. So please remember which signs we should look on and which signs help us for decision when we perform a permanent therapy.
Das meins, das ist so passen.
Yeah, not only the reinnervation, we learned signs that there is no chance for remobilization. So we learned that synkinesis is a sign. If you see that, you cannot wait on a reinnervation or remobilization. So this is a clear, and you can only see that clear in the EMG. You can have signs in the laryngoscopy, but you have clear information in the EMG. And sometimes there is also a medical legal discussion. Is there a nerve lesion or not? So in these cases, we need the proof. If the patient is not happy with his surgeon, and so in this case, it's really helpful to have an EMG to say what's happened with the nerve. So then we learned about the spontaneous activity, which is also a clear sign of a nerval lesion, and the distinction between fixation by a tumor or by ankylosis, also to distinguish between a neurogenic lesion or a mechanical lesion. So do you have more than me?
We haven't shown an EMG example of a tumorous nerve lesion. Often these tumorous nerve lesions, they look incoherent in a way that you see denervation and reinnervation processes taking place at the same time, which is usually a sign that the tumor has progressed slowly into the nerve, and then the nerves have grown around, but the damage continues. So they sometimes look a bit different. We haven't shown you an example.
And we missed one disease, what is increasing in the number over the last years after the COVID-19 pandemic. So we hadn't shown you an example of posterior glottic stenosis. So I would say this is also a clear indication for using local anesthetics and to have a close-up laryngoscopy, because I have seen a lot of laryngoscopic examinations with posterior glottic stenosis where the patient were sent for bilateral vocal fold paralysis and you don't see the scar. So from the academic point of view, it's clear if you have a normal EMG on both sides, but you can also clear that with a close-up laryngoscopy. Do you have an example?
Well, I had the example. I had a patient who, which I can't find quickly enough, but yeah, a patient who had been to the ER, had been to the pulmonologist, had been to the gastroenterologist, because everybody in the US treats everything with reflux, no matter the problem. Had been to a laryngologist, had been to a neurolaryngologist, and all I did was put lidocaine on and went subglottic and saw the band. And why do you need 6 months of life and 6 consultants and all the testing when all you had to do was put 2 euros of lidocaine on or whatever and go look? So yeah, it's really important to, especially bilateral, if you can't see below them, you need to get below the cords.
Sorry, Matthias, I have to interrupt you. Now it's your task. So what additional, so you said it before, but you can state it again. What are the hard indications to add EC50 examination on after laryngoscopy and maybe after EMG?
What I liked a lot today is visual laryngoscopy, just put it beside. I think it's a very intriguing way to see it. From my personal experience, it is not always easy. It's very difficult to see those fine differences. And I often don't think that I'm right. This is the range of EMG in our department. This is kind of the working force. And what we like a lot is that we have more examinations following, so the patients come back and they have the course of time. So also one very big thing that I like about it is that we have mostly more than one examiner. So one examiner doesn't have a very distinct clear signal, and you can always switch and another one tries and you see if you can match them. So this is also something that gives us additional value. And from the ECE cap, you can clearly use it in all the cases where you have distinguished between neurogenic and mechanical cause, for example, but cannot perform the laryngeal EMG for it because the patient doesn't tolerate it. And the other thing is, of course, if you have if you're looking towards spacing, for example, then and you need to know if the whole chain is working from viable nerve or not, then you can have an interesting way. It's simple. I mean, you don't have to interpret a lot. Right away, you can see if you have any viable fibers in the BCA. Of course, if you have additional the LEMG to it, then you have kind of an additional tool that you can match all of these together, and then you have more accuracy in the diagnosis. And so my recommendation would be it's a novel tool, so buy it, try it, get experience with it, and we will see what kind of perspectives will open up with it.
I would like to add two indications also, if you agree with that. So, for instance, I see sometimes patients they go for selective renovation, so they are candidates. So, especially children where laryngeal pacing is no option in the next future. So, in my opinion, it's quite also a mandatory examination before you perform a selective renovation to show with this electrical stimulation that the joints are mobile and that there is enough muscle bulk left that could result in any kind of abduction. Otherwise, you have a huge surgery and a lot of nerve anastomosis that should be established. And if they reach the muscle, they cannot effort anything. So I think also for pacing and selective renovation. And for all the hospitals, they do caudal enlargement surgery. You have an examination in general anesthesia. Why you don't take the cap before and look on, is there a resting abduction on one side? You can better decide which side you bring for the laser in a permanent disruption. Yeah. So this points, the caudal enlargement side and the selective renovation are additional points in my eyes where you could place it. Yeah. And maybe we have a lot of young people here inside, they will find other options. So this is a tool you can have in your hands right now. And it is good to establish that in a clinic. We do a lot of larynx surgeries, neurolaryngologic diagnostics. So in my eyes, it should be added to the to our diagnostic tools. Yeah. So thank you for staying in time. We have 10 minutes left. Are there questions, comments?
Lipothyroid muscle.
Sorry, again?
The recommendations for, sorry for my bite, recommendations for the examination of cryptothyroid mass.
Yeah, you have seen that in the distinction between vagal lesion in idiopathic and recurrent lesions. So the time course is different. And you can also, if you have patients with complaint of pitch, and so you can really examine the reason for that. You see that in laryngoscopy, but you see it, the severity of the lesion more in the CT EMG. But to be honest, to learn the CT EMG is more challenging than the TA EMG.
I was going to show.
We do it in most cases, yeah, because if you are a surgical lesion, often there's CT involvement when, say, on the thyroid, when they superior vessels, they often catch the accident, really don't see so usually do it. No.
And also during thyroid surgery, this muscle is, or the nerve branch is more often damaged than you think.
Yeah, I think if you want to identify it endoscopically, you're going to want to do your strobe at a low pitch and a high pitch. And if you have both functioning TA muscles, they'll be symmetric. And when you get to the high pitch, if both TAs are normal and both CTs are normal, you'll stay in phase the whole way up. Now, if you have one of the CT muscles weak, they'll be in phase here, and as you go up in pitch, the looser side will start to oscillate out of phase. So you can look at high and low pitch and during stroboscopy, and you can imply there's a problem. I think equally or both, you could do the CT muscle would be, excellent, or together they would add certainty. I think one of the things I do is go and try to talk to thyroid surgeons. I don't know if you guys know any thyroid surgeons. I go to the big meetings and they say they injure the superior nerve less than 0.05% of the time. And I can tell you that I get this lesion a lot. So
in EMG is 50%.
Yeah, I really like this discussion. So, but it is time. Well, we missed the lunch, so it's time to have a good dinner tonight. Yeah. Mm-hmm. And maybe Fabian can explain you the way to our dinner tonight.
Slide. It's not necessary because all of you have a cell phone. Most likely.
Thank you to the speakers.
Perhaps we do it from your laptop.
Oh, okay.
Possible?
Yeah, you want here, put it in over here. I think there's more room. Allow to connect. Is it, let's see here.
So dinner tonight will be in the restaurant Zur Noll. New state. Schreiben Zur Noll. That's it. This one. Yep.
Oh, we have to show it. It's yeah.
So at the moment we are up here, and you can walk to here. It's 20 minutes. If you are on Google, so that's for slow Americans without bikes. So I think he will do it in 3 minutes. We can do it in 15 minutes. But you can also take a tram. There's a tram line going here and stopping here. And then you can do a short walk. But yeah, just use Google Maps for Zur Noll. It's also there. And here in the middle, there's this big tower. This is the only big tower in town. So if you walk towards the tower, then you're nearly there, next to the marketplace. But there are some people walking. I think Matthias wants to walk, so you can also join him. And there should be food, hopefully, in half an hour. Thanks for your time. Thanks for the online participants. Is that the entrance? Here. And that's where we meet tomorrow. Shall we meet? Shall we first split up? Okay. So yeah. So we have a little bit time tomorrow, so we can meet at 8 o'clock up here and then split up into the groups, and then we show you where to change glosses to get green stuff. And yeah. Good. Thanks for your time.
Keep your badges on you for tomorrow.
Yeah, we need some more tomorrow than today. From Mike.
Yeah, you can have that.
Yep.
Hey.